అట్లా తెచ్చుకోలేదండి అంతా. లేదండి. తెచ్చుకోలేదు.
To this special occasion at Asram Medical College and Hospitals. Today, we are gathered here for the Caho Jeevan program, a meaningful initiative focused on quality healthcare, patient safety, and continuous improvement in hospital standards. It gives me immense pleasure to welcoming you all to the Ashram family for this prestigious Caho Jeevan Conference 2026. Welcome you, ma'am. He's Mr. Kantikiran, Manager Operations.
He's Monica, Assistant Manager, Organizational Development.
We are hosting for this time. Let us begin our first powerful session of today's title, the Tagore Program. Healthcare is not just science, it is ethics, it is accountability, it is doing what is right even when no one is watching. And the Tagore Protocol, doing what's right, ethics, legal awareness, and accountability in patient care. To check this session, we invite
It is a proud privilege to be the group from the Chief Professor, Medical Superintendent of Asram Medical College in Healthcare. Under the esteemed ASRE Society, with decades of dedication to bringing education and hospital system, he has played a vital role in strengthening clinical excellence and patient care services. His leadership has significant and contributed to enable growth quality healthcare delivery and institutional development. Please join me in welcoming him to share his valuable thoughts at this conference. Come on, so stand in.
Okay. It's my privilege to introduce Chandrasekhar Bhagat, sir, Managing Director of Downstream Healthcare Private Limited, a scientific leader in healthcare management. He is known for his strategic vision and commitment to excellence in healthcare. Through his guiding principles of case, assist, plan, and execution. He has consistently driven innovation and operational success. His experience in healthcare administration and quality systems makes him a valuable contributor to today's discussion. Please join me in warmly welcoming him to this conference.
It is my pleasure to introduce Professor Dr. President and CEO of Medas Admitted Group of University Colleges, Hospitals, Schools, Students, Gujarat. A visionary leader and educationist, he has been instrumental in advancing academic excellence and institutional progress. With extensive experience in higher education and healthcare administration, he brings a dynamic and transformative approach to the his commitment to quality education and holistic development continue to inspire students, faculty, and professionals alike. It is my pleasure to invite Dr. Bob as the distinguished healthcare professional and hospital administrator with extensive experience in quality management and hospital operations. He currently serves as a chief operating officer at Dr. Guru Multi-Specialty Hospital Center. The MSP organization, Dr. Murugan is known for his leadership and industry patient care standards and implementing quality healthcare practices. His expertise in hospital administration and education makes him a valued voice in healthcare education.
Professor Dr. Amit Shilimundagadhi.
Good morning, all of you. How many of us are happy today? Can I see your hands? I'm sure each of us are thrilled and happy to move onward with the program of Jeevan. I would like to bring greetings to each one of you from Caho. Caho is a consortium of all accredited hospitals across the country and also at the international level. I'm so thankful to Sir Rajarajan who has given me this chance to address this August gathering. I now would like to present something which is of very familiar connotation for each one of us. One of the movies that each of us have seen is the movie Caho. How many of us have seen this movie? Can I see your hand? Many of us have, and rather almost 80% of us have seen this movie. Can someone tell us what did you find unique or what is the concept of the movie? Same time, quickly. I have a remote to the slide. Okay. So what's the concept? Why did anyone volunteer? What's the concept? The whole movie's concept is what? Yes. Were there ethical practices or unethical practices? So they have they have a lot of unethical practices, and there you find one arbiter, one person who excelled in making sure he brings change. Am I right? So the farmer is a person who was exemplified to be a person who's going to bring change to what was happening in that particular place. So therefore, we have taken this title, and I would like to thank again Brother Rajan for giving me this wonderful topic on the Tagore Protocol. Doing what's right. Do we always do things right? In the medical profession, each of us, we try to do something right. But in the process of doing things right, we will falter, we will move on either side, and then we try to stumble and fall. But again, we rise, and again, we keep walking. And that's a part of anybody's life. But when we look at a medical profession where you're practicing on a living subject, on a living patient, you'll find that the errors or the way you falter and where you stumble needs to be always looked at. And then not only looking at, but the law is looking at it in a magnified manner. The law is looking at it in a manner where you and I are at the verge of scrutiny. So when we think of doing things right, there are so many things that come into our mind because you're all in the medical professions. The first thing that we talk about is ethics. A wonderful subject that can be taught the whole day. Then you have the legal awareness. When you go on a traffic, you're going on a bike, you come across a traffic police, and then you are not wearing a helmet, he charges you some fine, and then when you stay with the traffic police and say, sir, you haven't caught that man who was wearing the helmet, but you caught me, and you're fining me. And then what does he say? You are not aware of the legality. What about your own self? You are a person who has violated the law, and then you have actually no right to talk about the others. Correct yourself and correct the others. So basically, when you get that is called as legal awareness and accountability. You are accountable for what you are doing. You are responsible for what you are doing. So when therefore there is not to cover in this. Okay, what is this that we are trying to do today? System protect the ethical doctor. Every single doctor is a doctor who is supposed to be ethical. And each of us seated here are all ethical in our own work. But our ethics leading us to a better patient care? Or ethics leading us to the patient safety? Are we protecting the rights of the patients? Are we protecting the rights of the relatives who are coming into the hospital? Many things that we need to think and ponder. If you look at the Concord Protocol, you'll find in the movie there was a systemic corruption. What was lying there? There was systemic corruption. There was accountability failure. The government did not own what they were doing. The departments did not own what they were doing. There was no accountability, no responsibility. There was a moral uprising against injustice. People have come on the streets to fight what was not right. And how do we think about the same thing in healthcare? There are ethical shortcuts today. We find there is more documentation in our medical records. We also have a medical legal vulnerability. Why are we vulnerable? Because we are weak. We are vulnerable because we are not having the right access to what we are supposed to be exemplifying and doing in our own selves. There is a trust deficit among the patients, among the government officials, among the healthcare providers. Because of the competition, we start exposing our own vulnerabilities to others. And in short, we completely bring the healthcare industry in the poor light. So there is a trust deficit for the patients. Let's talk about the patient who is the consumer here. What's the message that I would like to bring to each one of you with this Caho protocol? The first thing, right action, right documentation, and right process. What are the three things? Can you please repeat for me? Right action. The second thing. What is the right? What documentation? How many nurses are here? Documentation, the most important thing, right? 2-hourly charting, 3-hourly charting, 4-hourly charting, whatever charting you're doing, and patient in the ICU, what kind of charting do we do? We talk about charting mostly, right? And the doctors who are there are also, how many of us are doctors here? There are quite a few of doctors in this place. So, how do we exemplify ourselves when we start looking at documentation? The right process. What is the process that you are employing to ensure that you are not in a problem because you are trying to have good documentation, ethical shortcuts, medical legal vulnerability is there, and trust deficit is there. If you want to correct this malady, which is here in the healthcare presently, you need to follow the Tagore protocol. And to achieve what? What are my objectives? The first objective is right action, right documentation, and right process. Okay, let's move a little more further. 70% of the hospitals in India are small healthcare organizations. If you look at the rural area, if you look at the B class cities, if you look at even the A class cities where you have huge big corporates, you'll still find there are small healthcare organizations. And we always talk about those big hospitals. We always talk about those corporates. But we rarely seldom think about those small healthcare organizations which are contributing to 80% of the healthcare work that is happening. So what do we find here? There are limited legal teams for them. Very few people. Documentation is inconsistent. How many of us have got SOPs for documentation? I'm sure we need to introspect ourselves. MLC confusion. What do we do when a patient comes into the emergency? Do we do an MLC? Do we do a non-MLC? Do we take consent for non-MLC? And when you take consent for non-MLC, the medical director comes and says, you have done something wrong. So where's the criteria? Where's the SOP made for such kind of an MLC country that we have? Consent quality gaps. These are some of the problems that we have. Consents. What's a consent? Can somebody help me with this? What's a consent? A consent is what is a consent form? The consent form, all of us get it signed, right? The nurses. So what do you find there? There is a huge big list of things and then somebody signs there, right? So what is it? It's actually a contract. What is a contract? A contract is an agreement which you need to sign between two people. One person cannot do the consent, right? There need to be two people for the agreement to be signed. So when the covenant is signed between two people, you need to agree on the same terms. When you have to agree on the same terms, you need to explain the respondent or the customer as to what you intend to convey to them. And what you convey to them has to be in their local language. What you need to convey to them needs to be having some amount of criteria. Of course, I'll be getting into that place there. And there is also a rising consumer litigation. Today, you'll find there is a lawyer that goes on a shopping to hospitals. In Gujarat, we find this. I don't know how much it is there prevalent in Andhra, but in Gujarat, we find there is almost 5-6 lawyers loitering in the hospital trying to find a patient who is unhappy. And what do they say? They say, don't have to pay to us. You don't pay anything to us. I'll do free of service for you. But when I get you the compensation, give me 20%, give me 10%, give me 30%. But if you lose the case, don't worry about it. So he tries to go on a shopping spree to different hospitals because he knows the small healthcare organizations are vulnerable areas. So therefore, we need to be very, very cautious. A nurse who is here, seated in this audience, if she goes to UK or she goes to the US, she has signed her documentation on the chart paper. And now, when this case has gone into the court of law, will she be called or will she not be called? Answer me quickly, please. A little less time. She will be called because when in the court of law, anybody who has documented and who has seen the patient can be summoned and interrogated. And by the virtue of you joining in that institution, you have already consented for it. And now, if you see any of your documentations, go back to the medical records and tell me which was the nurse that wrote that orders. I'm sure they had some medical superintendents here, Rainbow Hospital, I have some people, other hospitals. If you open up your medical records, can any one of you tell me one nurse's signature and tell me this nurse's name is so and so? Think about it, what you're writing on the chart paper, your signature is there. But can your nursing soup recognize your signature? Do you write your name and the place where you are putting down your notes? Do you write your full name or do you write only the first name? Okay, did your hospital take a repository of your signatures? Think about it, hospital administrators, and understand, have we taken a repository of all the signatures of the doctors, of the nurses, of the healthcare professionals, and did we document it in the medical records? Think about it. I'm sure 90% of the hospitals don't do that. But tomorrow, when your own case has gone into the court of law and if the judge is summoning a particular person, you may not know the doctor's signature, you may not know the nurse's signature, the lab technician's signature. So there has to be a repository. I'll move it more further. There's not much time. So we will try to see this is the kind of situation we are right now. Let's move it more faster and quickly. 4 principles of bioethics. We know it is autonomy. So consent is nothing but it's taken from autonomy. So as per our constitutional act, right to life is what is giving the authority for this autonomy. And because of this autonomy, therefore, we have the right to self-determine. Right to self-determine because there is right to life, therefore autonomy, and therefore there is a consent form, which is because I can self-determine what I want as an individual. Okay? The next one is beneficence, beneficiary of the patient, or non-maleficence. That is, we should not be any mistakes, justice. Let's move it more further. Key legal frameworks. These are some of the legal frameworks our countries. It's self-explanatory. I'll move it more further quickly. Some of judgments we find have brought about some very, very important things. The first one, The Indian Medical Association BP Shanta has brought what? The Consumer Protection Act. We'll go back to the international arena. In the year 1914, Justice Benjamin has brought about the first consumer right in healthcare. When was this? In the year 1914, before our independence. And Justice Benjamin, when he gave the verdict, that is where we have got the rights of patient. That is where we have got rights of an employee or rights of a healthcare worker, specifically when it comes to the arena of healthcare. But this year we are looking at the Indian context, and that's where we find in this. The second case, Samir Koni case, then that's where we find about the consent. Then the Jacob Matthew case, a very famous case, there we find about legal negligence. Let's move further. Now, as per the Samir Koni judgment, what is the first thing they have come up with? They came up with the nature of procedure. What is the name of the procedure that you're doing? What is the nature of it? What is it that you are intending to do? Have you explained the patient the complete procedure that you intend to do? Have you given the patient the information needed for the risks and alternatives? We all talk about risks, but do we tell about alternatives? The nurses, do you find your doctor when he comes and explains the patient, do they explain about the alternatives? We always talk about risk, and we talk the risk also very subtly we talk. We don't try to highlight those things. But what does the law say? You need to talk about all the risks. Now, we all talk verbally, but I want you to go back and check your consent. In those consents, you'll find that those things are missing. Consequence of refusal, and then you'll find many of those things are there. I have 5 minutes. Okay. Okay. How do we have a documentation discipline? If it is not documented, what does it say? If it's not documented, it is not done. If you have not documented it, that means you have done it, but it means what? It is not done. Let's go a little more further. We know all these things. Let me go to the target. Okay. What are some of the checklists that we have? The toggle protocol checklist. What do we do first? Standardize what? The consent form. A fixed template. Then procedure specific risk documentation. Not only risk, but what did I say? Also the alternatives. MLC SOP displayed. How many of us have an SOP displayed in the emergency department? Is it only emergency department you need to have MLC done there? MLC can be done even in the ward. When you come to know of certain things that has happened to the patient, even in the ward. So basically, every place you need to have the MLC SOP displayed. Maybe a flow chart. Okay. And next thing, patient rights charter displayed. That all of us have NABH. Refusal documentation system, until legal audit. How many of us do the audit of our charts? All of us, do we do audit of our charts? What we do as a good practice in our hospital at Surat is we pull out the charts every single day. The night duty staff should audit what the day duty staff have done. And they have to give us the non-compliances. And by next day, the chart has to be ready with all the compliances. Then the manager goes in for having a look at the document. Then the quality professional goes for looking at the document. Zero blank entries. No blank entries. Very good. No overwriting. Single marking and striking. Staff legal training quarterly. That's again one very important thing to do. In Tagore protocol, the fight was against what? Corruption. In healthcare, the fight is against negligence, informality, documentation gaps, ethical shortcuts. So in short, to summarize my whole presentation, what does it say? Ethics and documentation, combine it with legal awareness, which you will give to the classes that you take for your staff and with your doctors. And then what do you bring there? You bring the trust. Therefore, small hospitals do not need big legal teams, but what do they need? They need what? Strong systems. Quickly, how many of you have seen a lobster, a prawn, a big prawn? All of us have seen a big prawn, right? These prawns are an immortal living beings. There is a lobster that lives down in the ocean, and this lobster keeps on changing its changing its life. It becomes so bulky that the shell that is over it is so strong and it doesn't get time to remove the shell. But it keeps on trying to remove the shell, but the shell doesn't get removed. But what does it do? It swallows a lot of salt water, makes itself more bulkier, and what does it do? It ultimately, because of its bulkiness, the shell gets broken. And what happens to it? It becomes totally exposed with its soft body at the bottom of the ocean, exposed to any kind of danger, any kind of parasite, or any kind of creature that is roaming in those waters. And what do? It starts protecting itself till it grows its own shell again. And again, after a few years, the same thing goes on. Again, after a few years, the same thing goes on. And the lobster can live for more than 100 years. And there comes a time when it can no more molting. It can no more molt itself because it has exercised every single molting activity in the past many years and become very refined that no creature can come and kill it. A hospital is just like that lobster. The hospital is just like that lobster because the laws keep on getting added. The shell keeps on becoming stronger. You are cocooned in the hospital, not realizing what are those laws that are governing you. And you keep on following those same things what you know, and there comes a time when you need to go back for malting and changing yourself. If you don't change yourself, you will cease to exist. You will cease to exist in your own life. And if you molt and if you undergo the molting process, you can transform yourself and you can make sure you can be living immortally forever and ever. And that is what you don't want to be disturbed in UK, you don't want to be disturbed in some other hospital, you don't want to be disturbed anywhere. Therefore, if you do your things right today, you can be that lobster. Do you want to be that lobster?
Session. Now we move to our next insightful session titled From Chaos to Calm, Making Compliance Easier. Compliance is not a pressure, it is protection. It protects patients, it protects systems, and it protects institutions. I request Dr. Balamurugan sir to start the session.
Morning. Good morning. Good morning. Yeah, just to wake up everyone Saturday morning. Rayas has told we will be to come at 8:30. Isn't it? Okay. So first of all, thanks to Asram Hospital and Mr. Rayas sir for inviting us and hosting this Jeevan event in Eluru Asram Hospital. So thanks to everyone for the hospitality and we are the opening batsman. Rayas sir is coming from Surat, so I looking as a very similar opening batsman, so doing all the sixes and fours. Myself coming from Chennai, Varun Chakravarti is spinning the ball and taking this legal compliance chaos to calm and making compliance easier. How many of our hospital owners just want to know the league participants details so that I can change my deliverables? How many of the hospital owners? Okay, CS, CEOs, COOs. Okay. How many of our quality managers? Quality managers. Okay. Nursing staff? Majority nursing. Okay. Let's see. Most of the Jeevan program will see nursing staff only. But you can also be CXOs, CEOs, hospital owners. Don't think that you are nursing. I have seen most of the nursing staff becoming a CEO of big all corporate hospitals. Dr. Ajita Nair, Jyotika Ram. You can be CEOs, you're owners. Why come? I'm coming from Dr. Muthu's hospital, right from the chairman and we have 3 hospitals in Coimbatore, coming up a new hospital in Chennai. So we graduate for him to be present here and deliver the talk. So before starting a hospital, how many licenses are required? Any idea how many licenses are required? Number of licenses. How many licenses? Number of licenses? 10, 20, 20. Any guesses? 40. Okay. Any other numbers? No. So there are 70 licenses required before running a hospital. Okay. It's related to core regulatory licenses, diagnostic letter, and employee administration letter. So this is just sample of licenses starting from plain Establishment Act to diesel generator NOC and telemedicine compliance guidelines and doctor's nursing registration about your medical council and nursing council. There are a lot of regulations are there. I'm not going to detail about how to get the licenses for each licenses. I'll just talk about the important points because time is 20 minutes. We'll talk about only the important points. And this is basically about the 2-3 states, Tamil Nadu and other states. So Andhra Pradesh, I just started looking after the license process. So very important is pre-license that license, CA, we call it a CA license. Before starting a hospital, you have to get the license by submitting applications to health, medical and family welfare in Andhra. It's coming under the Allopathic Private Medical Establishment Registering Authority. So how many of you have got the licenses? You can go today. Before starting a hospital, you should get the license. And building permit certificate, fire NOC, and then sanitary certificate. For getting a fire NOC, you have to comply with the fire safety measures like your fire extinguishers, fire hydrant, and ramp if you are exiting the patients during the fire. And then consent to establish, consent to operate for biomedical waste. You can get it from the Pollution Control Board. You have to apply it, you come for inspection to get it. So in this, I put based on bed strength. So please be careful when you are applying for the biomedical waste license. Whatever you got license for regulations from that, the same bed number you mentioned in the biomedical waste license also. If a discrepancy happens, it will be difficult to get it during the NA-based audit or any other external audit. So there should be same version for biomedical waste license and CEA license. So please make sure that it is safe. And then encourage safety and inspection certificate, like you have to get the license for your electrical safety, like to run the hospital for your electricity services. ARB for X-ray, CT, MRI, the PCP entity and registration. And it is included in ultrasound as well as echo mission. So how many have included your echo mission in the PCP entity license? Echo mission also should be incorporated in the PCP entity license. Don't think that it is not coming under PCP entity because for echo mission also they can able to see the sex of the fetus. So they can use different globes. They can check the gender of the baby. Blood cell licenses, organ transplant, MTP, and reactive license. So I will not go in detail. Pharmacy license, you need for retail as well as for wholesale license. Form 2021, Form 20B, and Form 21B. Narcotics. So here I don't know how they are doing the narcotic license. So how many departments will come and see your hospital for giving a narcotic license? Any idea? So there are 4 departments will come to your hospital. So in this in Tamil Nadu, I'm not confirm about Andhra Pradesh. There are 4 departments. One is the excise department, second is the JDL, and third is the police SP office, the fourth one is the collector office. The 4 departments will come to our hospital and see the facility and then they will tell you narcotic license. Please be ensured that the number of files are properly mentioned in the narcotic license. Most of the time, we'll face that the fentanyl count is dispensing the narcotic license. GST, obviously, we know that for OP pharmacy, we need to get the GST certification. So if you have 2 pharmacy, one is in the ground floor, one is in the first floor, both the pharmacy doing the billing. So if you require 2 licenses or 1 license is enough. Two licenses. Okay, any other answer? Some hospitals they have only 1 license. Can say that we are licensed for both the pharmacies. So please be ensured that if you are doing the billing, you should get the pharmacy license. If you are not doing the billing, not doing require the license for particular pharmacy, what we are practicing and the legal measurements will give it. Ambulance situation, please be check that we have sufficient or valid license for ambulance drivers, pollution control. Your insurance is very important. Sometimes the insurance is expired, you're not able to get the coverage if you are in any accident. E-waste license, license, general waste. So now the issue is happening the general waste disposal. Most of the times they are disposing in any open areas. The public will come to know that the hospital is dumping the general waste in the open area and they'll get the complaints from the local authorities. So please make sure that the general waste is properly disposed. So read, be aware and update act in time. So don't say that I don't know about the licenses or legal parameters in the state as well as the national laws. So please go through it and read it. Make sure that you are aware about your legal document. These are news we got from the Google and website. So still now we have seen about the licenses required for hospital. But we only 10 key steps or tricks to make sure that the compliance is very easier. First, we choose one trusted staff as a compliance officer. Most of the times we'll see that license is expired, nobody is checking it or nobody is following it up. They will apply after the expiry of the license. So please maintain 1 person or allocate 1 person to track all the licenses that your relative or your experienced staff or your genuine staff who are trusted in your hospital working for a long time. You can assign them as a champion of legal licenses. They can handle the file submissions, all those things. And make a tracker sheet, make it a digital or physical, make an Excel sheet and enter all the licenses starting from valid till whom to apply, when to apply, all those things can be maintained in the tracker sheet. We can give a automatic reminder. So Caho, we are having a compliance tracker sheet. It's an app-based module. You can enroll the Caho institution member. It will be free downloaded from the Caho website. So this report to the local officers. Most important that sometimes they will come to inspection or they come for any report collections. Most of the time, the staff they are not behaving properly and they will get angry and then next time we complain for license, they'll show their ego and their public. So please make sure that you having a rapport with even a electrical line in case of any power shutdown, they help you to run the hospital without any features. There are basic SOPs, as far as told that you have to make SOP for all things, but make sure that the legal SOPs are maintained properly, particularly biomedical waste, fire safety drill, and additional safety aspects. Self-audit or external audits, do at least a quarterly audit or check yourself for licenses tracker. You get the license tracker from the any quality person or big people, check the validity and then If anything expired, you can inform them, and we can do a audit of the department also, fire safety or biomedical waste particularly. So Caho also doing the external audit, you can reach us to do the external audit for fire safety. But also work with the work with local vendors, particularly fire biomedical waste treatment facility. So that they can help you in getting the treatment properly. HVAC maintenance or your AC maintenance. These are licensing records. Most of the time, what happens is you get the license, the original copy will be missed. They will say that it's with that particular department, it's in the other department. When you want to apply for the renewal, the original license is not there and everything kept in the system. So keep digitize, scan them and put it in the Google Drive or Google records, and keep it in a separate folder in your personal computer so that it's useful for your future renewal certificates. Educate your team, keep them knowledgeable of the new regulations, changing the parameters, what are documents required. And you can display the licenses in your certain area. Most of the times, the people will come and see the facility. If you see the display of licenses, the license is kept, they'll go back without any questions. Even the public or even the press people, they'll come and see if for displaying the certificate, it will be easy for them to know that you are complying with all the legal parameters. The information system staff, whom to call during the inspections. For example, any fire safety officer comes, he is asking the front office staff about the licenses or about the renewal. If they don't know about whom to call or what to inform the people or government staff, it will be a problem for future. The last, avoid consultant dependence. My personal experience can take your decisions. Don't blindly believe the external consultant, third party consultant about the licenses, renewal or applying. If you want to get anything done to the initial stage, but be careful that they are doing proper job. Most of the time, will give money, and then at the end of the day, you will get the proper licenses or proper outcome from the external agency. Not finding fault, but make sure that they are very genuine and they are doing good job in their background areas, so we can verify them the previous records also. Don't blindly follow them and keep them in a dark side. To keep them informed, you can also check with them how much they know about the license protocol and all. So thank you everyone, and on behalf of Caho, I invite you all for the Caho Con in Chennai. It's on April 10, 11, 12. So you can register and any feedback you can give it to us. Once again, thank you for the great opportunity. Thanks everyone.
Thank you, sir. Thank you so much for your insightful question. Now I request our respected chair and co-chair to kindly share your observation and vote the questions to speak.
Good morning, everyone. Welcome to the conversation. And so coming to the topics related to the ethics, what would be the one change that could reduce 50% of risk in the hospitals, especially small care hospitals?
If we can go to the patient with the heart of service and have empathy, most of our problems will get solved. Because we're not looking at it commercially, but we're looking at the angle of service. Service brings accountability, accountability brings responsibility, and they become more ethical.
If there is any ethical failure, who should be held responsible? Owner, other medical superintendent, or anyone else?
Every stakeholder who is in the chart, whoever has documented there, and there are some people who have not documented also, but they're actually part of the whole team. So every single individual is responsible. But here, a glitch is here. There is onus mostly lies on the hospital and the doctor. That is the compensations that we have seen, majority of them are borne by the doctor and the hospital. and a few instances where you find even this were implicated. But mostly the onus falls on the hospital also. Therefore, we take the indemnity insurance from them.
Actually, there was a case in Hyderabad in one of the hospital. So the patient was treated for the limb lengthening surgery. So and after limb lengthening surgery, the patient has went to the High Court stating that I couldn't perform my daily activities, and he has approached the court. The doctor has been fined 2 crores and 7 years of ban. So what would be the problem in that case?
Not knowing the intricacies of that case, sir, but for sure, if he has taken the consent carefully and told him all the risks and the alternate is available, it is actually there. I'm an assessor since 2009, NIH assessor. So there was one hospital had the same kind of an issue, but luckily they documented the information in the at least operation theater notebook. They have a notebook there. The charts, it was missing, but the notebook was there where the doctor signed the procedure he has done, and he has not listed the whole steps of the procedure that he has performed. But still, the court took cognizance of that notes because it had his signature, and then the doctor was actually what we call saved from any kind of penalty. But what I'm trying to say is, if the patient has a right to say yes or no, even on the table, the patient can refuse. And we need to take the many types of consents. It's a very huge topic. We can take a duration consent, anticipatory consent, and also there are different consents. So, as per this case, if I know the more details, sir, for sure, if you would have taken the right consent, these days we have digital consents because we keep a patient inside a room, video is on, the audio is available, you take the consent and it is documented. That's the kind of digital world we're looking at. And if we have even written consent with the patients, if the patient said, I have gone on my own for yes, consented for it. I don't see a reason why the doctor should take 10 minutes. Maybe the consent is not taken. As I said, there are so many lawyers talking, and if you have done a fantastic and an ethical job, but you have not documented, then you are vulnerable for any kind of legal. So the most important thing is documentation. Documentation, communication, documentation with proper same language what the patient speaks. Who should sign for the patient is another important thing. An adult who has a sound mind is what they say. But how do you decipher whether he has sound mind or not? Is again something to be qualified by a psychiatrist. But of course, all adults are normal, so they take consent. But at the same time, whoever has given the consent for a child, again, that becomes a little more complicated. So there are so many things in this. It's a huge area, but for sure, that patient who has gone and I'm sure he's an adult because of the kind of surgery. But if his documentation was right and appropriate, and the surgery was successful, and he was told about the risks involved in it, even the 1% risk is what the court says. It is an incident that happened on this person. So the court is very lenient to the doctors also at the same time. But at the same time, we need to be careful in our documentation. Sometimes the nurse documents it, but the doctor doesn't document it. The RMO doesn't document it. So the nurse documentation will contradict the RMO's notes and the doctor's notes. So it is not just the doctor is absolved of the problem, because if he has done a procedure and he is trying to change the record here, but that record speaks about something else. So again, documentation should again speak to each other. The nurse's note should speak to the doctor's note. Doctor's note should speak to the nurse's note. So everything should be again the lab reports. But again, if it's a abnormal value, you have to document it here. Not just the value, but you'll also write there. It's an abnormal value. Therefore, this is the kind of intervention done. So, a lot of things are there. But,
So the intent of the session project not to blame anyone, to blame anyone. It is not about the courtrooms. The medical practice has been less dignity because of increased awareness in the public, and also there is and several things are coming into the picture. So the intent was to make aware of the public that how important is the documentation. I care for 3 hospitals. And what I do, every administrator of the hospital, every manager of the hospital, supervisor of the hospital is compulsorily taking one full case because they need to know what they have to go there. The pain that they undergo standing there waiting for your call, making sure you are literally confident in front of the lawyer. The lawyer just pieces you apart. And all that if they see, they learn immediately. So it is a lesson for all of us. We need to stand up managers, supervisors, senior nurses. Once in a while in the court, you look at what happens there. Then they will surely fall in line. Okay. Actually, I'm the aviation but my private aviation. So, in most of the hospitals, what happens generally is that, especially in the MNC, you know, in the MNC, they will vote, but they will not bring it to the police. So, so that is the problem. And the second thing is that sometimes because of lack of awareness, they will be picture of their like the number will go in the so that is another legal problem. So that is because we will give the time.
So much and any other questions from you? Oh, it is open for any questions from the audience. Yes, sir.
Thank you, Balabagan, and thank you, Anil, for a wonderful presentation. Uh, the chairman asked a question. Ethics starts from where? Maybe a person like me has worked for almost 35 years. And I believe the ethics starts from the top. If the head of the institution has got ethical values, but let down video. In fact, just about almost 20 years ago, I joined the hospital in private work. And that hospital is a large hospital, it's a boy very simple. And believe me, that chairman was very clear that it will not be Rafael charge 10 years ago. Believe me, it continues even today. So just imagine a lot of hospitals are going for research practice. It's still happening, and I think first of responsible was the chairman. Thank you.
Thank you, sir. Thank you so much. Any other questions? Yes, sir.
Insights of the Pala. One threat matrix that we could aspect is with the AI, because I would like to see how ethical and how standardized we make. There's always a evolution that is happening with the healthcare aspect where patients are becoming more smarter. There's something that is in their hands, the AI aspect. So how would you interpret and give us an insight where AI falls as an evolving aspect for right now, because I think we are on a platform where we should be more precautious as for healthcare wise, and yeah, I think that falls as a very generalized question to you.
That's a very nice question, sir. Today, if we all have patient has right to take the medical record from the hospital. So the patients, if they load all the medical records onto the AI, chat GPT, and evaluate it as the best consumer lawyer, the AI is going to tell tomorrow what are the mistakes the hospital has done. They don't need to go to a lawyer now. That's I want to encourage all of you get enrolled into Caho digital standards training. In that, one of this is the topic there, sir. And what we suggest there is we ourselves should actually load that into the chat GPT, because we can use it, right? And then see where our documentation lacks, and then look at the audits according. Yes, sir.
Now it's time for felicitation. I request organizing committee. I request Dr. Shantara Garu to please felicitate Dr. Anil Chinnimutta Garu. Now I request Dr. Manoj sir to please felicitate. Please join sir. Please. Now I request Mr. Rajnath sir to please felicitate Shantaya sir. Thank you, sir. Now I request Dr. Harish Gautam sir to please felicitate Dr. Chandrasekhar Banot sir. Request for one photo. Thank you, sir. Thank you so much.
Let us begin with a powerful session of the day, Wakadu Mission. One goal, one direction, one commitment to quality, patient safely, and strong systems. This session reminds us that transformation begins with the unity of purpose. Now may I respectfully invite our esteemed leaders to the dais for the panel discussion.
It is my privilege to present Dr. Harish Gautam sir, a distinguished preoperative physician with over 15 years of experience in preoperative care and hospital systems. Currently serving as a deputy medical superintendent and head of medical services at our Ashram family. A fellow in interventional pain management and an MBA graduate in hospital and health system management. He seamlessly blends clinical expertise with strategic leadership. As a system-focused clinician administrator, he leads initiatives in quality, patient safety, and clinical governance. A respected national faculty member and panel moderator, he continues to elevate healthcare standards and inspire excellence. We request Dr. Harish Gautam to kindly chair the session. Sir.
It is my honor to introduce Sri Anapa Vasu State Consultant for Health Care and Quality Assurance and Education on Remedy. A dedicated public health professional, he plays a key role in strengthening healthcare quality systems across the state. As a national assessor for NTA, Lakshya, Muscon, and Kaya Health, he has significantly contributed to evaluate standards in public healthcare institutions. We requested the Adapa Basubab to kindly take the statement.
He is a healthcare leader. His biggest extensive experience in hospital operations and patient-centered care. Under his leadership and the institute continues to uphold high standards of clinical excellence and service quality. Please join me in welcoming Sri and Jeevan.
It is my privilege to introduce CH Kumar, Regional Head of Omega Super Hospital, Jeevan and Guru Glasgow. And our panel member is seasoned healthcare administrator. He brings strong leadership and operational excellence to multi-field hospital management. His strategic vision and commitment to quality healthcare has significantly strengthened instituted performance across the region. Please join me in warm welcome from CH Kumar.
It's my pleasure. to introduce CK Nageswar Rao as Manager Quality and HIM AM Architect and Digital Strategist and ISNI Healthcare Identity. As a panel, he plays a key role in driving quality excellence and digital transformation initiatives across the Vijayawada and Eluru states. With extensive experience in healthcare information management and innovation AI solutions, he has been instrumental in strengthening operational efficiency and patient care standards. He currently oversees quality operations in Vijayawada and AU. Please join me in welcoming him to share his valuable insights of this conference. Welcome you, sir.
Geography and technology are Caho is the name of the statue and shows the street corporate population. And human care goes wide and our esteemed member is having vast experience in healthcare, leadership, and corporate cooperation. They have speed drive and board in promoting quality standards and global best practice through its association with government. He continues to contribute significantly to healthcare excellence and accreditation institute, and his visionary leadership and commitment to patient safety make him a significant voice in the healthcare sector. We welcome you, sir.
Morning, everyone. Welcome to Asram. Welcome to Caho Jeevan. And welcome to our panel discussion on one goal, one direction, and one commitment to quality, patient safety, and health systems, strong systems. So I welcome all the panel members for our discussion today, and it will be a 1 hour session. And we have experts from all fields of medicine. So we have a facility director from Rainbow Hospitals, we have a Omega head taking care of the Vijayawada and the Guntur cluster. We have digital expert here, and we have our international representative who understands across all the countries and states and how the systems are going on. So the first, we know that each and every hospital will have strong doctors, individual nursing staff, and departments who excel in their patient care and safety mechanisms. But does the healthcare organization depend on individuals? No, it should not. It should depend on the systems. So the patient, when he enters into the hospital campus, from his registration to discharge, he experiences the process. The way the person is being taken care of, how reliably the patient care is, how the things are being explained to him, and the family members, how the things are communicated to him, how the concerns are taken, how the treatment protocol is standardized. So the patients and his family, they understand the process. So unless we put the excellence in the process, the system will depend on individuals. That should not happen. So that is the essence of our Okodo mission, which falls in line with the core principles of Caho Jeevan policy, which states that patients' safety is the first, always, systems over individuals, and there should be continuous reporting of the things and culture, and learning should be there. The person should have continuous education. So in aligning with the Caho principles of philosophy, so let me start the session today. And we have divided session into 3 segments. So one is one goal. What is to be measured first? The second segment will be about how to define these metrics into standardization. And the third segment is about how we go forward after the accreditation process has stopped. So we have done with our accreditation, how we really continue with the sustained culture improvement. So that those are the 3 things. And we start with the first segment, that is how do we measure. So I asked Tim Mercer, who is the Omega head here. So how do we proceed with the metrics here? So what are the different types of metrics available? And which one do you think is the best one to start with? And how, in your experience, will help in the improvement of the patient care? Thank you, sir, for this great opportunity. Hospital healthcare industry, particularly when we are talking about small and medium healthcare domain, so intensity care hospitals. Secondly, the point is we have to, with ultimately our PNL role, our PNL aspect, we have to see that, and based on that, our numbers and our metrics will contain on that. There is no doubt in that. But ultimately, the systems, how strong the systems that we have to see that. So, number one point is the conversion ratio of the patient comes outpatient and how that is converting into inpatient. Patient to inpatient, the challenges, follow-up challenges, and the patient, how we are tracking that suddenly that leads to our healthy PNL. And there are a lot of things. So, as you said, rightly said, that the first goal is to specific metrics. The metrics where we are talking, no doubt in that. So, I strongly believe in that. Outpatient footfall to the hospital. So how we are giving the best service to the patient, how we are so that the word of mouth publicity to the patient to conversion ratio. Similarly, our internal systems, how effectively we are converting that patient into the inpatient. The ultimate goal is to give the best service to the patient. In that, definitely this tracker of the OP to IP conversion ratio will help to tell you one parameters. And secondly, if the patient is undergoing any investigations, the tracker of the biopsy trackers, the follow-up trackers certainly comes into that again. So I'm going to the micro level of this thing when you have come to this. So these things ultimately leading into the conversion, patient conversion. So I strongly believe into that. And there are other metrics, things like when we are moving into that the patient care, individual the attack of the laboratory attack. So each patient, for example, one patient is undergoing for CBC, LFT, RFT test. What is the basic tag of the basic investigations? We have to display that and we have to keep track on that. There is any deviation with the lab investigations. The strong coordination team should be there to coordinate so that the reputation of the lab tag, whether if we are giving in 2 hours time or it is leading beyond 2 hours, we have to certainly we have to keep track on that. Particularly for the patient is paying for money and or else we are going for insurance category. Suddenly we have to give the utmost care and utmost tracking methodology we have to embed in the systems. So that is how we have to keep track on the trackers. There is a second tracker that we fall into the line. And after that admission tracker, start from the admission, doctor advice to admission to patient, bed allotment to patients. So what is the tag for that? So ultimately quality indicators will certainly will tell all these tags, no doubt into that. But again discharge process, again the tag. So what in charge of something that's most of the team, nursing care team members are there. I think certainly doctor initiation of the treating doctor initiation of the discharge start from how we are doing the follow-up in the patient exit from the hospital. So these trackers indirectly ultimately entry to exit. So certainly matters for the trackers. So from the registration till discharge, along the clinical pathway, so the patient's family will make a lot of access. Exactly. So they encounter the front desk, they go to the registration counter and they follow up with the billing processes, how the thing should be, and they talk to the floor managers about the type of insurances or claims they can really put for the duration of the stay, and they enter into the initial assessment process. So after that process is over, so from the time of initial assessment to the bed allotment, if we can really bring down the time to as early as possible, so then the treatment can actually start. So because everything is accountable. So from the time of admission till the day of discharge, each and every day the progress notes, the type of treatment that is given. So everything has to be accounted by the nursing staff, the treating physicians, and all the managers. So that is how we go with it. So is there any role of dashboards, how we can track the turnaround time? So can we really tell me specifically about one or two metrics or turnaround time to be exact? How we can improve that and what solution can be there?
Yeah, I think the recent systems, I think Suvarna is also part of it. It's also where definitely the recent domains, the most advanced things are coming up. I think dashboard, I think the dashboard methodology of Suvarna software systems. examples. So in that everything is user friendly nowadays. Like so, as for my knowledge, I remember that certain things I will the process itself. So we can tracking methodology we can generate the report. So the basic reports are available in the system like admission, number of admissions, number of discharges, number of this thing, department wise. These things, basic information will be available in the software. But how the software will be useful for day-to-day operations that's more important in this aspect. Discuss.
I think Nagesh should also will have much to
Yeah.
say about this aspect.
I think
Over to you, sir. So what should be the metrics that we check daily and how is software and dashboards that we use?
Good morning, everybody. Thanks to Caho. As far as dashboards concerned, management, first of all, management would like to know straight away. There is no middleman. Okay, information is like a river. It has to flow. It shouldn't be stopped by anybody. Whenever management wants to know anything about the main everything, it should be in fingerprints. So our software vendors, our team should try to get that type of dashboards. Nowadays, it is becoming very easy with the advent of this AI and information. So all should focus on the internet. The information should be top to bottom, based on rules. We shouldn't just show every information to everybody. So that is our prime box. We should keep focus mainly on that.
Okay, how should we collect the data? So I always tell my students and everybody that we are all data collectors initially. So we collect the data, we process it, and we analyze it, and we try to categorize it. After we categorize it, we want to check if it is right or wrong. And if it is wrong, I want to check if it is acceptable or not. Even if it is wrong, that may be acceptable for me at that point of time. So this continuous data, which is generated and shown on the dashboard, how can make the clinician trust it?
Before going to trust your data, you have to validate the data. Validation is most important. There may be many modules, there may be many systems, but when you feed the data, you have to validate the data. Somebody should be there to validate either manually. Otherwise, consultants or management cannot touch the data. And moreover, healthcare is having a lot of data. Though it is an oxygen for the organization, it is a huge data. So, as long as we are going to use the data, it should be valuable. Okay. Then only consultants will believe the data. They will come into. They won't believe it.
So
They will have
can include the clinicians from the design, signing of the metrics clinician.
even they don't want to pay 1% efficiency because 1% mistake also costs a lot. In this type of medical legal aspects will come review. So they are not ready to give you 1% chances. They want 100% foolproof system. Then only they will use. They will believe start using it. Will support us.
Okay, now let me take the pediatric and neonatal perspective also. So please tell us which metrics are really useful in understanding the thing. And in pediatrics, it's not like I'm a cardiac arrest. I always say there is 5 to 10% mortality. Some people will accept because the person is more than 55, 60 years of age, having these problems for such a long time. But even if we say that 1% or 2% risk is there in pediatric population, so people will take it very emotionally. That is really on a different scale altogether. So, which metrics specifically at the practical point will help us in understanding the measurement and how we progress from that? We are in the initial segment where we are defining the goals. So, which metric should be really taken for our consideration and how we proceed with the dashboard? Your opinion on that?
Very good morning to all. To start off with the question, sir, I would go in a very general aspect. Let it be non-clinical or unclinical, I'll separate it. When it comes to the generalized aspect, I would term as one term as patient experience. Let it be neonatal, pediatric, or adult. The patient experience that what has been discussing from the day they have landed up to the hospital till there are regular follow-up patients. It is our responsibility to take care of all the each every step is to be managed by us because it is our prime responsibility to take care. So when it comes to neonatal and pediatric, especially points, specific points, I would focus on the FTR kind of specific where failure to rescue is the main aspect where all the clinicians and all the administrative persons are aligned towards. Just to focus on what is FTR, it's just to brief upon a very layman aspect is it's an inability to prevent death due to a treatable condition, just like a post-surgical complication or pneumonia, VAP, where ventilator-associated pneumonia. When it comes to pediatric or neonatal cases, it is very much hard to digest, as sir said, where even 1% to our next kin or to our son or a daughter is much more as a priority than an adult kind of case. Yes, so there are a hell lot of, metrics, so many aspects, so many elements, so many aspects that we can take care of. But there are key aspects where you need to focus mainly on. But one aspect that you would focus on is FTR, sir, where it implies a lot and brings a lot of change in the neonatal and pediatric aspect.
If metric is made visible, the numbers, if once we start improving the discipline or the process and everything, so you can see significant improvement in this if we make FGR as the measurement. So that's your take on that. Sir, what is your opinion about across the thing, across all the hospitals and internationally, about the health systems where various states have them. So what maturity systems? So depending on the hospital issues. So we say early system, developing system, mature system. So that's what sir was saying about the maturity. So what is your take on which metric should be taken, which we measured?
Good morning, everybody. So globally, the hospital, how they are looking at this maturity level indexing and maturity level compliance evaluations is a hospital that doesn't rescue a patient in time is not a mature hospital. It's not by size. So as Dr. Swa stressed upon, it is a failure to rescue rate. That is globally managed as something. Now coming, we cannot do all globally in our state or city. So coming to our city, what we can do is we can add that rescue failure rate to unplanned ICU admissions. Like how many unplanned ICU admissions are happening? What can we do? What can we do to prevent that? See, what we get out of this is we can change the culture also to measure this rate. What we are doing in preventive mode, failure to rescue rate is a preventive mode rather than a mode that already happened. So this increases the responsibility of the nursing staff, creates a transparency in the meetings, what you do, conduct everyday review meetings, and also what it enhances the care program of the organization. So I really stress upon this part where, and we can even extend this failure to rescue rate to port blue. Now we do more of port blue in ICUs. You can do beyond ICU care and 30 minutes of escalation processes. So all these add on to the failure rate, rescue to failure rate, which we can stress upon, which is happening globally. And our city, it's very easy to apply to unplanned ICU admissions. Such things can be done to 30 minutes, before 30 minutes, we can escalate to the corresponding authority in a documented way. All these steps can be captured to improve this maturity in the hospitals that we are.
So now the theme is all about the small and medium hospitals. I believe the small and medium hospitals where our health system is in the early stages. I say sepsis is the main one. So stopping or preventing hospital-acquired infections and following the sepsis bundle compliance comes early. So once we take control of the infection protocols and everything, so then we move on to unplanned return to ICU or unplanned return to OT and rapid response calls in the thing. So that is the developing hospitals we should focus on. And the mature is like you're saying about the FTR failure to rescue and risk adjusted length of stay. So that is one more important metric where we adjust the risk to organ system defects and then define a length of stay. And if anything is going beyond that, we want to identify, do a proper audit, go down to the clinical pathway where it really went wrong. Is it at the diagnostic level or the treatment level or the antibiotic, if we really follow So that is one. So we have a lot of metrics here. So starting from sepsis bundles, unplanned ICU returning, failure to rescue. So now that we identify which hospital or its system has to take which metric, so that the goal is defined. Now let me move on to the second segment, how this has to be put into a proper direction. That means standardization. So came to us, sir. So how do we standardize any metric? How we standardize that? How we really make the doctors and the nursing staff and the senior administrators and the management also align with how we progress with these metrics measurement. So we identify the data. We are now in the process of measuring them. Putting in the right direction is very important. Standardization is important. Your call on that, sir.
Yeah. Standardization, the clinician perspective and rest of the team perspective, simply like, so for example, SOPs will be formed, SOPs we have to execute. For that reason, we have to engage clinicians. Firstly, tumor, for example, tumor board meetings. So multidisciplinary tumor board meetings plays a role for clinicians to execute or establish the standardization so that the the sequence of meetings, the sequence of the discussions definitely will give the best results. The continuity is also important for giving the best results. As per clinic standardization, the clinician perspective, and daily reviews, other team perspective, like we have to review and educate the team members, learning and development perspective, we have to standardize the processes.
So we create standard operating procedures. We all know that SOPs will be converted to PDFs. But how do we convert it into workflow? So by having our review meetings daily, so measuring data, going to the problem where it actually is happening, and reviewing the data and going and take this interest instead of really taking the data and putting on the table. We want to go to the appropriate people, identify who is responsible for that, make them own that, and make them accountable, and come up with a possible solution for that. And reviewing. So that is what keeps us standardized. So from digital point of view, tell me about the data-driven standardization. So how can we really integrate into the EMR? Is there any process how we progress it? So you are showing me a beautiful thing about an enable 6:30 in the morning. So how we can digitalize that and make life easy for them. So because we have consultants who are double-minded in completely going on to the EMR, so why can't we really continue with my manual thing? I can take a lot of patients more. If I start digitalizing, so if everything is not comfortable for me, I will be looking at less number of patients only in a given day. So that's our main concern. So how does technology help here? And how do we integrate all these measurement metrics into our EMR programs? Aishwarya.
First of all, consultants would like to have accountability on his own. Okay, it is not a IT department work. It is not a nurse job. It is not a quality department. So whatever the data he is generating for his patients, it is his responsibility. Management can provide everything, but he should have inclination towards his patient's data. His or her data. Okay, so he should take ownership for the information of their patients. Okay, once he starts his journey in that way, then automatically all the systems will support. All software, hardware, whatever he wants, they will provide. So first of all, consultant is the person who is responsible, who should show interest. In our area, it is the only one area we are lagging of it. Hospitals are facing the same issue. So once they are ready, everything is ready.
Something from your experience, how this dashboards helped in.
Dashboards will show us numbers, sir. But the thing, numbers never give us a real picture. Numbers never give us a real picture. Doctor, consultants and the team, they know it very well. So to believe that numbers, consultants should involve in that process. So somebody is showing numbers, so okay, but how far it is reliable? They know very well that these numbers are right or wrong.
by looking at it instantly, they can tell what is right, what is wrong. So we need involvement by the consultants.
So how to motivate them? That's the
We have to show the numbers for them, what they are doing. If suppose you take a complaint rate of okay, some consultant is very good at, some consultant is very weak. So once you start showing them this is your rate, this is your rate, this is your rate,
So peer comparison is what you're talking about.
definitely
Give them ownership and peer
they
comparison.
take ownership for them. That is their responsibility. Nobody can teach them to take ownership. So we have to show them this is your complaints rate. Like that, every month, whatever frequency you are conducting meetings, that time you have to show the peer comparison. Then you will get motivation. They will start towards it. And they will believe it. They will be taking ownership and you will get maximum on meals.
Exactly. Self motivation is the best thing, and administrators' instructions. So they always are very hard, and they don't really want to take them in Zoom manner. So we are worried about the patient systems only. So once the direction is made, so we want to progress on improving the numbers and this peer comparison and how we have the interdepartmental meets where each and every number is visible. So they want to correct them for themselves, even before the quality team enters, even before the administrators call and discuss about the numbers. So once they compare between the two units, they want to improve on that. So that's how we go with it. So the standardization from the data point of view is very simple. So there are softwares available for making them easy and so from pediatric point of view, we have senior consultants don't want to go with this. So definitely. So this is all. There are two types to this. So can we really put up basic instructions which can be non-negotiable and ask the senior consultants to follow them, or if we really give them complete freedom to establish how the direction should be?
I would suggest that there's one word called consensus, where it should be a collaborative effort with the consultants and give them a support, because there's always a myth when it comes to EMR and kind of these kind of strategic changes or paradigm shifts. There's always a resistance that I will lose physical touch with the patient. I'll have to sit and type. I will not see the patient. The patient will lose trust upon me. So there's always a kind of mythological thing. But I would categorize the consultants into two ways, where one is passion driven, where they are interested. Many of the persons are interested with this thankful iPhone and all the Android technology in the hands. So they are very much passion driven, where they want the systems to be more streamlined and EMR based, where they are driven. And when it comes to the second part is the need, because getting vexed with all the manual processes, so the doctors are getting vexed. So that this is what is the availability of the OP pharmacy? Are those medicines available? Did the patient get those reports or not? Did it get delivered to the patient or not? Is the patient taking the medication? So this creates a need to the doctor where those gaps can be filled. So we can create a platform, give a support to the doctor, saying that you will have a medical transcript with you who will type those all kind of things. Then bring the consultant onto the platform where he will be a part of the change. Without the doctor being a part of the change, whatever we do, it will stay, at that stagnant level itself. So we'll have to. It should be a collaborative effort. Take in champions from the doctors itself who are passion driven. Do a pilot study and show them the change, so that this can be a peer compassion. As you said, yes, peer compassion has a very good result, and show them the transparent changes. So with that, I think we will be able to bring the change accordingly.
So let us talk about variations. So now that you say that it should be a consensus and the doctor's inputs are very valuable here. So we cannot ignore the experience and knowledge they get us from. So people, most often they come from famous institutes, bring a lot of protocols with them. So that's how we have been. So if they are coming up with variations which we have not decided upon, can we accept to all the variations, or how do we proceed with that?
So those can be taken as a added educated part, where we need to work on them, show them the difference, rather than constructively, rather than destructively define them or chew upon them, shun away that no, this cannot be done. Rather than doing that, let the constructive feedback be taken in a proper way. Show them that this is whatever you have given as a feedback. We are taking it and we will work on those and show them the result. So it's been just I've been with the system for 2 months. The HIS was not so properly end to end implemented. So doctors were in a kind of confusion that where they have to use, what has to be used. So those points came to my desk. I sat down, ensured that those end-to-end analysis has to be done so that we should know what is happening, and then we show them the change. Then they will definitely imply to itself. So a bottom level kind of a change should be brought up so that the change can happen from the down level, and it definitely will seek up to the top management for sure.
Okay, I believe there should be non-negotiable things here, 30% or 40% beyond which, because they are for the patient safety. And the doctors, experienced doctors, they can put up their own variations or any protocols. If there is evidence supporting their thing, so you can always think about the patient outcomes. If the evidence is not there and the concept-driven situations arise, so we can wait on reviewing them if no harm is to the patients. So that's how we can really make them comfortable and on the one side, and slowly, once we generate adequate data, we can compare with the evidence based and how we can apply the concepts and move about. So that's about that one. So
I would just add one point to it, sir. Clinical evidence-based pathways are the ones where the clinicians take part, and a little bit of tailoring would be from the management side so that it can adjust according to the hospital needs and the clinical pathways, but it should go hand in hand.
yeah, that will be the point. Yes, that's what we are here for. So from global governance point of view, sir, what is about this? So how do we standardize it? How do we proceed this? Sir.
Now, globalization and the global perspectives are things are very much standardized. Hugely standardized. As you told, we need to have some 70-30 rule model. The 70-30 rule model has some 70% non-negotiable, 30% negotiable. Non-negotiable will be escalation, delay in escalation. So delay is the main cause of non-standardization. It's not that they know everything, but the delay is one part where the global markets are looking at. No delay. Every metric is a delay. Delay in escalation, delay in treatment, delay in judgment, delay in care, delay in approach. All these things are main cause. So they are adopting a 70-30 approach, which is possible in our markets also. Like non-negotiable services protocol, medication safety, infection control, emergency escalation. And the negotiation, 30% can be on clinical and not. Because they take time in judgment, they need to evaluate. So that can be built. This 70-30 model is working a lot, sir. And SOPs, if they're not held accountable, they don't work. So SOPs in relation to 70-30 model, standardization should be working it, sir. And clinical governance and local responsibility. So as a part of clinical governance and central governance, what you can do is you can try to make a central system in adapting all these SOPs centrally, and you should make accountability at the local level. Give them the rights, make local audits, make them local implementation in charges, implementation viabilities, all these things are mattering. So it's not from top to bottom. Involvement is important, but it should be broken down into this process to make it more standards.
Once we have these goals defined and once we have a direction, so I think the nursing staff will be the first ones to respond to this. So because they work at the ground level, and the clinicians will understand the importance of having all these protocols in place because they can visibly see how it is improving. So then from the administrative point of view, we can always oversee the things and we can manage them in little tweaks here and there, support them with the resources and licensing issues and all, equipment issues, and then everything is in place.
It captures so many things. So the delay is not captured properly in our Indian markets more. Because the delay is the main cause for it. Clinicians are ready to care. We can protect, we can lifestyle the delay. Data is huge. Delay. Now, the delay concept is a metric that has to develop.
Delay in escalation.
Anything.
And delay in escalation or delay in triggering
Clinician gives not. It's not executed. Whatever. It can go 80 be down. Whatever is the implementation, the delay metric should be captured.
delay. So that lag behavior on each and every part will be checked periodically and we have to go there. So the goals and directions are defined now. So let me move on to this after compliance stage. So we have achieved compliance, we have gone through the accreditation process and everything is cool now. So that we can, whether should we go back to the normal of a sluggish nature or how can we really keep us motivated? So to move about, see with maintaining the review systems, meetings and all. So you taken.
It's a good question. This is, I really feel like that in the recent scenario, we had undergone through this 6th edition of NAVH in recent times. So in that, we have achieved one benchmark, and we are further achieving to the set of some part of the best part of that we are going to achieve it. So in this process, the main sustainability is also important to continually manner the standards and quality and the service. So that is most important to continue the four processes. So definitely plays a vital role to adopt the best out of. So I have seen in Guntur and Vijayawada that Guntur we are the first NABH oncology center. In fact, NABH accredited hospital, and the processes that we are following that is predominantly that is helpful to the patients and the service standards that we are following. The recent accreditation also we got the good result on that impact. That is what we felt that. So ultimately we'll measure that our NCs, how we are closing that NCs and how many NCs we received, but ultimately out of those NCs, how many actually what that need to be addressed really alarming. So these things ultimately post standardization, continuing the standards also toughest role from the administration perspective, no doubt in that. For that, staff also, stakeholders, concerned stakeholder orientation and the adaptiveness and the training sessions also very, very important to continue that manner. So in addition, now we are discussing about the clinical matters and so doctor given treatment and what is the cost-effective mechanism, whether it is right or wrong. The question rises. So when the question rises, so that is a sensitive part of it, of course. So for what we have to follow, as per the recent this thing standards, we have to measure the ethical management. We have to follow that. How we have to that's a sensitive matter. Patient counseling. So when you are giving a counseling to patient, you are giving the counseling to patient, and are you giving counseling to psychological counseling? Also plays a vital role. Yeah.
Sir, one question I want to ask. So actually, they have less time. So first, I want to share my experience. I am working as a state care consultant in the quality assurance program since 2015. Lot of challenges are we are facing in the government sector. So I want to ask you how to overcome the challenges. First, I want to tell you the challenges. What are the challenges we are facing? So first, we see the definition of quality. What is the quality? The quality definition we see the doing the things in the right way first time and every time where nobody is observing. That is very important. Then we have three components in the as per Domabedian model, that is the structure, process, outcome. Same way we have three components in the management also, that is the allocation of resources and optimal cloud utilization and customer satisfaction. So mainly we are facing three challenges. Those are, as you said, creating the responsibility in the staff, then accountability, then authority. These three are major challenges. We are facing these three challenges in the government sector. So in the allocation, if you see the right person in the right place in the right time for the right job. So right person should be placed in the right time, in the right place. That is the first challenge we are facing. Then accountability, maintain the accountability. This is the next, we are going towards the third segment, that is the commitment. Commitment is the major challenge. In the government sector, mainly a quotation, that is పని చేస్తే పని ఇస్తారు, పని చేయకపోతే జీతం ఇస్తారు. సో అలాగే సేమ్ ఇక్కడ హౌ టు క్రియేట్ ద అకౌంటబిలిటీ. జస్ట్ వీఆర్ రిమైండర్స్. Is there any tracker to give the reminder to the staff, task manager? Have you developed any software or tracker to give the reminders to the staff? Because quality is not a continuous improvement process. It is a continual improvement process. If you see the example, age and base. Age will increase always. Second to second minute. But we cannot improve the quality second to second minute to minute. Periodically only we can improve the quality. So to improve the quality, we have conduct the regular audits, regular assessment, capacity building trainings, and committee meetings and other activities. But is there any tracker to conduct the regular activities
and who monitor the activities like other indicators like productivity, efficiency, clinical care service quality indicator. Have you developed any tracker to maintain the sustainability after the accreditation process?
You said that almost nothing, but it's almost checklist as of now. In software also, there are not much improvement. As of now, many of the software are also in the early phases only. As you said, it is the responsible to create responsibility for every individual in the healthcare industry is very difficult.
So
We cannot expect all the persons all the day with the same instinct what one is having. So you have to continuously motivate them with the right appraisals. That is management aspect. The right managers to motivate their sub staff like that. Then only we can get much better results. And one more thing is only one thing when we refer once big quote about business transformative coach Carl Gaud. He said one technique, I cubed means intelligence incremental improvement. Okay, you can't get everything at a time. So you have to be intelligent, be in incremental phase. You have to show improvement. So it is a I cubed, I3 cube. Okay.
yes, sir. As you said, the motivation is the very important aspect. So there is one analysis that is the Pareto's analysis, alarming. So that is that says that this is the 80-20 phenomena. 80% of the problems affected due to the 20% business. If you address the 20% business, we can close the 80% gaps. These 20% gaps are problems of one gas are quite a few others. Remaining are the useful many. Same way in the organization also, 20% of the people are doing the 80% work, 80% of the only doing the work. 20%. How can we standardize the work? How can we design the same task as per their job chart? Can we measure that?
There are two things here, private and government. Government is centrally policy driven. To implement anything, you need a policy. By the time the quality terminology is changing. So now coming to private. Okay, let's not pay our advance far ahead, we are ready to accept this. The only thing is create a dashboard where you are shown as an outlier. The non-performance is shown as an outlier. Nobody likes to be an outlier in that. Right? Performance versus non-performance. Once you start showing as an outlier to public, automatically it should be setting it as a self-payment. Important.
We got a conclusion somewhere that
The final goal on is how do we sustain the direction?
Sorry.
How do we sustain this direction?
I would continue the same one that we have been discussing. If there is an automated tracker that is there, also here. So where we follow, we follow on all the regular basis. Where leadership has a kind of a context where leadership is supposed to take responsibility, ensure consistency maintains, go to the ground and ensure that this being followed up in a regular task rather than putting into a tracker kind of a thing. It mainly falls on the burden of the leader and ensure that the data that is being taken is looked upon and the results are being driven. Ensure the results are appreciated, are celebrated, so that the team who is collecting the data driven, result driven mechanism always shows a lot of participation and a lot of complete and meaningful outcome is what I can compare.
And said, sir, if you see the standard everything, the text must be sometimes based in the organization to improve the improve the satisfaction of the customer, improve the enhance the quality. So, if example, విజయవాడ నుంచి ఏలూరు రావడం గంట పెట్టంటే కార్లోనా బస్సులోనా బైక్ లోనా అని అడిగి వెంటనే మనం చెప్పొచ్చు ఈజీలీ మన వల్ల రాదు సేమ్ వే ఒక ఎంప్లాయీకి వర్క్ అసైన్ చేస్తున్నాం అంటే హౌ మచ్ టైం విల్ టేక్ కంప్లీట్ దట్ వర్క్ అనేది we define in the organization every employee is working 8 hours. You know why 8 hours?
activities, they have to be performed. Day-wise activity, monthly-wise activity, even if they have any, develop any app to measure the performance of the employee. Like, yeah, they calculate idle time. Employee monitoring apps are there, they calculate idle time, working time, and as per his job roles, job description takes time. There are employee monitoring.
Okay, thank you, sir. Thank you for this discussion on goal, direction, and sustainability. So we are slowly trying to move from good people to good systems, episodic excellence to predictable excellence. So that should be predictable. People who come here, so you should not depend on the time and day, and you should not depend on who is on duty. It should always depend on which system is on duty. Thank you so much for this panel discussion. Yeah, final statement from us.
This is the final statement. There is one statement in the polity, that is the mantra of polity. That is, if you can't measure something, we cannot understand it. If you can't understand it, we cannot control it. If we can't control it, we cannot improve the quality. First step towards the quality is the measurement. We are measuring lot of indicators. As per NABH, NQuas, other lot of programs are there. We are measuring the indicator. So how we are understanding the problem, how we are prioritizing the problem, how we are reviewing the problem, how we are taking the corrective and preventive action, the identified gaps that is more important. This is called PDCA cycle, time to check actions, kind of exercise we have to do. So a lot of quality indicators and tools we have to develop. We can develop our own tools and own indicators also. So thank you very much to our organizing team. Thank you, sir. Thank you everyone for this given opportunity. Thanks.
Thank you, sir. Thank you so much for the insightful session. And I request it's open to forum. I request all the audience. Any questions? Yes, sir.
Very good. My question, sir, you have mentioned there is a gap, consultant to HIS. So will AI replace that?
Pretty much sure. I think when it comes to cancer driven kind of thing, where M. Kumar knows this, where people who have lost their voice box, there is a AI driven kind of a mechanism where they're implanting a chip into the throat where the place of the voice box is there. They're able to speak and interpret in that kind of way. So that kind of mechanisms, yes, in future with AI kind of a power, I think we will be able to the gap between the consultant and the EMR. Yes.
Comes to the privacy, is it acceptable?
We have to make our system stronger. When it comes to IT, there's a huge gap of IT privacy kind of a thing, where when your systems are strong, if you see US healthcare, it is primarily dependent on EMR. If you will see hacking kind of thing, IT being your systems being hacked, so there is a different perspective which we don't know, which we are yet to think about. So if the systems are down, their hospital lighting is down, their DGs are down, everything is down. So they cannot even administer medication. So that is the kind of thing that has been established in US. When it comes to here, we are still in manual mode thanks to all the perspectives. Yes, maybe when the systems are strong and the ID has a very good kind of security, there's a big lot of things that we need to conquer. Where ID securities, ID systems, where there's a gray area that we need to work on. But when it comes to IT in the current context in Andhra, it is being looked on very, at a very lower level. There's a huge level of IT, right? Suvarna, which is also in a part of it, they can give a brief impact of how they can develop IT healthcare.
Sir, my next question to sir. Sorry, sir, I forgot your name. Sir, Nagesha, sir. Is number games plays a vital role in a plan? Sorry. Is number game
Next, information next we have the team. So that time we will have the one questions and get it to work. So very quickly, you time to be with
So much, sir. I request Dr. Harish please facilitate and Shivam. Please. Thank you so much, sir. Now I request Sri Adapa Vasubabu garu to please felicitate Sri Nageshwar Rao garu. Please, sir. Thank you so much, sir. Now I request Vasubabu garu to please felicitate Dr. Chakraborty garu. Thank you so much, sir. Now I request Dr. Bala sir to please felicitate Dr. Harish Gaurav. Thank you so much, sir. Now I request Rajarajan sir to please felicitate Sri Adapa Vasubabu garu. Thank you so much, sir. Please post the book. Thank you so much, sir. Sir, I think at this point in time, a cup of tea will make this event better. Am I right, guys? Am I right? Okay, let's have 10 minutes tea break and I request the delegates who have not completed the registrations and who have not collected their coupons, lunch coupons, it is available in the registration counter, so please collect. And another announcement also, they will issue the e-certificates who will sign the beginning and end of the sessions only. We will issue the e-certificates. So please be in session. Thank you so much. Have 10 minutes short tea break. Thank you. I request Kirandar to please entertain us.
Sir, audio quality, medium part of audio or కొంచెం నాకు ఇవ్వలేదు కదా సార్ నాకు ఉన్నటువంటి కూర్చొనిలో వచ్చింది వచ్చింది సార్ సార్ అక్కడ పౌజ్ చేసేసి అక్కడ మీరు ప్లే చేసుకోండి ఆడియో నేను ఇక్కడ నుంచి అక్కడ పౌజ్ స్క్రీన్ పౌజ్ చేసి అక్కడ మీరు లిరిక్స్ చూసుకోండి సార్ ఇక్కడ నేను మామూలుగా ఇక్కడ ఆడియో ప్లే చేస్తాను అది పౌజ్ లో పెట్టాను సార్ నేను నేను ఇక్కడ ప్లే చేస్తాను సార్ కాల్ చేసే కదా సార్ ఒక్క నిమిషం ఒక్క నిమిషం సార్ పెట్టారా సార్
everybody. Kachori masti.
అరే నీ ఎక్కడ ఏం చెప్తున్నాను ఓ వెళ్తున్నా
గట్టి మనసులు గాను పేరుకుదిరి మేఘ కురిసి పాడిరి కరుకైన గుండెలు చిరుజల్లు కురిసిరి తలవాటి తిరుగు చిరుగులాక చూసి మరి జీవితాలనేసి చెలరేగిపోయింది చిరుగాలి చెదిగే చిగురాసరే పెరుగట్టి మనసులో పొంగిపోనవా వెలువైన నొక్కిలంట పట్టడేదు చెప్పులకి నేల తల్లి వంటి మరద వెలుగుందనికే హృదయం నీకు ఒక్కరు మనసులో రాగం మనసున ఆకాశం మేలుకొలిస్తే మనలో తారలకి తలుపు ప్రతిభలో ఎవరికి విరిసిన ప్రతి పూతో గోపువేల మడి చేరే నదిలో ఉంది ఆకాశం Correct. కురిసిని కనవారి పిలుపుతో ఆశవాయే ఆశ
Wow, wow, wow. Super, Priyanka. Super, super. I'm proud of you.
We get the inauguration ceremony in the anthem. It is time to invite our esteemed dignitaries onto the dais for the ceremony lamp lighting. I respectfully invite Dr. Harmad Rao sir, Chief Executive Officer, Allur Sita Ramaraj Education Society, to please come onto the dais and occupy the chair, sir.
Thank you, sir. Now I invite Mrs. Sakshi Director, Sita Educational Society, to please come on to the dais and occupy the chair, ma'am.
Respectfully invite Dr. Chevron Srinivas Rao sir, Principal, Allur Sita Ramaraj Academy of Medical Sciences, to please come onto the dais and occupy the chair.
Thank you, sir. Now I request Dr. Babu Narayanan Garu, Caho, CHCO Chair, Chief Business Officer and Head of Quality, HOD General Medicine and Diabetology, Gem Hospitals, Chennai, to please come onto the dais and occupy the chairs, sir.
I request Mr. Rajarajan, sir, Group Chief Operating Officer, Allur Sita Ramaraju Education Society, to please come onto the dais and occupy the chair.
Thank you, sir. Now I request Dr. Santay Garu, Medical Superintendent, Asram Hospitals, to please come onto the dais and occupy the chair, sir.
Dr. Harish Babu, sir, Deputy Medical Superintendent, Head of Medical Services, Allur Sita Ramaraju Academy of Medical Sciences, to please come onto the dais and occupy the chair.
Mr. Ram, Chair, Hospitals, to please come onto the dais and occupy the chair. Welcome, sir. I respectfully invite our today's guest of honor, Dr. D. Srihar Rao, Chairman, AP Medical Council, to please come under the dais and occupy the chair.
I respectfully invite our today's chief guest, Dr. P. Ramesh Babu, Chief Cardiologist, Managing Director, Master Ramesh Hospital, to please come onto the dais and occupy the chair.
We welcome you, sir. Asatoma Sadgamya, Tamasoma Dhamma. Lighting the lamp is not just lighting up a flame, but instead it is lighting up a ray of hope and love. The bright flame will symbolize knowledge, enlightenment, experience, and hope. Now I request all the dignitaries on the dais to enlighten today's program by lighting the lamp. I request the organizing team to help. I request the organizing team to basically Thank you so much, sir.
Now I would like to call Miss Sivani and Geeta Krishna, students of Allied Health Sciences, for prayer song.
Request gathering to please raise for prayer song. Mahaganapatim manasa smarami. Smarami Mahaganapatim manasa Smarami Vasista Vamadevadi Vandita Mahaganapatim Smarami Vasista Vamadevadi Vandita Mahaganapatim Mahadeva Sutam Guru Gohanutam Mahadeva Sutam Guru Gohanutam Marakoti Prakasham Shantam Marakoti Prakasham Shantam Mahakavya Nataka Dipriyam Mushikavan Bhogatam Priyam Mahaganapatim Smarami Mahaganapatim Smarami Mahaganapatim Geeta and Shivani for the prayer song. Now I invite Dr. Cheprol Srinivasagaru, Principal, Ashram Medical College, to deliver welcome address. Please.
Good morning to all the assembled members here. Respected chief guest for today's occasion, Dr. Ramesh Babu, the Chief Cardiologist, Ramesh Hospitals, Vijayawada. Guest of honor, Dr. V. C. Herragar, Chairman, AP Medical Council, Vijayawada. Other distinguished dignitaries on the dais, off the dais, my dear colleagues, members of the press, a very warm welcome and greetings from Alluri Sita Ramaraju Academy of Medical Sciences. On behalf of Ashrams, it is our privilege and honor to welcome you all to the Ashram Caho Jeevan conference, focusing on healthcare excellence for small and medium hospitals. We are honored to have you today to share insight, best practices, and innovations in healthcare. I wish you all a good time as well as a productive discussions. Make the most of this opportunity given to you all to learn from each other and to share the future of healthcare. Thank you. Thank you for giving me this.
Thank you so much, sir, for your warm welcome.
This is now my privilege to invite Dr. Babu Narayanan Garu to give an introduction to Caho about its vision.
So when I was 29 years old, I just finished my MBBS and MD in general medicine, and I was so young at that time, 29 years. So first employment is with Vijaya Hospital. I think that most of you know Vijaya Hospital in Chennai, around the 900-bedded facility or so. So I joined there as an in charge of an intensive care unit because as a physician, I had some experience and other things in running intensive care unit for 1 month. I was shortly associated with the World Bank project on setting up poison centers across Tamil Nadu. After 3 or 4 months or so, the owner, Mr. Venkatarama Reddy, you know about the Vijaya Productions and other things, right? So he called me and said that, Babu, from tomorrow, you be the chief medical officer and medical director of this. I was shocked. At 29 years, a 900-bedded hospital, and I have to run the hospital. And that's because it's a trust hospital. If you say you are the medical superintendent or chief medical officer, then you have to look into everything. And at that time, it was around 38 years old, because I was associated with them then for 13 years. And most of, as you know, the Vijaya Hospital is the first multi-specialty hospital in Tamil Nadu and in Chennai before Apollo as well. So most of the physicians there, the clinicians are 60 plus and 70 plus. Think of them managing them, a 29-year-old graduate coming out, going to our first urologist and asking that credentialing and privileging, sir, have you got your MBBS certificate, sir? Right? Professor Chindaswamy. Babu, you think that I'm practicing urology for the past 40 years without MBBS certificate? So, but that is a kind of thing, right? But there, NABH came for my protection, right? Because under the guise of NABH, we can say that NABH has asked for this, NABH. Because at the end of the day, people doesn't see that how, senior doctor you are. At the end of the day, they will ask that, okay, your urology department is headed by so-and-so, what is credentials and privilege? How can I give a privilege for a professor who has been practicing and he is the first urologist of India, right? So, but however, that is how standards. Then came the bigger problem, right? We have established an NABH, we have got an NABH. What is there a system available for capacity building of our staff, for training of our staff? If I wanted to have an ICN, then what should I look for? NABH says that you should have an ICN. Then what are the credibility or credentialing or privileging of an ICN? I do not. Then one day, Caho came into the picture. Consortium of accredited healthcare organizations. So the motto of Caho is It is a registered society, and it is a registered society of accredited organization. Individuals also can become members. The main motto is that quality and patient safety. Or it is governed by missionaries, Dr. Vijay Agarwal, Dr. Lallu, Dr. Shankar, and Dr. Nari. The intention of Caho is to conduct training programs. Training programs on what? Training programs on CSSD, training programs of ICN, training programs of infection control practices, training programs on your quality management, training programs on your clinical indicators. So the intent of Caho is to run training program so that the individual hospitals which are going in for accreditation have the capacity of the resource person to adhere to the norms of the NABH. We have three major divisions. One is healthcare organization, second is your diagnostics wing, and quality professional wings. We have different forums. Name whatever the forum. Engineers forum is there, dietetics forum is there, global rehabilitation forum is there, innumerable forum is there, and all the specialists are members of it. What do? They create standards. They also conduct training programs. For example, CahoCon is happening, as Dr. Bala has showed us, CahoCon is happening in April 2026, 10, 11, and 12. While in GEM Hospital, while in work, we are collaborating with Caho to bring out laparoscopic standards. There is no India-specific laparoscopic standards, and we are releasing those laparoscopic standards. And Dr. Palmini, the owner of GEM Hospital, who is a very famous surgeon, he is patronizing that, and we are bringing that kind of standards. So the Caho brings in all these kind of resource persons together and build a system, capacity building of the organization. Once we have built up this organization, we were thinking that, right, we have reached out to all those major things. For example, group of hospital, chain of hospital, resource-rich hospital. What happens to our small healthcare organization? They constitute, as Mr. Anil was saying in the morning, 65 to 70% of your healthcare system is by your small healthcare organization, right? Which means that for every 100 bed, 65 beds are being contributed by your small healthcare organization. What do you mean by small healthcare organization? It is typically your 30-bedded to 90-bedded organization, which has been run by maybe a single hospital owner or a clinician. It would have developed into 50 beds or 60 beds. This is the problem. Then we thought that during our experience, we thought that there were a lot of these small healthcare organizations are closing down, either due to the complexity of the system, the kind of standards which it comes in, or don't have the resource person, have the technicalities to manage it. For example, they don't have a financial officer, they don't have an operation manager, they don't have a lecturer, a single person multitasking. A manager will be there, he will be multitasking. So we thought that there should be a movement for uniting this small healthcare organization. With that vision, this SHCO forum was formed. There is small healthcare organization. First headed by Dr. Rai, due to some untoward event, he expired in an accident, and now the baton is carried by us, the members of the SHCO wing. Our main intention is to capacity build, be compliant, collaborate, and credibility. We run two types of program. One is Jeevan and Boost is a webinar kind of thing. Jeevan is the program like what we are running here. Every week we travel across India and conduct program. Last week we were in Shillong, Meghalaya. We conducted the program. Next week we are in Pondicherry. So the aim of the program, how we can make this small healthcare organization self-sufficient, make it standardized so that our secondary healthcare sector can be strengthened, so that the reference, the treatment, the first contact of treatment is given in a proper way according to the evidence-based medicine, and then it is referred to tertiary care centers, right? Because right from the clinician who is attending the case at the periphery to the secondary healthcare center, to the tertiary and quaternary centers, if care is unified, then only the outcome can be achieved. This aim, we are conducting this Jeevan program, and I take the opportunity to thank the management of Asram and also the eminent chief guests who have come there. They are visionaries. They have built the organization of their own Ramesh hospitals. I mean, we heard a lot about it. I mean, they have done a lot in a healthcare field. I think they should guide us or they should guide how this small healthcare organization can thrive so that they can be self-sufficient so that our healthcare system is stabilized and standardized. Thank you very much for the opportunity. I once again take this opportunity to thank from the bottom of my heart for the hospitality rendered by Asram and my beloved friend, Mr. Rajarajan. Thank you very much. Thank you.
Thank you, Doctor, for outlining the mission and commitment of Caho towards healthcare quality and patient safety. Yes, sir. It's my proud privilege to introduce our guest of honor, Dr. D. Sriharirav Garu, an eminent radiologist from Tirupati and a distinguished leader in the medical fraternity with decades of dedicated service. He has held several prestigious positions, including chairman of the AP Medical Council and state president of IMA and IRI, contributing immensely to healthcare administration and professional excellence. A recipient of numerous national and state level awards, including Dr. A.K.N. Sinha Award and Lifetime Achievement Honors. He is widely respected for his commitment to medical service and community welfare. His tireless efforts in public health initiatives, medical education, and social service truly inspire all of us. May I now request our esteemed guest of honor, Dr. D. Sriharikaru, to kindly address the gathering.
Good morning, everyone. Respected Chief Guest, P. Ramesh Babu Garu, Pratidhi Velan Garu, Srimati Srinivas Garu, Babu Narayan Garu, Dev, and Rajaranjan Garu, Group of Chief Officers, Rammohan Garu, Chairman, Staff, Babu Hospital, Santai Garu, and other dignitaries on the dais, and the our state master state president and IMA national leader Sri Srinivas Raj Garu, IMA leader Sri Naresh Garu from Yamvaram, and distinguished patrons and esteemed CHO leadership, ashram management, doctors and administrators, nursing leaders, and my dear healthcare warriors. Good morning to all of you. It gives me immense pleasure and deep satisfaction to stand here today in Yeruru at Asram Hospital for a program that is not merely an event but a declaration of commitment. A commitment to quality, to patient safety, and to ethical healthcare. The theme healthcare excellence for small and medium hospitals touches the very backbone of Indian healthcare. Let us be honest, India's healthcare system does not survive only corporate giants. It survives and thrives because of small and medium hospitals. These are the institutions that create emergencies at midnight, deliver babies in rural towns, stabilize trauma teams before referral, and provide affordable care to families who cannot travel to the metros. That is the strength of this small hospital. They may be small in size, but they are enormous in responsibility and for many, quality and care was pursued as a concept without for their heart power. But that mindset has changed. Quality is not about the size of the. It is about the system. It is about accountability, documentation, and infection control, communication, and above all, a culture of state. A 50-bed hospital cannot be served ethical as a 500-bedded institute of this. systems are strong. That is why institutions like Caho and FHO wings are so important. They encourage excellence and set a powerful measures to smaller hospitals. YouTube deserves structured quality framework and YouTube can lead in standards. As chairman of the Speaking Council, I witnessed two realities as the brilliance of doctors and the vulnerability of clinical excellence is about in not enough. If document fails, if input control is weak, if communication breaks down, or if accountability becomes clear, even the most talented doctors can be turned into a systemic fail. Patient safety is not mere paperwork, it is respect of human life. When a patient calls to the hospital, they do not speak of the department or protocol. They see hope. When a mother brings her child for treatment, she does not verify accreditation certificate, she places the question and the question is stagnant. So we are practically facing challenge in time. And all of you know, with digital exposure, social media scrutiny, legal pressure, increased consumer awareness, and financial stress. In such an environment, strong system protect both the patient and the doctor. Ethical accountability and compliance are not academic. They are fields. Transparent system, reduce litigation, reduce violence against doctor, and strengthen the public confidence. And ethics is not weakness. It is a long-term strength. So I sincerely appreciate Asram and organizers for bringing initiative to Yellow. Healthcare excellence is not remain confined to the metropolitan city like Hyderabad, Chennai, and Delhi. Type 2 and Type 3 cities must become a role model. Why not Yellow? Why not Vijayawada and Rajahmundry? Why not Andhra Pradesh become a national example of ethical governance, patient-centric system, and transparent medical practice? To hospital owners and administrators present here, I say this clearly: investing in quality is not an expense. It is a risk insurance, reputation capital, and future sustainability. The hospital that will survive and grow in the next decade will not necessarily be the biggest. They will be the most different. I also want to integrate the business and allied healthcare professionals. Patient safety is not a doctor centric, it is a team centric. Teamwork is needed. And the nurse who double checks a medication, the technician who calibrates the equipment, the infection control function who audits the compliance, the silent prevent disaster every day. We must build system that empower them, not intimidate them. So the request we have is teamwork. Teamwork is our motto. And as a medical council chairman, our responsibility is not only regulating but guidance, protection, and ethical oversight. We stand on professional integrity, clinical responsibility, and public trust. Regulation alone cannot create excellence. Participation can programs like this encourage voluntary excellence, and voluntary excellence is always stronger and more sustainable than the efforts compliance. As all of you know, we have the powers of inspecting any hospital according to the section 20 in the class 4 and 5 of the registration medical Andhra Pradesh practitioners registration act. You can visit any hospital if you receive complaint anybody against the unqualified, unregistered doctors in our hospital or anybody trained in other system practicing in our. So be careful about this. And also we have the body to the anti-quackery committee also. We are preventing the anti-quackery committee. Recent days, it is the most problem for the growth of our hospitals. Healthcare is not merely a survey. It is a nation building. Healthcare corporation builds a strong economy, a safeguard hospital builds a confident society. A trusted medical system builds civilization strength. If our small and medium hospitals become quality driven institution, India's healthcare transformation the accident significant. Let us not wait for the crisis to default. Let us not wait for an incident to correct ourselves. Let us not wait for legal journalism to improve. Let us act promptly. Because when we prevent one infection, avoid one medication error, and document one problem, process correctly, we were not just saving money. We are saving life, protecting dignity and pursuing the trust of people. I congratulate you and I congratulate Asram and I congratulate every healthcare person who have chosen to be part of movement towards excellence. Excellence is not even an event, it is a habit. Let us make quality our habit, safety our culture, and ethics our identity. Thank you, Ananda. Jai Hind.
Thank you. Thank you, sir. It is my proud privilege to introduce our esteemed chief guest, the Chief Cardiologist and Managing Director of Astor Ramesh Hospitals, a visionary leader in healthcare. He has pioneered landmark initiatives such as EMR implementation, smart ambulance, tele-ICU services, and the Golden Hour program in Andhra Pradesh, transforming emergency and cardiac care delivery. An accomplished academician with MBBS, MD, and DM from AIMS New Delhi. He has an extraordinary clinical record, over 1.34 lakh coronary angiogram and thousands of such cardiac interventions, reflecting his dedication to excellence and patient care. A recipient of several prestigious national and international awards, he continues to inspire the medical fraternity through innovation, research, and compassionate services. May I request our district chief guest to kindly address the gathering. Sir.
Thank you for the kind introduction. Respected the dignitaries on the days of the days, my friends, I'm really honored and humbled by the invitation for this very meaningful initiative, which was started under the auspices of Ashram Management, Prati Devi Madam Management Team. You have heard Dr. Babu Narayan's experience and also Dr. Srihar Rao Gari, the glimpse of what is quality, why do you need quality, why everyone should adopt. I go a little older because I'm older than all of you. I'm 68. Okay, I started my MBBS in 1975, almost 50 years ago in Guntur Medical College. Then in New Delhi, I did my MD and DM. When I joined, you'll be hearing now some words like healthcare, excellence, best practices, right? Quality, continuous quality improvement. But when I joined MBBS, we used to have lessons on Sushruta, the greatest ancient surgeon, and Charaka, physician. So the people at my age, when we joined, we were thinking either to become physicians or surgeons, either Sushruta or Charaka, right? I have chosen to be a physician, and almost the first year I decided to become a cardiologist because there was a book on working Golwala cardiology, which was very fascinating, and he was considered one of the best cardiologists in the country. So I wanted to become almost in the first year itself. I decided not to go to US, practice in India, preferably in my hometown. So after that, after finishing my MDDM from Delhi, then I was thinking where to start the practice. Most of the people were going to go to Hyderabad or stay back in Delhi. But my uncle said, "This is your birthplace. You have to come here and you have to start your practice, serve the people here." When I started in 1988, again, there was no ventilator, there is no cath lab where I was trained, and I started with just 6 beds. Though I did not know anything about quality, though ISPA was initiated in 1985 by international healthcare experts to maintain quality standards across the globe. I didn't know anything about it. I didn't know anything even for few years after the NABH was started at the national level, which is one of the part of this, right? ISPA, under ISPA, you have NABH, you have JCI, we have Joint Commission International in Guntur, which we have. All these come under this ISPA, and I didn't know about it. But then we kept on. In 1996, we started first medium-sized hospital with 80 beds, right? So small is up to 50 beds and medium is up to 300 or 500 people. Say that. So I started first medium-sized hospital, and management was extremely difficult at the time. 80 beds, with few hundred employees and few medical officers, some consultants tried to gather from Hyderabad. That time it was extremely difficult to get the doctors from Hyderabad, right? Specialists and other. So I started, and then I started realizing the difficulty of running a hospital. The management part, the finance part, and then the nothing much we didn't know in 1996 about the quality parameters because we didn't hear. But we know that we have to do something as medical professional. We have to do the best to the patient, but no specific clear documentation, no proper guidance or training facilities for the nursing staff, which is the backbone in the hospital, well. And with all the limitations, we used to have problems. Like once and there used to be the some management of medication, some issues with management medication. And then some errors happen. And we used to face the music naturally because patients were always expecting more and there was no documentation to protect ourselves also. Then slowly we realized, and in 2014, we were on the first NABH accredited organizations in Vijayawada. And subsequently, we got in JCI in Guntur. And there was a lot of difficulty, probably many people must have faced. Most resistance comes from the consultants. They don't want to document, they don't want to be accountable with all these things. We took almost 3.5 to 4 years to train our people and to get this accreditation. First accreditation NABH in 2014. But the same quality champions, we shifted to Guntur and we could get in 3 years JCI, Joint Commission International, which was very reputed, and we felt that was one of the happiest days. And then we had a re-accreditation also. And then slowly, all the people, consultants, the nursing staff, initially they were worried about documentation, writing hours together, and they were thinking my patient care is getting affected. But then slowly they realized that it is a protective mechanism. It's a self-check, and you know what you are doing to your patients. Because what you have not documented, even if you say I have done, it is not believed by any standards. If you don't document, you haven't done it. Even if you say that I have done it, nobody believes. So these are some of the principles which change the whole gamut and of practice, and our staff, everybody started realizing from IMR, security people, nursing people, all these kappa and any incidents, reporting incident, they started realizing the importance. Though it was considered only for the major corporate hospitals, I'm not a corporate grade, we are medium-sized hospitals. We have in Ongole, Guntur, Vijayawada, Tiruvallur, Vemuvaram, we manage all these. So we realized the importance, and then we were the first to, you'll be hearing about Suvarna software. In fact, in 2017-18, our consultants team sat with Suvarna technical team from Hyderabad for almost 4 to 6 weeks, and we developed first electronic health record and then they commercialized data. So we were very much keen on developing these records. And also the other important thing is, of course, the quality and the best treatment to the patient. The second most important is the technology, right? So now even your NABH 6th edition or JCI 8th edition
with all 1,000 elements, 600 elements, everything. Now focuses on adoption of technology. One is to ease the operations, patient flows, management, and also the patient care prevention. And most important is digital health. So digitization of the processes helps. All of you are aware. You know, the telemedicine which was started, we started for the first time telemedicine being in Delulu, my chairman's native village in 2013. Telemedicine. After that, several telemedicine units across the private sector and many government hospitals, we started freely the telemedicine where we used to get the ECGs and we used to get it. So technology adoption is very, very important. We used to have telefax when even the fax machines, ECG, the villages, we used to get to our center when WhatsApp was not available, mobile was not available in 2000. And we used to give the treatment, we used to suggest the treatment to MBBS doctors, almost with the periphery, mandals, and that's our rural health program, Golden Hour program, that also started. So technology adoption is also part and parcel to practice medical profession. This is very, very important. Now coming, in the past few years, we are hearing the buzzword AI, deep neural network, recurrent neural network, machine learning, quantum computing, and hybrid quantum machine learning, right? And I'm very passionate about this AI, and we have the first artificial intelligent CT machine in 2011, second machine in the country, that is CT scan, which was, you know, it was not accepted by many cardiologists across the globe till 2021. Almost for 10 years, there was a lot of criticism about the CT cardiography. Now, you know, it is a global standard and it is a gold standard, not the invasive cath angiogram. Invasive cath angiogram has got a lot of fallacies, eyeballing, and you do it only when you need only for stenting. But we do now CT guided PCI. This is artificial intelligence. There is a digital twin wherein we see the CT FFR, we measure the pressure above the lesion and below the lesion. You know, there's a lot of confusion and mistrust in the Department of Cardiology in the society is because a three vessel disease, if a patient has got 80% disease in three vessel, from 1990s we have, and we send the patient that we give the CD to the patient to take a second opinion. So one cardiologist Hyderabad says medical management, one says multi-vessel stenting, and the other says bypass. Now with the technology and this intelligence and so-called digital, you have the measurement of the FFR, you have the human morphology, which is now making huge impact in therapeutic decision making. What are we were practicing by eyeballing the invasive cath angiogram? We were wrong 30% of the times because it is too weak. Now with the 3D and with the computational fluid dynamics, Navier Stokes equations, we measure the density, the viscosity, the velocity, and then we decide, yes, even if it is 80%, one vessel may be just okay with medical management. Second vessel you may have to fix up, or if all the three vessels are significant, you may have to go for 5%. So the technology, not only this, the quantum is making huge impact, oncology, the biomarkers, everything. So in healthcare, single cell atoms, regenerative medicine. You heard about AlphaFold 3. Protein unfolding is one of the biggest mysteries, and which the Google and isomorphic labs have got the Nobel Prize for AlphaFold 3. Now every protein literally in the humans, plants, animals, it can be very easily documented, and the genetic defects. What all you have? The ultra fast genome analysis now you have. Earlier, people used to take weeks together. Now, within 20 hours, you can get your genome assessed. What are the defects at birth? Now, with the sickle cell anemia, thalassemia, hexacell, all these now at birth, you can identify. You can do what is called CRISPR-Cas9, what is the protein that's a molecular scissors, where you can put, delete, insert, or see that the faulty DNA is repaired. So the technology is becoming so vast.
And it will be part and parcel of your medical profession. Just a stethoscope which we were holding decades ago is not sufficient. And now with the computer imaging, ResNet unit, ResUnit, you know the medical imaging, whatever you can see in the chest X-ray, the brains, even the hologram. The cardiac anatomy or brain anatomy, the surgeon operates, he can see the hologram. Three-dimensional picture, he can rotate and see what he's operating. Pixel, 4D pixels, very clear vision is there. So with all this technology now, with adoption, with all youngsters, you will see much different medical profession practice what we have done. But after, in the past, 10 years with the CTFF or CTCA and all, we are seeing the change. And in the next 5 years, it's going to be something phenomenal, explosive, and it's a disruptive innovation what is happening. So with all these things, of course, quality also becomes very, very important. These quantum calculations, algorithms, you can see that the mistakes, number of mistakes are minimized because it's so fast, right? So ultimately, the quality and it gives satisfaction as medical professionals. We were dreaming about becoming charkas or sushrutas, but then it was not possible. Now it is possible only with the international characters and people like Dr. Babunaran, he was in Assam last week and traveling. So people like him and people like JC editors, they were also traveling all over the globe and they were the mentors, they were giving us guidance. It's a much bigger service than what as medical professionals we do because they are spreading the knowledge, they are seeing that the organizations improve the quality of work and the patient care. So with this, I think I stop here because we have several talks in the afternoon. And once again, I thank the Asram management for giving me this opportunity. Thank you. If you have a
Yes, and now I request our Chief Operating Officer, Group Chief Operating Officer, and Dr. Raghunaran sir and Dr. Harish Chaudhary sir to please felicitate our guest of honor, Sri Hari Garu. I request the organizing team.
Thank you.
Leader in medical dedicated services.
Thank you so much, sir. Now I request our beloved CEO sir and our beloved principal sir to please felicitate our chief guest.
Chief Cardiologist and Managing Director of Asram Hospitals.
Thank you so much, sir. We request the one post for group. Thank you, sir. Thank you so much.
Now we have sponsor talk here. Technology today is not optional; it is foundation. We now invite our sponsor talk on Suvarna HIMS, EMR, and NABH certified solution. I invited Dr. Harita Pushpagaru, Project Manager, Suvarna Technology Staff. Harita Pushpagaru, Project Manager, Suvarna Technologies. This program is sponsored by Suvarna Technologies and Effort Plan. Next, we have after this we have sponsor talk from Effort Plan. So be ready. This program is sponsored by Suvarna Technologies and Effort Plan.
Good afternoon. Good afternoon, everyone. Good afternoon to all the deputies. I'm Dr. Harita from Suvarna Technologies. So I'm here to talk about a journey that all of us are going through. The shift from paper-based system to smart care delivery. So the question is no longer whether you want to go digital or not, but how to do it practically. So most of the hospitals are working hard. The doctors are dedicated. The teams are extremely committed to go digital. But then still, the system underneath is largely manual and not as digital as they would like to be. Now small facilities or the mid-sized hospitals or the hospitals can no longer depend on memory and they have to rely on the system. So being digital is no longer an option. So the quality today requires traceability, the database decisions, standardizations, etc. Manual systems not only increase the risk of clinical but also operational and also financial risks, and the safety becomes a challenge. And coming to ABDM, a unified digital health ecosystem is the new mission wherein the healthcare facilities are moving towards it and is now going to be a standard, and a unique health record, an ABA, is becoming a standard. And this is also not possible when you have the systems manual and not digital. So only when you become digital, a complete patient life cycle can be managed digitally. So starting from registration, consultation, admission, treatment, and follow-up. So a continuity of care, a longitudinal patient journey or an end-to-end visibility of a patient life cycle is possible only when you go digital. So to make the digital an option, a doctor adoption is as important as anything else. So for the doctor and doctor-centric digital consultation, there are a lot of things that are coming up. Being a healthcare IT vendor, we ourselves provide different types of things for the doctors to adopt. It could be the specialty-based templates, the voice to text, structured EMR, which is specific to each individual specialization, the local languages which can be, prescribed, and a quick treatment plan so that the typing is as less as possible for every doctor, and so that they can also adapt to digital EMR as much as possible. So we also have adopted to an intelligent clinical layer, to support the adoption as much as possible and support the clinical care. So it could be the drug-to-drug interactions or the AI-based clinical decision support, which we are going to talk about. And coming to the clinical decision support. For the clinical decision support, we have a separate application led by Mr. Prasad sir, who is also here. A quick short video where you will understand better how intelligent system or clinical decision support can help the operations today. Let me just switch to the.
Every day, hospitals face a critical challenge: prescription errors. These mistakes can cost lives and affect care quality. Did you know medication errors are among the leading causes of preventable harm? Introducing Drug Detail, a clinical decision support system designed to enhance your hospital's prescribing process. Drug Detail brings safety, intelligence, and precision to your fingertips. This innovative tool integrates seamlessly with your healthcare information or electronic medical record (EMR), supporting clinicians in real time. With Drug Detail, you'll receive drug interaction alerts to detect and flag dangerous combinations instantly. It also offers adverse drug reaction warnings, helping avoid preventative harm with context-aware risk codes. Pregnancy and lactation safety warnings ensure the protection of all patients when alerts. Plus, access unbiased, evidence-based drug information anytime. The drug program. Drug provides recommendations tailored to indication groups, with pediatrics and pregnant patients. Importantly, it also works without an EMR in the way pharmacists. During outpatient patient, nurses can verify risks into procedures and empowering organization. Here, for drug detail supports any claims.
So, clinical decision support, every decision I was talking about, is nothing but, it will support doctors as much as possible. So, you are already aware that, you are not supposed to prescribe any two drugs together. So, when you are trying to prescribe, the EMR automatically, intelligently, suggests that, hey, the two drugs that you are prescribing should not be prescribed together. A patient has a certain health condition. So, say for example, asthma, and a certain drug like ecosprin should not be prescribed. So it will give you a doctor support, clinical decision support, saying that these two should not be prescribed together. So like that, not only drug to drug, but drug to food, drug to lab, drug to disease, drug to allergy, drug to pregnancy, and drug to lactation. So all such alerts and clinical decision support is provided to the doctor. And not only that, Suvarna Technosoft has adopted to AI as much as possible with the evolving technology. So with the help of AI, today we have the voice to text summarization and structuring, where you simply speak and the clinical documentation is ready in a few seconds with the help of AI. Or the lab report smart scan, which is nothing but just simply scan your lab reports. The patient has got some papers of lab reports from outside or something. Just scan them and the entire structured data will be visible for you in your system. Or just upload the ECG or the X-ray image, and then you'll be able to have the interpretation right in front of you. Or the automated generation of various summaries like discharge summary, clinical notes, everything is possible with the help of AI. So we suggest that not only your OPD but expand to other departments also. Even if you're a mid-sized hospital, even if you're a clinic, we have the laboratory management, daycare, teleconsultation, pharmacy management, IPD, and daycare also, where you can have a single unified solution running your hospital, clinic, or a center. So these days expectations have also increased. So they would like everything to be digital. So previously, any of the patients for any of the health records, they would search through the pile of papers. But nowadays, they're searching through mobile. All of them, including all of them. All we do is go through the mobile. So similarly, the patient's expectations are also raising. The patient mobile app, they want their reports to be delivered on WhatsApp or via SMS. So they want the video consultations, teleconsultations. Everything is possible only when you. So all this is possible only if you adopt to the latest technology and go digital, and the manual process that we have been following throughout the years would not work anymore. So coming to analytics or decisions, what you cannot see, they say you cannot improve. So all the decisions are possible only when you have everything documented digitally. So you will have the reports, insights, everything, summaries, in terms of financial, clinical, everything, only possible only if you have everything documented digitally. So we suggest that you start small, not all together at once that you go live with, but start small, start incrementally, but go about it in a phased manner, and start with billing appointments or introduce, first OPD, then IPD, like that. Go about in incremental manner, have a roadmap, and start your adoption slowly. So once you have adopted to the digital, or EMR or clinic management, whatever it might be, you see the improvements yourself. So it could be your increased revenue, it could be your reduced prescription errors, increased patient satisfaction, or whatever it might be. You'll see the improvements yourself. And last but not the least, Suvarna Technosoft has been in the industry of healthcare IT since last 26 years and mainly focused, improving the standards with various solutions to support the hospitals, clinics. Suvarna Technosoft is run in 1,000 to 15 bedded hospitals with multiple branches to even a doctor, single doctor led clinics. So we are here to support you in your digital journey as much as possible, and thank you for the opportunity.
Thank you, ma'am. So much. And now we have another sponsor talk from Effort Plan. We now move to our sponsor talk by Effort Plan. I invited Srimati Lata. Sorry, I invite Ankit sir. Please come on the stage.
There is a small announcement to all the participants. We have placed 2 lucky tip boxes outside the registration counter, and the people who are having their visiting cards, you can place their in lucky tip, and students also can participate in this lucky. Those who are not having any visiting cards, you can write your names and place them in the lucky. Thank you. During the lunch break.
Hello everyone, good afternoon, and it's an honor to be here today. I would like to thank the Caho Jeevan members, esteemed hospital owners, and the Asram Hospital leadership team. Today I would like to talk about the financial hospital problems what hospitals are facing nowadays is that margins nowadays are shrinking, receivables are delayed, and out of pocket expenditures are still to 80% of patient payments. So, today I want to speak about one thing, that is how we can strengthen the hospital financial health without increasing patient burden. Let's talk about the core problem for the hospitals. The core problem for the hospitals is revenue challenges, rising operational costs, margins declining day by day, insurance payments delays, underutilized labs and pharmacies. This is where the main problem comes in. It is because of the competitors outside giving high discounts on the lab and pharmacies, where hospitals are not able to compete with the discounts because of the trusted medicines available at the hospital and procurement inefficiencies. Also, non-performing pharmacies inside the hospitals, due to the pharmacies outside are giving a lot of discounts, let's say 20%, 30%, and hospitals are not able to provide those discounts. because of those trusted medicines which we used to provide to the patients. So Afford Plans First is not just a revenue realization and retention program, it also helps patients to retain cashbacks, get the cashbacks on each and every transactions, and provide repeat users to the hospital and gives loyalty and privilege to the. It feels like privilege for patients to be in the hospital. It is managed by the financial counselor which we used to place at the hospital. Moving to the next, it helps increase revenues for the hospital. How does it help? Improve per patient realization, increase pharmacies and labs, discount elimination. What I have just talked about because of the discount which outside labs and pharmacies are giving. We are fighting with the 20 and 30% discounts which labs like online completers, pharmacy, healthians and others are giving outside with just 10% or 5% of the cashback which hospital provides to the patients for each and every transaction which patients makes at the hospital on the Afford Plan First program. We also provide wellness offers to the patients. We help patients with embedded insurance and provide at-home services like care and pharmacy. Afford Plan First is delivering the impact. We are currently have partnerships with 100 plus hospitals with on an average adding 10 hospitals every month with a capacity of 42,000 beds and 11 lakh families are currently with us. Moving to the next slide is how does Afford Plan First works? It's a physical model, gets patient to spend in hospital in just 1 minute. How does it work? Patients at the hospital or comes to the hospital. Our financial counselors are placed there. They help patients to navigate to the right place and register them on board to the first platform. Patients will get a link and downloads the app, completes the KYC, verified their KYC, and moves to the billing desk. Here we have our QR codes placed where patients can make the payments using QR codes for online payments and cash payments at the hospital home. On each and every payments, patient will get some cashback which they can use in the next visit or in the next touch points. Let's say when patients make the payment for OPD, they can use it next on the lab or pharmacy. On those transactions as well, patients will earn some cashback and this cycle repeats, and goes on repeat. This is how we maintain the loyalty and retention of the patient to the hospital. This also improves the IP to OP billing and OP to IP billing for the hospital. And settlements are on T+1 day basis, no more delays. Plug and play advantage for your hospitals. We give the full control over innovation to the hospitals. It is database backed. Data is secured, completely secured with Afford Plan and with hospital only. No other hospital can see your data. In-house tech. We have in-house tech. Nowadays, hospitals are not able to, some hospitals are not able to build their apps. We are there. Efforts that in the integration, plug and play model, zero time for the integration for the app. We are here. Moving to the next. Is the next problem, the big problem for hospitals nowadays is also procurement. Procurement optimized with ProCalix. We have another platform called ProCalix. For ProCalix, I would like to ask my friend Karneshwaran to come and explain more about ProCalix, how ProCalix helps and what it.
The hospitals face the major cost effective on the purchase of medicines. It's very rare that hospitals often negotiate with the pharmacy suppliers. Now, this is one of the platforms where we connect the manufacturers, and the end users of the hospitals. The manufacturer phase, the manufacturer and later on, it will be very much difficult for them to come down to any places and give a quotation to the hospital. Larger hospitals, the same medicine purchasing for 5 rupees, the other would be purchasing for 8 rupees. So it is a platform which connects both of them. And you can see like what is the price and am I buying the right price? How many medicines are purchased at the right price? What we do is you can also see here. We have many pharma companies in this way.
Hello. Hello, mic testing. Hello, mic testing. పెట్టారు. ఇప్పుడు లంచ్ తర్వాత చికెన్ పెట్టారు, పెట్టారు. నేను తిన్న తర్వాత నేను నిద్రపోకుండా మీరు చూసుకోవాలి, మీరు నిద్రపోకుండా నేను చూసుకోవాలి. సరేనా? ఆ వెనకాల కొంచెం ముందుకు వస్తే మీరు నిద్రపోవట్లేదని నాకు రాజరాజన్ గారు అందరూ తెలుసు కదా. రాజరాజన్కి మన ఇంట్లో చిన్నపిల్లలు ఉన్నారు అనుకోండి, ఒక పిల్లడు ఉన్నా కూడా ఆడపిల్ల డ్రెస్ వేసి ఫోటోలు తీసుకుంటారు. తర్వాత వాళ్ళకి నెహ్రూ గారు లేదా గాంధీ గారు లాగా వేషాలు వేసి ఫోటోలు తీసుకుంటారు. వాళ్ళకి ఆనందం పెద్దవాడు. రాజరాజన్కి నన్ను చూస్తే అట్లా ఒక ఫీలింగ్. నార్మల్గా వచ్చి మాట్లాడతారంటే బాహుబలిని యాక్ట్ చేశాను. రాజమౌళి గారికి 5 ఏళ్ళు పట్టింది బాహుబలి గారు. ఇప్పుడు నేను 15 నిమిషాల్లో బాహుబలిని హెల్త్ కేర్ రెండింటిని కంపేర్ చేసి చెప్తాను. ఏమైనా న్యాయం? టైం అయిపోతుంది. 10 నిమిషాల్లో మాట్లాడినట్టు బాబు గంట 10 నిమిషాలు చేస్తాయి. ఇంకొంచెంలో బాబు గారు కూడా నిద్రపోయేటాడు. Sorry, Babu, with the permission of Caho, I will talk in Telugu because my linguistic appeal in Telugu has gone down tremendously after shifting to Chennai. Okay. So wherever I am comfortable, I speak in English. When I am not comfortable in Telugu. Telugu matladachu kada, all of you follow Telugu, right? Telugu matladna, English lo. Telugu. Good. Both these under English lone kada. Sorry. English. Okay. So, ఎంతమంది చూసారు బాహుబలి సినిమా? అందరు చూసారు. ఇప్పుడు బాహుబలిలో మాహిష్మతి అని ఒకటి ఉంది. ఏంటది? దాన్ని దేంతో కంపేర్ చేయొచ్చు? ఎందుకంటే మన హాస్పిటల్ కూడా పెద్ద సామ్రాజ్యం. కరెక్టా? ఇలా ఎవరో తెలుసా? తెలియదు. వీళ్ళే ప్రొడ్యూసర్స్ బాహుబలి. ఏ ఇన్స్టిట్యూషన్ కి ఫండింగ్ చేసి ఆ ఇన్స్టిట్యూషన్ ని మొదటి ట్రిక్ పెట్టిన వాళ్ళని ఎవరు గుర్తుపెట్టుకోరు, వాళ్ళ మిషన్ కూడా గుర్తుపెట్టుకోరు. ఇదే ఫస్ట్ ఫిలాసఫీ ఇన్ హెల్త్ కేర్ బై ది ఫెయిల్. ఎప్పుడైతే కనుక వాళ్ళ కొంచెం ఎవరైనా ఒకళ్ళు మొదలు పెట్టినా కూడా అందరూ పట్టండి వైరస్. ఓకే, అప్పుడే మీరు నిద్రపోవట్లేదు నాకు తెలుసు. ఎందుకంటే ఆ మొదటి స్టోన్ పెట్టే వాళ్ళ మిషన్ మనం క్యారీ అవుట్ చేసినంత వరకు అది ఒక లెగసీగా ఉంది. వాళ్ళు మర్చిపోతే అంతా మర్చిపోతుంది. ఏదైనా మర్చిపోయిన తర్వాత మళ్ళీ ఇంకో బాహుబలి రాలేదు. ఈవిడెవరు? మీ హాస్పిటల్ ఎవరు? మేనేజింగ్ డైరెక్టర్ ఓనర్. మాహిష్మతిని బ్రహ్మాండంగా నడుపుతా వచ్చింది. యాక్చువల్గా వాళ్ళ ఆయన మాహిష్మతి అనేది ఒక సిస్టమ్స్ తో కూడుకున్నటువంటి ఒక సామ్రాజ్యం. అందుకని కొన్ని వేల సంవత్సరాలలో ఆ సామ్రాజ్యం నడిచిందని మనకి సినిమాలో చెప్తారు. It has been there for several hundred years. But there was a system, there was a rule. They used to go by the rule book. So the rule book said, a man, if he is not physically, he's differently able, then he cannot run the. So his husband has to give up his kingship to her, and she was made the queen of the place. So they followed the system, they followed the rule and the rule book of her Maheshwari. And she ran Maheshwari fantastic. అవునా? ఒక తప్పు చేసి లేకపోతే 3 గంటలు అయిపోయేది, 6 గంటలు పట్టింది. కరెక్టా? ఏంటి ఎవరు చెప్పట్లేదు? ఈజ్ ద హీరో. మన స్టార్ డాక్టర్స్ లాగా ప్రతి హాస్పిటల్లో స్టార్ డాక్టర్ ఉంటారు. ఆయన అంటే అందరికీ ఆయన ఎవరు హేట్ చేయరు. నేను అంత ట్రాన్స్పరెంట్, అందరికీ రెస్పెక్ట్ ఇస్తాడు, చాలా మర్యాదపూర్వకంగా ఉంటాడు, మంచి నాలెడ్జ్, మంచి హ్యాండ్స్. ఆయన చూస్తేనే సగం రోగం పోతుంది. కరెక్టా? ఆయనకి ఈక్వలెంట్ ఈయన కూడా నాలెడ్జ్ లో అన్నింటిలో. బట్ నేను అని అహం ఉంటుంది. వాళ్ళకి కావాల్సింది ఎట్లాగైనా చేయించుకుంటారు. హెచ్ఆర్ మేనేజర్, సారీ బ్యాడ్ హెచ్ఆర్ మేనేజర్, మంచి హెచ్ఆర్ మేనేజర్ బ్యాడ్ హెచ్ఆర్.
ఎవరు మంచి మేనేజ్ ఇది ఎవరిని ఫోకస్ గా నేను ఈవిడెవరో తెలుసా ఆయన పెద్ద మార్కెటింగ్ మేనేజర్. ఎవరు తప్పు చేసినా పాప ఇతరులే పట్టుకుంటారు. ఈవిడ చూడండి, ఈవిడ ఏ తప్పు చేయలేదు, బట్ ప్రపంచం అంతా ఈవిడ నానా హింసలు పెట్టింది. 25 ఏళ్ళు 30 ఏళ్ళు బాహుబలి మళ్ళీ పెద్ద వచ్చేటప్పటికి వండలేదు. అంతే మార్కెటింగ్ మేనేజర్ కూడా హాస్పిటల్ ఏం చేస్తారంటే, అరే పేషెంట్ చచ్చిపోయినా కూడా ఆయనే పట్టుకుని తిడతారు, నువ్వు మంచి పేషెంట్ తీసుకురావట్లేదు. బిజినెస్ డెవలప్మెంట్ తగ్గితే ఆయనే పిలుస్తారు. ప్రతి దానికి మార్కెటింగ్ మేనేజర్ అని ఏర్పాటు ఒక స్కేప్ బోర్డు ఉంటాడు. ఐ థింక్ మార్కెటింగ్ మేనేజర్ నెక్స్ట్ నా మీద పాట పాడాలి. ఓకే, వీళ్ళు నాకు బాగా క్లోజ్ హార్ట్కి, ఈవిడ వీళ్ళు కూడా. మన నర్సెస్ ఏది ఆశించరు, ఏమి ఆశించరు. ఎవడు తిట్టినా పడతారు, ఎదురు చెప్పరు. కానీ అవసరం వస్తే న్యూ ఇయర్ కి ముగ్గులు వేయాలన్న వాళ్ళే అర్ధరాత్రి పేషెంట్ చచ్చిపోతాడు, కన్సల్టెంట్ రాడు, వాళ్ళే నిల్చుంటారు, ఆడపిల్లలేదు. ఫేస్ చూడకుండా చెప్పారు, ఎందుకంటే వీళ్ళు ద మోస్ట్ లాయల్ పీపుల్. ఏమి ఎదురు మాట్లాడరు. బాగా వాన ఉప్పెన వచ్చినా కూడా మీ అందరికీ తెలిసి ఎవరో కథను ఉంటాడు ఇన్స్టిట్యూషన్ లో, అతను వెళ్ళి చూసుకుంటాడులే అని. అలాంటి క్యారెక్టర్. అందుకనే నేడలోనే అని చెప్పేయగలరు కట్టప్ప. కరెక్టా? ఉన్నారా మీ ఆర్గనైజేషన్ ఉంటాడు? ఉన్నారా? ఆయన ఇది చాలా ముఖ్యమైన క్యారెక్టర్. ఎవరు తెలుసా? ఎవరు పేరేంటి? కుమార్ రాజానా? కుమార్ రాజా ఎవరో తెలుసా? ప్రతి మేనేజ్మెంట్ వాళ్ళకి ఇష్టం లేకపోయినా చుట్టాలు పెట్టుకుంటారు. నిజమా కాదు? అంటే వాళ్ళకి చెడ్డోళ్ళు కాదు, ఏమీ తెలియదు, ఏదో తెలుసుకోవాలనుకుంటారు, అర్థం వస్తుంది. వాళ్ళని తీసేయలేరు. తీసేస్తే ఓనర్ సీట్లో అన్నం పెట్ట, ఈయన ఓనర్కి ఇంట్లో వండడం బెటర్. బట్ వాళ్ళు చెడ్డోళ్ళు కాదు, బట్ వాళ్ళని చూస్తే అందరూ భయపడరు. నేను చెప్పిన ఇవన్నీ కరెక్టేనండి. చెప్పండి. ఈరోజు అంటే సిఇఓ లేకపోతే నాలాంటి కన్సల్టెంట్. అయిపోయింది మొత్తం సినిమా పావుగంట. అలా గంభీరంగా ఎప్పుడు స్థితి సంపదలతో ఉండదు అని హాస్పిటల్ స్టార్ట్ చేస్తుంది. బట్ నిజానికి ఏమవుతుంది? ద ఫ్యాక్ట్ హాస్పిటల్ స్టోరీ ఇస్ లైక్ వెరీ సింపుల్. ఫస్ట్ 5 years వాళ్ళు స్టార్ట్ చేయగానే గోల్డ్ అంత ఫండ్స్ వస్తాయి, బ్యాంకులు ఇస్తారు డబ్బులు, ఫ్రెండ్స్ ఇస్తారు, వాళ్ళ ఓన్ మనీ పెట్టుకుంటారు, అడిగిందల్లా చేస్తారు, బ్రహ్మాండమైన ఎక్విప్మెంట్ కొంటారు, బ్రహ్మాండమైన ఇన్ఫ్రాస్ట్రక్చర్ క్రియేట్ చేసుకుంటారు, మంచి మంచి డాక్టర్లు తీసుకుంటారు, అగ్రెసివ్ గా మార్కెటింగ్ చేస్తారు, అగ్రెసివ్ గా ప్రమోషనల్ యాక్టివిటీస్ చేస్తారు, మంచి గ్రోత్ చూపిస్తారు. నెక్స్ట్ 5 years ఆ గ్రోత్ అయితే చూపించారు కదా, ఆ తర్వాత ఏం చేయాలని తెలియదు. పేషెంట్స్ వచ్చేస్తారు, ఎంప్లాయీస్ ట్రైనింగ్, కొత్త ఎక్విప్మెంట్ తీసుకోరు. ఈ 5 ఏళ్ళు ఎలా జరిగినాయి అలాగే జరుగుతూ పోతా ఉంటుంది. పాత ఎంప్లాయీస్ వెళ్ళిపోతారు, జీతాలు పెంచలేదు, ఇన్ఫ్రాస్ట్రక్చర్ డెవలప్ చేయం, కొన్న ఎక్విప్మెంట్ పాత అయిపోతాయి, ప్రాబ్లమ్స్ వస్తూ ఉంటాయి. ఒక రకమైనటువంటి ఆపరేషనల్ కియాస్ జరుగుతూ ఉంటాయి. అంటే ఏం చేయాలి, ఏంటో పేషెంట్ బెడ్ లేదంటారు వాళ్ళు, ఒక చోట ఏమో నీళ్లు రావట్లేదని, ఒక చోట ఏమో డాక్టర్ వచ్చి చూడలేదని, ఆ స్పెషలిస్టే లేడు, సిటీగా పంచాయతీ లేదు, బిల్డింగ్ లో ప్రాబ్లమ్, ఇట్లా chaotic సిచ్యువేషన్ వస్తుంది. ఎందుకంటే వీ హ్యావ్ నాట్ మేనేజ్డ్ ఇట్ ప్రాపర్. ఇంకా 5 years అయిన తర్వాత ఇంకో 5 years అయ్యేటప్పటికి ఏమంటే ఇది ఇంకా యాక్చువల్గా ఈ 5 years 10 years అయిపోయింది, అంటే ఇంకా కూర్చుకుపోయింది. 3-4 years గ్రోత్, ఆ తర్వాత ఒక 2-3 years ఆపరేటింగ్ టెస్ట్, తర్వాత ఒక 2-3 ఏళ్ళలో 10 ఏళ్ళు వచ్చేటప్పటికే స్టాగ్నేట్ చేస్తుంది. ఆ తర్వాత ఇన్స్టిట్యూషన్ గ్రో అవట్లా, డబ్బులు ఉండవు, అదే డబ్బులు కానీ అందరికీ ఇంక్రిమెంట్స్ ఇస్తా ఉన్నారు. ఎలా జరుగుతుంది? ఎక్విప్మెంట్ కొత్తవి కొనలేదు, బ్యాంక్స్ లో లోన్ ఇవ్వరు. దీనికి ముఖ్యమైన కారణం ఏంటి? ఎందుకంటే సిస్టమ్ ఓరియంటెడ్ గా కాకుండా పర్సన్ ఓరియంటెడ్ గా మనం హాస్పిటల్స్ రన్ చేస్తాం. అంటే నేను స్పెసిఫిక్ గా కార్పొరేట్ హాస్పిటల్ దృష్టిలో పెట్టి చెప్పట్లేదు, స్మాల్ అండ్ మీడియం హాస్పిటల్స్ గురించి జీవన్ ప్రోగ్రామ్. కాబట్టి ఈ చిన్న చిన్న టౌన్స్ లో ఏదైతే హాస్పిటల్స్ ఉన్నాయో వాళ్ళు సిస్టమ్ ఫోకస్డ్ గా కాకుండా ఇండివిజువల్ ఫోకస్డ్ గా ఆర్గనైజేషన్స్ నడపడం వల్ల ఇట్లాంటి ప్రాబ్లమ్స్ వస్తాయి. ఇంకో ముఖ్యమైనది ఏంటంటే దిర్ ఇస్ నో సక్సెషన్ ప్లాన్. అంటే ఒక డాక్టర్ గారు, సర్జన్, ఒక ఈఎన్టీ స్పెషలిస్ట్, లేకపోతే ఆప్థాల్మాలజిస్ట్, లేకపోతే జనరల్ ఫిజిషియన్ 20-bedded హాస్పిటల్ 30 ఏళ్ల క్రితం స్టార్ట్ చేసి దాన్ని 50 బెడ్లుగా 70 బెడ్లుగా చేస్తాడు. కొడుకు నేను డాక్టర్ చదివినా కూడా నేను చెన్నైలో బెంగళూరులో సెటిల్ అవుతాను, లేదా నేను యుఎస్ లో సెటిల్ అవుతాను. ఈయనకి 65 ఏళ్ళు వచ్చేటప్పటికి ఇప్పుడున్న రూల్స్ రెగ్యులేషన్స్ కి రన్ చేయి. అర్థమైందా మీకు? సో అలాంటి పరిస్థితి వచ్చినప్పుడు ఆ సక్సెషన్ ప్లాన్ అనేది లేకపోవడం వల్ల ఇవాళ చాలా చిన్న చిన్న హాస్పిటల్స్ అన్ని కూడా ముయ్యబెడతా ఉన్నాయి. కానీ ఆ సక్సెషన్ ప్లాన్ అనేది, ఫర్ ఎగ్జాంపుల్ టాటాస్ కి ఫ్యామిలీ రన్ చేయదు. ఫ్యామిలీ రన్ చేస్తుందా? ఎగ్జిక్యూటివ్ సిస్టమ్ క్రియేట్ చేస్తారు, ఆ సిస్టమ్ రన్ చేస్తారు, అది ఎవరైనా అవ్వచ్చు. అలాంటి సిస్టమ్స్ మనం చిన్న హాస్పిటల్ అయినా కూడా రన్ చేయొచ్చు. నార్మల్ గా పీపుల్ ఏం థింక్ చేస్తారంటే గ్రోత్ అంటే మార్కెటింగ్, మార్కెటింగ్ ఉంటే గ్రో అవుతుంది. ప్రాస్పరిటీ అంటే ప్రైజింగ్, అంటే డబ్బులు కొంచెం తక్కువైంది అనుకుంటే ఎవరో వచ్చి చెప్తారు, అదే మన రిలేటివ్ వచ్చి చెప్తాడు పక్క హాస్పిటల్లో మనకంటే 20% ఎక్కువ, మనకు కొంచెం ప్రైస్ చేస్తారు. ఇమీడియట్ గా ఒక 20% రైస్ చేయగానే నెక్స్ట్ మంత్ ఇంకో 2 లక్షలు 3 లక్షలు పెరుగుతుంది. ఆహా, ఇదే కరెక్ట్ స్ట్రాటజీ అనుకుంటారు. తప్పు. ప్రాస్పరిటీ ఇస్ నాట్ ప్రైసింగ్. సస్టైనబిలిటీ అంటే ఏమనుకుంటారంటే 68 స్లైస్ సీటీ ఉంటే సస్టైనబుల్, ఇంకో హాస్పిటల్ బిల్డింగ్ కట్టేద్దాం, వచ్చిన పక్కన ఒక కార్పొరేట్ లాగా ఒక రూల్స్ తో కడదాం, ఏసీ పెట్టుకుని అనే ఆలోచన. సో సస్టైనబిలిటీ ఇస్ నాట్ యువర్ బిల్డింగ్స్ అండ్ టెక్నాలజీ. సో వాట్ ఆర్ దే? నార్మల్ గా హాస్పిటల్స్ లో ఏం జరుగుతుంది? ఈ ఫౌండర్ ఎవరైతే ఉన్నారో ఈ స్మాల్ హాస్పిటల్స్ లో ఎక్కడైతే ఉన్నారో వాళ్ళే హెచ్ఆర్ మేనేజర్, వాళ్ళే సిఇఎఫ్ఓస్, ఓకే, వాళ్ళే ఇంప్లాయింట్. సింపుల్ ఇష్యూ చెప్తాను. ఓకే, దర్ ఇస్ అ వాటర్, ఎక్కడో ఒక లైట్ అలాగే కూర్చాయి, ఎవరు వెళ్ళి ఆ ఎలక్ట్రికల్ మేనేజర్కి చెప్పడు, వాడు చూసినాడు, వాడు వెయిట్ చేస్తా ఉంటాడు ఓనర్ రాగానే. ఆ ఓనర్ పాపం ఆయన ఇంట్లో ఏదో క్లీన్ వచ్చాడు, ఇది రాగానే సార్ లైట్ అలాగే అంటే వీడికి మార్కులు పడతాయి. ఓహో, చూసారా వీడు అంత చక్కగా పనిచేస్తున్నాడు. ఆ లైట్ లేకపోవడం నలుగురు పడ్డారు, వాడు చూస్తానే ఉంటాడు, ఆయన ఏం చేయాలి? ఈయన ఇమీడియట్ గా ఎలక్ట్రీషియన్ ముందర వ్యాన్ పని నుంచి తీసేయాలి, పంపించాను. ఎలక్ట్రీషియన్ సార్ 2 days ago itself I wrote to the stores. Stores fellow was called. Stores fellow said, sir, 2 days before itself I wrote it to purchase department because I don't have the staff. Call the purchase said I spoke to I gave the thing to PO to the administrator to sign. Administrator called. He says, sir, I signed it and sent to the finance manager. Call the finance manager. Sir, how can I give 120 rupees for 2 light without your signature? Now, who should be removed from the hospital? Tell me, who should be removed? When there is no process, there will not be any efficiency. So systems have to be tested, whether it is small or big. Tell me one thing, if there's a small town, mark in the book, any systems, and much in the hospital. But the gentleman in that small town will go in 5 series BMW. Why he needs? When you need a 5 series BMW, okay, you should also ensure that the same quality of standards be maintained in the hospital. So what is growth according to me? Growth is nothing but winning the trust. Growth is trust, nothing else. And how do you build this trust? First is empathy. I'll tell you a simple thing. I worked in a hospital in Chennai. Okay, this is a huge hospital. Vijay knows, everybody here knows. Okay, it's a 7-star hospital. Rajarajan was also a part of that hospital. They could get doctors, nurses, technicians from across Chennai. Name who came and joined. This is a neighborhood hospital where I was the CEO for some time. When I was the CEO, only that new hospital was started. Not a single person joined. Not a single doctor moved. Because of the respect, no, not a single patient we lost to that hospital because of the empathy of the founder of that person. The founder died. The son is the legacy, who owns the legacy. The founder died. The founder bought the brightest of doctors and gave them life. They were so loyal to him. The patients, when the patient leaves the hospital, he comes to his room and says, "Sir, my bill is 50,000 rupees. He says, calls the manager and says, "Make it 40,000. Then he again, the man thanks him, and when he moves out of the room, at the door, he stops him again and calls him back and says, "Bus பணம் இருக்கா? இன்னொரு 2000 கொடுங்க, எல்லாரும் சாப்பிட்டு இந்த பஸ் ஏறி போகும். Sorry. అందరూ 2000 వేయాలి చేతిలో అందరూ భోజనం చేసి బస్సులో వెళ్ళండి లేదా కార్ తీసుకున్నారు ఈ పేషెంట్ ఇంకా ఎక్కడికి వెళ్తాడు నిజంగా అతని దగ్గర డబ్బులు ఉండవు తినడానికి అది ఎంపతి ఆ ఎంపతి ఇలాంటి చోట చాలా ఇంపార్టెంట్ నేను చెప్తున్నాను పేషెంట్ చచ్చిపోయినా కూడా వాళ్ళు మీకు లాయల్ గా ఉంటారు కానీ రెస్పెక్ట్ లేకుండా ఉంటే ఈ చిన్న చిన్న ప్లేస్ ఎందుకంటే మెట్రోపాలిస్ లో ఫ్లోటింగ్ పాపులేషన్ వాడు ఇక్కడ ఉంటాడు 5 చోటకి వెళ్ళిపోతుంది వాడికి ఏమి లాయల్టీ సిక్ అయినప్పుడే మిమ్మల్ని థింక్ చేస్తారు He will only think of your hospital when he is sick in metropolitan cities because it's a floating population. But whereas in places in 2-tier and 3-tier cities, there is a settled population generation. They're more loyal to the particular. So they should think about your hospital even before they get sick. Got it? So empathy, okay, putting shoes into their shoes, okay, putting your foot into their shoes is very important. Transparency. ఏం చేయబోతుంది ఎలా చేయబోతుంది చిన్న చిన్న విషయాలు విచ్ దే ఎక్స్పెక్ట్ వాళ్ళకి భయం ఉంటుంది మీతో మాట్లాడాలి పెద్ద డాక్టర్ గారు మాట్లాడారు సో దట్ ఈస్ వెరీ ఇంపార్టెంట్ రెస్పెక్ట్ ఈస్ నాట్ జస్ట్ ఫర్ ద పేషెంట్స్ ఆల్ దీస్ 3 things are not for just this all the stakeholders of the hospital should have this your staff should be you should be empathetical to your staff you should be empathetical to your staff your vendors and your patients. Same thing, you should be transparent to your vendors, your people, that is your people and your patients. And you should also have respect for all these categories, all the stakeholders. So you have to win the hearts before you win the territory. So trust is like this. You understand? So people trusted him, whether he is in power or not, people trusted him. So your hospital should be having the characteristics of somebody like Bahubali who can bring that trust. So what is prosperity? It is discipline. Prosperity is not pricing, it's a discipline. Discipline. Okay. By the small towns, the problem is there will be ENT surgeon. Sorry if any ENT surgeon is there. But we will also take care of a pneumonia patient. Okay, they will not cross referral. Okay, first this also somebody was telling the first session the credentialing and privileging. Babu Narayan sir also was telling about privileging and credentialing. He had faced it at the age of 29. Now he's 35, of course. So what I am trying to say is, so NABH has brought in the kind of credentialing and privileges. So clinically, you have to align to one patient, one line of treatment. That is very important. So that discipline has to be there. The financial discipline. Okay, what to be bought, when to be bought, where to be spent. Okay, this particular discipline has to be there. It is not necessary because somebody has bought a 128 slice CT, you should buy it. Somebody has bought an intensive, so okay, by giving 1,000, they got an intensive, what in your hospital, you have to analyze and get that done. So those disciplines are important and discipline for. So people discipline only when you recognize what you make them accountable and responsible. You engage in the organization, engage in people with discipline in the oneness, belongingness of the creator. So discipline is important. If you have this, okay, then prosperity will automatically. I will fast move చేస్తాను ఓకే ఎందుకంటే మరి సో ఫైనాన్షియల్ గోల్స్ ఆర్ ద టఫెస్ట్ యాస్ ఐ టోల్డ్ ఓకే మనం అనుకున్నట్టు ఈ ఏడు అనుకుంటాం అది రాకపోవచ్చు ఇంకో సంవత్సరం రావచ్చు సో వాటిని మనం అచీవ్ చేయాల్సిన అవసరం ఎంతైనా ఉంటుంది ఈ ఎట్లాగైతే కనుక బాహుబలి సెవెరల్ టైమ్స్ ఈ ఫెయిల్స్ రాస్తాడు హిల్ అట్లా ఎన్నోసార్లు మనం అటెంప్ట్స్ చేస్తే కానీ ఒకసారి మనం ఎందుకంటే ఎదురు కూర్చొని so finance is important when financial discipline fails. Okay. Financial discipline is very very important. లేకపోతే ఇట్లాంటి సర్ప్రైజెస్ చూడాల్సి వస్తుంది ఏంటంటే డబ్బులు ఉండవు ఇప్పుడు చాలా మంది ఇన్వెస్టర్ వచ్చిన తర్వాత ఏమవుతుంది ఎబిటా 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 ఇస్ రాంగ్ కాన్సెప్ట్ ఎబిటా ఇస్ నాట్ ఎ స్ట్రాంగ్ ఆర్గనైజేషన్ ఇఫ్ దే ఎబిటా పాజిటివ్ డజంట్ మీన్ దే ఆర్ స్ట్రాంగ్ 100 రూపాయలు సంపాదిస్తున్నారు మీ హాస్పిటల్ 100 రూపాయలు బెంచ్ మార్క్ చెప్తా 100 రూపాయలు సంపాదిస్తుంటే మీకు యాక్చువల్ క్యాష్ వచ్చింది 40 రూపాయలు కానీ మీరు ఎబిటా పాజిటివ్ 20% అంటే 20 రూపాయలు కానీ మీ ఖర్చు ఎంతప్పుడు 100లో 20 రూపాయలు లాభం ఉంటే ఎంత ఖర్చు 50 రూపాయలు మీకు డబ్బులు ఎంత వచ్చింది క్యాష్ గా ఎంత వచ్చింది 50 రూపాయలు మరి 30 రూపాయలు ఏం చేస్తుంది ఎక్కడి నుంచి తీసుకొస్తారు బుక్కులో ఉంటుంది చేతిలో అదే క్యాష్ ఫ్లో ఉంటే అప్పుడు ఏం చేస్తాం బ్యాంక్కి వడ్డీ తీసుకుంటాం 10% 12% వడ్డీ వేస్తారు 30 రూపాయలు గవర్నమెంట్ నుంచి రావాల్సింది ఏదైతే ఉంటుందో 50 రూపాయలు గవర్నమెంట్ నుంచి అంతే వాడు 10% దాంట్లో కట్ చేస్తాడు డిడక్ట్ చేస్తాడు మంచిగా ఉంటుంది ఇది కాదు ఎప్పుడైతే ఫైనాన్షియల్ ఎప్పుడైతే రీచ్ అయ్యగలుగుతుంది అప్పుడు మన దగ్గర క్యాష్ ఫ్లోస్ బాగుంటాయి అప్పుడు మనం చేతులు ఎత్తి పట్టాల్సిన అవసరం లేదు మూడోది చాలా ఇంపార్టెంట్ పీపుల్ ఎంగేజ్మెంట్ మనం ఎప్పుడైతే పీపుల్ ఎంగేజ్ చేయము మేనేజ్మెంట్ బోర్డ్ రూమ్స్ లో మాట్లాడేది తెలియనప్పుడు ఏమవుతుందంటే మనం ఏదో చెప్తాము అదే మీకు తెలుసు కదా కిలకిలి పాత్ర దాసోయేదు మన మేనేజ్మెంట్ ఏం చెప్పినా మీరు అందరూ అదే అట్లాగే ఉంటారు ఏంటో మనకు అర్థం కాదు సో ఎప్పుడైతే బోర్డ్ రూమ్ నుంచి డిసిప్లినేట్ చేయాలి బోర్డ్ రూమ్ లో మీరు మాట్లాడే ఏదైతే ఉన్నాయో ఆర్టిస్ట్ అది అటెండర్ అవనియండి ఓకే లేకపోతే నర్సింగ్ స్టాఫ్ అవనియండి ఓకే ఒక జెనిటర్ అవనియండి టెక్నీషియన్ అవనియండి ఒక అడ్మినిస్ట్రేటర్ అవనియండి ఎవరైనా సరే వాళ్ళని ఇన్వాల్వ్ చేయకపోతే మేనేజ్మెంట్ మేము చెప్పేసామని ఈ లాంగ్వేజ్ ఉంటుంది మనకు అర్థం ఏమవుతుంది రాజమౌళి గారు సో ఇదే మోస్ట్ ఇంపార్టెంట్ థింగ్ రైట్ టాలెంట్ దాన్ని రికగ్నైజ్ చేయండి చేయకపోతే ఇట్లా అవుతుంది అంతే లాస్ట్
ఇది కదా
ఏమి తెలియనాడు చూస్తుంటాడు మనకి చెప్తా ఉంటాడు ఇది కదా ఇది ఓకే సో కాబట్టి టాలెంట్ రికగ్నైజ్ చేయాలి
ఇది కత్తి
interest of the time, sorry. Okay. I was telling Rajamouli took 5 years to take the film. I have to show it in 15 minutes, including healthcare also into that. What nyayam here? Okay. So, రెండు కవర్ చేశాను కదా. I have covered growth, I have covered prosperity. Third is sustainability. Sustainability అంటే ఏంటి? I have a huge auditorium, I have a beautiful building with air conditioning room. I have 128 like PT. I have an MRI, Tesla, that's all. Sustainability is putting systems in place. Make people adopt the system. Respect the system. That is sustainability. అప్పుడు సస్టైనబిలిటీ అంటే legacy. అంటే మీరు ఉన్న జీ ఎలక్ట్రికల్ జనరల్ ఎలక్ట్రికల్ ఎన్ని సంవత్సరాల నుంచి ఉంది ఎవరు స్టార్ట్ చేసింది హూ స్టార్టెడ్ Thomas Edison. It is there for 200 years. Ford, almost 150 years. Procter and Gamble, it's almost 220 years they are in the industry. ఎవరు ఓనర్ ఉన్నాడా లేదా అదేదో కళలో వచ్చి చెప్తా వెళ్తా ఉంటారు కదా లేదా దెయ్యం లాగా వచ్చి వెళ్తున్నాడు సిస్టమ్స్ ప్రాసెస్ విషన్ దట్ ఈస్ మేడ్ దెమ్ టు స్టే ఫర్ సో లాంగ్ ఓకే ఎకానమీ నువ్వు ఇప్పుడే ఫైనాన్స్ చెప్పు మళ్ళీ ఎకానమీ అంటే ఎకానమీ ఇస్ డిఫరెంట్ ఫైనాన్స్ మేనేజింగ్ యువర్ రెవెన్యూస్ యువర్ మనీ టుడే it is భయంగా ఉంది వచ్చి లాక్కెళ్ళిపోతారేమో సో బట్ వాట్ ఈస్ ఎకానమీ ఎకానమీ is something you envisage how it is going to be 20 years later what all I need how much of resource I should have what kind of people I have to create మీరు నమ్ముతారు మనకి అమూల్ ఎంత పాల్ హూ స్టార్టెడ్ అమూల్ ఎవరో కేరళ నుంచి హూ స్టార్టెడ్ బాబు నారాయణన్ సార్ అమూల్ కురియన్ యా కరెక్ట్ So he started in that particular point with a lot of women, rural women. He enlisted because milk will be a big production supply gap will be there. So we can have this as a big industry. Correct or not? So that is economy. So improve the economy. ఎంతమంది డైరీ ఫార్మ్స్ ఎన్ని కుటుంబాలు అవునా కదా మీరు ఎవరైనా డైరీ ఫార్మ్స్ పెట్టుకున్నాడు ఉండొచ్చు ఇట్స్ బిగ్ సోర్స్ ఆఫ్ రూపీస్ తగ్గినాడు ముఖ్యంగా నేను బాగుంటే మన ఇంట్లో గొప్ప పక్క ఇంట్లో పడేసి కూడా తీసుకెళ్ళాలి ఇది ఎన్విరాన్మెంట్ చాలా ఇంపార్టెంట్ హెల్త్ కేర్ 4 to 5% గ్లోబల్ కార్బన్ ఫుట్ ప్రింట్ గ్లోబల్ కార్బన్ 4 to 5% హెల్త్ కేర్ మెడికల్ కానివ్వండి గ్యాసెస్ కానివ్వండి మన ఓటింగ్ నుంచి వచ్చే గ్యాసెస్ కానివ్వండి 4 to 5%. ఏమి పెలాగామి అనేది అందులో ఉంది ఫస్ట్ హాస్పిటల్ మెడికల్ కాలేజ్ కన్వర్ట్ కంప్లీట్లీ పేపర్లెస్ దే క్రియేట్ 50,000 రికార్డ్స్ ఎవరీ ఇయర్ అంటే డిశ్చార్జ్ అవుతారు అనుకుంటారు అంటే 1 crore న్యూస్ పేపర్స్ A4 పేపర్స్ ఎవరీ 1 crore A4 పేపర్స్ అంటే క్లోజ్ టు 30,000 ట్రీస్ ఎవరీ ఇయర్ మనం ఎంత అక్యూజ్ చేస్తాం పేపర్స్ మన రూమ్ లో నుంచి బయటికి వెళ్ళేటప్పుడు ఏసీ మంచి ఏసీ ఏదైతే పవర్ సేవింగ్ కొంటారు దానివల్ల పవర్ యూజ్ చేస్తారు సో మనం బట్టి కమ్యూనిటీలో ఉన్నటువంటి కమ్యూనిటీ ఎన్విరాన్మెంట్ కూడా దట్ మీన్స్ community also because of your misdeeds because of how you pollute the environment, you have to be responsible for that. So that is very important. So I'll please slip. Never ever compromise. What is right? చాలా తప్పు ఎక్కడున్నా తట్టించి అడగండి పర్టికులర్ గా నర్సెస్ అడగనే అడగదు So I am doing last two slide. So what is the growth? The invisible driver is what happens when we have more patients, then have more about what is prosperity, discipline on clinical outcomes, financial. What happens? We have better income, better cash flows, and better outcomes in clinical governance. And what is sustainability? It's culture, system, and the planet. We will also take care of the planet. And it will have a lasting legacy. One of the there, they go, we will adopt this and it will be there for 100 years, 200 years. So, my dear friends, people make you grow, processes make you prosperous, and systems make you survive. Thank you so much.
Thank you so much, sir. Next, it's my privilege to introduce our respected group CEO, sir, hospitals, and our today's speaker for the session, Mr. Rajarajan, sir, a dynamic healthcare leader and visionary administrator of the Alluri Sita Ramaraju Education Society. with vast experience in hospital operations, strategic growth, and digital transformation. He has been instrumental in strengthening systems, expanding services, and driving excellence across our institutions. His leadership, commitment to quality, and forward thinking approach continue to evaluate our organization to greater heights.
Welcome you, sir. Now I invite our today's speaker, Dr. P. Vijay Garu, is a seasoned healthcare planning man. He's a se- He's a seasoned healthcare planning and management consultant with over 15 years of experience across 50 plus hospital management projects. He is a turnkey specialist in oncology, mother and child, cardiac care, IVF, and super specialty care, contributing to more than 10 million square feet of commercial healthcare infrastructure. He brings strong expertise in healthcare quality accreditations, lean applications, operation scaling, and digital health implementation, including HIS, RIS, PAC, and EMR systems. Currently serving as the South India Operations Head at Integra Ventures. He focuses on improving accessibility, availability, and affordability in healthcare. Approach postgraduate in hospital management from Administrative Staff College of India. Dr. Vijay Shetty is invited to Caho Jeevan Unit to share insights on healthcare excellence for small and medium hospitals. We welcome you. Sir.
Growth without systems is temporary. Systems without vision are statement. And our next session, fixing healthcare inside out, design thinking, customer centricity, and EBITDA.
We have to follow up about the energy set by Venkat Pallina, sir. So I hope all of you we are very excited to have one of its kind, probably the first of its kind, healthcare management program here at Ashram and probably here at we're thankful to Caho for partnering us and the Caho Jeevan event here. So today I'm going to talk about something which is very close to everybody's heart. Keep talking about it in hospitals, but do we actually follow it? Do we do it? This is all about patient centricity. So, but before that, may I ask how many of you have attended healthcare management conferences before? Can you raise your hands? Okay. Very few, slow hands are raising. Okay. All the others who have not attended, raise your hand. Okay, so now all the others who have done also raise your hand. So everybody raise your hand. Okay, so slowly bend it at the back. Back yourself. You are doing a great job. Today is a great start for all of us here at the Ashram Caho Jeevan event. So we're going to talk about customer centricity. So in that we are looking at design thinking and design concepts of design thinking and how do we, after he has dissed out on EBITDA, I'm here talking about EBITDA. It's okay, but still, as PNL heads, for us, our North Star is EBITDA. Okay, cash flow is for the promoters, maybe, but for PNL heads, our North Star is EBITDA. So on that aspect, so over the years, our chief guest also had mentioned about Sushrita and Charaka. We have those halls, just like any other medical college, which is very unique to all medical colleges. We have the Charaka Hall, the Sushrita Hall. In fact, we have something called as the old Sushrita Hall. I don't know which is the new Sushrita Hall. So the Charaka Samhita and Sushrita, the earliest documented medical and surgical literature that is available from all those ancient lores and history, folklores, sorry, not folklores, the history, we are now with Da Vinci systems, cyber-knife systems, even proton therapy systems. There is a lot of things which has come, but still, as
our fellow poet had said, wise to do. So, over a period of time, what customers, the word customers, we call them patients, we call them attendants. So, when a new term as customer, in 15, 20 years back, in hospitals, we call them patients or attendants or customers. People would come back with regards to beat us up. But today, we can proudly say they're customers. So, there's a lot happened. The wind of change is from how it was a commodity to goods, to services, to experience. Today, experience matters. Today, we are living in a world of experience. So, on that note, this is something new. One of my mentors had invested and started the super health. Dhoni had also invested. It's in Bangalore, in Koramangala. Their aim is 100 secondary care hospitals. So, not very good, small and all healthcare organizations, Babu and Dr. Bala. So, it's again disruption. Today, we talk of an important concept called VUCA. Okay, we will talk, we will see the slides on that. But in the VUCA world, disruption is real. We all need to accept and become a part of the change that we need. So, Deloitte has this beautiful model which we say we are going to go, we recently just had a beautiful lunch in this beautiful super specialty facility of ours. Thanks, Vijay, also for being part of this project and helping us out with that. So, but the concept, 10, 15, 20 years from now, it's going to go into something called as a hospital without walls. We're already seeing a piece of it today as we talk. We have a lot of home healthcare companies. We have a lot of other companies don't which are in this space, they don't operate as a whole. So with changing times, we have to keep looking ahead. So who are running by volatility, uncertainty, and conflict? Okay. To easily understand, can we remember Donald? Look, volatility, uncertainty, and conflict. All together. Okay. Thanks for the last one. So how do we overcome this? It's a very important technique that we need. We have to have the vision to overcome volatility. We have to have the understanding to have overcome uncertainty. We have the clarity to overcome complexity, and we need to be agile rather than being ambiguous. So that's something that we call take home message about everybody. So we talk, right? So more importantly, the real problem today in our hospitals is it's doctor-centric model. It's prone to revenue dictation. It has low patient retention. And definitely, if you don't have somebody like Swarna or somebody like upper class, patient retention is going to become a problem. In our system, we are able to know when the patient is going to come back. We are able to track to our EMR what are the diagnostic retention we are able to use. With Asram thing also, we are able to see how many patients we have retained in this system, how many of them have come back to our cashback internal loyalty program that we have. So, right now, daily payments for patients, all these are creating thin EBITDA margin. Okay. Venkat sir told 20% EBITDA is good. Yeah, did 18 to 25% EBITDA is good. There are healthcare organizations like there are healthcare organizations, listed companies, which are looking even above benefits. Like we have one speaker from Rainbow Public Information. They are online. They post, Anthropagnavan sir was part of Rainbow earlier. So they have about 30 34% every time. They are listed company. If you have not bought the stock, you can please look at it. So design thinking. The cornerstone of design thinking is we all, many students are also here. We're all taught about thing called plan, do, check, act cycle, PDCA cycle. A little bit of like the solid weight technique, a little bit of empathy into it. This is your design thinking. So this particular diagram I call it as design thinking for dummies. There was a series of books called C++ for dummies, Java for dummies. So like that, exercise define ideas, prototype methods.
design thinking for Navi. But this is enough for us to establish our healthcare system thinking in a proper order, patient centric. So, what I feel is we have to empathize with a very important aspect called the patient journey. We have to have proactive risk measurements. In fact, I thank NAPH as risk management was part of a earlier NAPH mission. But in NAPH 6, there is a lot of proactive risk management related aspects. So reframe the safety problem. We need to look not just at patient safety, employee safety, everybody's safety in the system. So it could be even the nurse mixing the chemotherapy drug. So what kind of safety and what kind of risk mitigation methods we have in place for that? We have to co-create with multidisciplinary teams. We have to do rapid test prototypes and scale with governance and accreditation alignment. It's more important in Andhra Pradesh. We live in a skill-based environment. So how do we align? So if we start implementing many of this, what we will have is growth by design. So we are also in the era of Industry 5.0. Healthcare was never in Industry 4.0, but there was 3.5 as well in between. Industry 5.0 has brought the focus back on co-creation, from robots to cobots. So where human and technology would coexist, become human centric. So it's a very important concept as we move forward to realize better every time. Okay, so customer experience matter because patients today, as I said, this is experience over clinical, not over clinical, not just clinical. So a patient who's coming for a particular ailment has to be addressed with that particular treatment. Online reviews matter. How many of you have the habit of checking Google reviews? So how many of you give Google reviews? So we are living in that era where we are able to voice out. Think about pre-independence day. If Britishers had a Google page, what would all Indians would have done? So in this era, it's very important for all of us to actually have good reputation management. So be it small, medium, large hospital, reputation management is very key. And also, from the patient point of view, the emotional context of loss and fear is very high. Who are we addressing that? That's very important. So, attendance matters and decision instrument. How many of us talk even to the attendance? So, many doctors only talk to patients to move away. Nowadays, there are doctors who don't even have a simple pat on the patient's back as well. So all these we need to rediscover. So everything is customer experience, right from the time they start searching. So it all comes in the digital exposure, the digital front door, what we call the registration and waiting, the consultation. Each of the steps is important in the patient journey, and we need to ask the important question: where is the frustration very high, and what am I going to do about it? How am I going to alleviate it? So this is my most important study. If I do about 10 presentations, 8 out of 10 presentations will definitely have this slide. The backbone of a healthcare institution is our nurses. Now, our nurses are not God. Our nurses are not Lord Kali Mata with so many hands who can multitask, but we are expecting them. Correct, madam? My dean madam is sitting on the front row. So we are expecting our nurses to do everything from pin to play, from restroom problems to patient documentation errors. Everything is blamed. So the load on their system, the load on the nursing system has to be reduced. So we have this mechanism of understanding what are the core activities, what are the non-core activities, and those non-core activities we do task shifting for better customer experience, for better EBITDA. It's part of design thinking what we do. So fixed processes before promotion. My marketing head is there. He would always say, sir, you the system in then we will go, sir. That is a standard thing across marketing. So experience before expansion, systems before scaling is the need of the hour. So most hospitals we try to get equipment, marketing, and pricing right, but what we ignore is OP flow. In fact, with our board of advisors, we did a 2-3 day rounds of our new super specialty, defining how our OP flow has to be. Okay, billing experience, discharge delays, follow up system. All these have to be looked into and not into. So even NABH, we are, as a larger part, as Caho, we also focus on quality. NABH systems also focuses on all these things. So customer journey is very, very important for tracking, and customer is not just the only patient. So we have the attenders, the referring doctors, the corporate partners, the insurance the desk at the various companies, the digital desk, the internal staff. So all this experience drives loyalty, loyalty drives everything. That's another take home that you need to understand. So you can have your simple net promoter score, you can have your wait time perception, can have counseling clarity given to your team, training for them, and the complaint closure time as a key metrics that you need to look at. The truth about EBITDA is there's a lot of revenue leakage, poor cost control, idle assets. When when I came here 2 years back, we did not have a fixed asset register. Many hospitals, small and medium hospitals, might ask, what is a fixed asset register? So every capex items are not OPEX items. Capex items are stand, they are there, they cannot be consumed. Okay, many of your equipment are capex items. So these capex items, you need to look at how you are able to utilize it. So a fixed asset register has to be maintained, and each of your capex items should have a minimum of 50% utilization. You need to budget for your capex item. So this is not that I buy a robotic system tomorrow, and I budget that I'll be doing 100 surgeries every quarter. But if I don't do even 50 surgeries every quarter, there should be an intervention. There should be a deep dive. There should be a discussion to how to make it happen. So these kind of things are very important. So another important slide for all small and medium hospitals out there, or the staff from those hospitals, we need to focus on bed occupancy percentages. We need to reduce the average length of stay. That's a beautiful thing. How to keep the hospital lights switched off and still the cash registers clean. So this was told in one of the GE conferences that I attended in Indonesia. But it makes a lot of sense. That's again, that's 10 years back. And that's what we're talking, hospital without walls. So reduce operating wastage and improve collection efficiency. In Andhra Pradesh, collection efficiency is very, very important. You have almost 60, 50, 60 percentage as credit patients over here. So go back, fix all these things. For want of time, I'm just moving a little fast. So low surgery conversion. You should be having many of the hospitals have these kind of problems. Low surgery conversion. Instead of blaming marketing, empathy interviews reveal fear of unknown cost, poor explanation of this, attender anxiety, and no option for EMI. Okay. So when we start fixing all this, we see that the conversions are up, cancellations are down, and EBITDA, customer experience. So yeah, I would also like you to look at this word called team goals. Time, inventory, material, TIM, These are the 8 ways that a hospital or any system can. Okay. And broadly classified in the Toyota production system of Buddha, Muri, and one more way. So, so these things will help us have better lean management. So customer centricity will increase brand preference. So you need to measure loyalty, don't assume that. So we need, as I said, it's not just about patient safety, it's about employee safety. Not this system design is not just for the customer, it's also on the user. The user centricity is the most important. That's where I take the example of the nurses as well. The engaged staff with higher productivity is increased every day. So what this is a cheat sheet for you all. what you can do in the next 30, 60, 90-day plan. So all of you are registered and given your email ID, we can just do it. So you can start to implement this. Maybe if you all want, I'll send a Excel tracker sheet also with. So growth is not bigger building, more consultants and bigger apps. It's better processes, predictable outcomes, measured experience, sustainable margins. And Deming once said that what cannot be measured cannot be improved. But the same Deming later in life said that not everything can be measured. There is something beyond measurement. It is that human touch, is that empathy, that which we've been, lot of speakers have been talking about from the morning. So design better systems, profits will follow. So technology is best when it brings together people. Thank you all.
For the next session, conceptual. Building hospitals is not a construction, it is creating healing ecosystem. To start this session, I request Dr. P.V. Vijay Garu.
Hello. Yeah. Good afternoon, everybody. Mine is a very vast topic, but again, it's being squeezed into 15 minutes. So, then running through the slides, let me just also run through my experience. What is that? Conceptualization to commissioning. Most of the doctors at any point of the in their life, at any point of the time, they would like to start their own hospital or want to partner with somebody or be an entrepreneur. So everybody has got that particular thing in them, but most people don't make it, or who try to have take. There would be a lot of reasons for that. So basically, when you want to commission a hospital, what are the major things which you have to look into? So, first of all, selection of your hospital type is very important. What is that you are going to do? So, it starts with the planning. So, when it is planning, it is not just on the architectural plan or anything. It involves your complete detailed project report, which we say. So, I think Venkat sir would agree. Even for a small hospital or a big hospital, it is very important that we do a detailed project report. It may not be at a level where we do a detailed project report to a bankable thing or anything, but at least for you to discuss with your well-wishers or your financiers or even for your bank. So, what is the importance of the detailed project report? Basically, this will tell you that what is that I am going to do, what is that investment I am going to do, how much of money I need to invest, do I need to phase my project or do it at once, where am I going to get my funds from, and also who is going to fund and when I'm going to break even. So, this is what the basic exercise any promoter has to do before they start any hospital or project. It may not be, it is not only applicable for a big hospital, even a small 20-bed or a 30-bed hospital. I think following this process will bring in a lot of clarity for you. So, whenever I plan or help small or medium sized hospital owners, everybody go back with some friends or family's suggestion. They say it is okay, we can just start with small OPD block, put 5 beds, you manage with things, and that's how then we can expand and stuff. But today, if you see metros at least, I don't see that scenario which has reached till the scenario has reached in tier 2 or tier 3 cities. Recently, I read an article in Kerala for last 3 years or 4 years, I think, close to 450 small or medium sized hospitals have shut down. Why is this happening? Because you're not able to compete or you're not able to deliver the kind of services which a bigger setup is doing. And it is not true if you have planned your premises well, if you have strategy in your mind, even a 20,000 square feet hospital, like he was saying, the next door hospital to one of the 7-star hospital, they were able to compete because infrastructure is one of the major component which you need to have it planned right so that you can excel or compete with people. Always, I suggest people when you build a hospital, don't think for today. Please think for 10 years ahead. Even after 10 years, if there is a new competition in the town, your infrastructure or your planning should be able to support you to compete with them. So that would be very important. Next, once you do your DPR, again, lot of people come back and say, "Sir, my father-in-law gave me one piece of land for dowry or something. I would like to plan and construct a hospital there and stuff." So when you analyze the site, it is somewhere in the old city of the city or in the city center where you don't have even proper two-way access to enter that place. But the land is worth crores there. But most of the time when I assess that kind of situation and stuff, I always tell them you better sell this, go slightly 1 or 2 kilometers away from the crowded space, go for a bigger land. Maybe instead of 2 grounds or 3 grounds, you go for half an acre or a 1 acre land. Build whatever you're comfortable and you have a expansion strategy there. So that again depends on the DPR which you do. You can plan on this. Then once you do this site fix, then again it is very important to seek professional help. Most of you end up giving the project to your uncle or your cousin or brother-in-law who is a civil engineer or architect who is not qualified to do. So most of the projects which I intervene in between and stuff, they
Jeevan. And they will try to follow their thinking that but that's the problem. Okay. You can take the good in that, but then you should understand you don't see. I always and because you have money in the first fight, okay, tax will be everybody will that amount of thing will. So what happens? You don't think about future. You think okay. So good one. Healthcare has changed a lot. I am in healthcare for the last 3 decades. For healthcare, CEO about the when I started my healthcare journey, our EBITDAs, our balance sheets, our cash flows are seen only once in a year. Once in a year, we used to have a board meeting and we used to look at the cash flows and how the performance of the hospital is. Then it changed into 6 months. Then it changed into 3 months. Then it came to monthly reviews. Today it is every day. It is every day. Every day there should be a dashboard, and we have to see how many pharmacy advisors have been done. Which doctor did how many pharmacy advisors? How many have been honored in the any pharmacy? Doctor A రాశాడు ఈ రోజు ఆయన రాసిన 10 కొన్నారు ఆ ఫార్మసీలో ఆ 10 వాల్యూ ₹1000 అయితే ₹1000కి కొన్నారు. అర్థమైంది నేను చెప్పేది అంటే అంత నిటిగ్రిటీ ఈ రోజు వర్క్ చేయాల్సిన అవసరం అంత మైక్రో మేనేజ్మెంట్ వాళ్ళు చేస్తే కానీ సర్వైవ్ అయ్యాలి లేదు.
Sir, one more question, sir. Actually, I want to speak in Telugu, sir. మీరు చెప్పారు ఫస్ట్ 5 years లో సార్ ఫస్ట్ 5 years లో మనకి మనీ ఉంటుంది. సో వీల్ ఇన్వెస్ట్ లైక్ ఎనీథింగ్ సార్. సో అలాంటి సిస్టమ్ ఉన్నప్పుడు సో ఇన్సెంటివ్ ఇచ్చినప్పుడు డాక్టర్స్ కి సో క్యాన్ వి అడ్జస్ట్ విత్ ద సిస్టమ్ గోల్ సార్. ఇన్సెంటివ్ అనే ఒక కాన్సెప్ట్ స్టార్ట్ చేసినప్పుడు can we adjust with the existing systems? Yes, sir.
వాడు ఎంతకాలం ప్యాంపర్ చేస్తారు లైక్ 18 ఏళ్ళ తర్వాత కూడా ప్యాంపర్ చేస్తే ఏమవుతాడు? ఎస్ సార్, ఐ డోంట్ బిలీవ్ ఇన్ incentives. They have to grow with the organization. You understand that? Incentives are short. Okay, so that will only trigger. Tomorrow he gives more incentives, he will go there. Okay, so they are not. That is a very short-term goal. Okay, to achieve. These all you do in the first 5 years, and then you will do it. You have to create that bonding and trust among people. Why a nurse should not know what is EBITDA? Arbapani edu teliyakoodu HR manager thing. Okay, they should learn that. You have to inculcate that culture. So that is important.
Thank you, sir. Even into diagnostic the incentive system, sir.
Thank you so much, sir. Now I request Ibrahim Abbas Garu to please felicitate Venkata Fani sir. I request Abbas sir to please felicitate Rajan sir. Thank you so much, sir. Now I request Ramesh sir to please felicitate Vijay sir. Thank you so much, sir. Now I request Babu sir to please felicitate Abbas sir. Thank you so much, sir. Now I request Arumugan sir to please felicitate Ramesh sir. Thank you so much, sir. Can you please post the photo? Thank you so much, sir. Thank you so much. Let's move to next session. Next panel discussion is titled Clinical Management Process. Best practices and mitigation strategies for small and medium hospitals. To chair this session, I request Dr. Babu Narayan. He is a distinguished healthcare professional and quality leader, currently serving as Caho CHC Co-Chair and Chief Business Officer and Head of Quality at GEM Hospitals, Chennai. He also leads as a HOD of General Medicine and Diabetology, combining strong clinical expertise with strategic hospital management. With extensive experience in healthcare quality, operations, and business transformation, Dr. Babu Narayanan has been instrumental in strengthening patient-centric care and accreditation practices. His leadership focuses on integrating clinical excellence with organizational performance, making him a respected voice in healthcare quality and hospital administration.
We have Dr. Pranit sir. Is an accomplished emergency physician and is currently servicing as associate professor at Asram hospitals with a strong expertise in emergency and critical care medicine. He plays a key role in managing complex acute cases, advancing clinical training. He is actively involved in academic development research and strengthening emergency.
Now I request Professor Dr. Sikindar Mohan is a distinguished general physician and academician serving as an associate professor in the Department of Government Medicine at Government General Hospitals, Eluru and Government Medical College, Eluru. He holds an MD in General Medicine and brings extensive clinical expertise in diabetic, hypertensive, infectious diseases and critical care. we welcome you, sir.
Dr. Vandana Kanpuri is renowned gynecologist serving as professor and head of the Department of OBGYN at Asram Hospital, ALU.
Now I request Dr. Kalyan Chakravarti. He is a consultant physician and critical care specialist with significant experience in emergency and comprehensive medical care. He serves as a managing partner at Jeevan Hospital, AU, where he leads clinical and operational initiatives. We welcome you, sir. We request the chair to start the session.
Good afternoon. So as Bahubali has ate most of our time, we are left with very short time. So I would request the panelists to excuse me. So excuse me if there is we are trying to shorten the session. In view of taking into consideration long interesting sessions ahead. Okay. So this session is mostly about say the clinical governance, right? Now we are into an era wherein we are trying to do the packaging very well, right? Packaging very well. But what has to be delivered, we miss the point. So the core of any hospital system, why hospital exists? As simple as that. Cure a patient, right? So I personally think that, but I think everybody's opinion would be that the core of any hospital management system is the clinical outcome. As simple as that, right? So the patient comes to us, what is the most important indicator to say that this hospital is good? The clinical outcome. All other things are only decorations. Please understand. However, we are gone into an era wherein we are not concentrating much on the clinical outcomes. We are about the decorations, right? Whether the Wi-Fi is present, whether the comfort is present, whether I have given a very good suit, whether somebody comes and welcomes me, everything done. What happens to the patient at last, right? So this topic is very relevant that whatever may be the thing, wherever you are, the one indicator which the hospital should work on is the clinical outcome. So we have an esteemed panelist, wherein we are trying to ask them, okay, if that being the one important parameter to measure or a success or failure of a hospital depends on that one parameter of outcome of the patient when he comes to the facility, then what are the where they cannot say? Because I come from Madras Medical College, where 1,500 beds at any given time, you will be having at least 2,500 patients admitted, inpatient. Right? So it is very important aspect. So, Dr. Pranay, as an emergency physician, I would ask you a perspective, right? For example, there is something called as clinical governance. Whenever a patient comes to you, it is your duty and responsibility to offer a good care, right? A good outcome. What do you do when a surge of patient comes? Like, for example, in disaster or some accidents, maybe 20, 30, 100 patients. How do you manage it? Because as an emergency physician, how do you manage it? Do you have any system in place? That is my first part. Second part is that, okay, if at all, if you could manage, what happens to a small healthcare organization? Let us say 50 bedded, they will be having probably 1 or 2 beds as their emergency beds. What they have? Yes.
First of all, thank you everybody and for the opportunity. So, regarding to your question, the first thing is we at the Asram being a tertiary hospital, we have systems in place.
we have disaster preparedness. So we have effective triaging systems in place, and we know how to expand when needed. And first and foremost, there are two things that we need to consider. One is something called as a mass casualty, which everybody knows, and the other one is called as a multiple casualty. So when you have multiple casualties, it's the resources of the hospital don't get overwhelmed. You'll still be able to take care or attend to all these patients without disrupting any services. But if there is a disaster that has occurred, and there's about 20-30 people that come in at once, so then the resources of the hospital get overwhelmed, and you have to have contingencies in place. So for this, we do these mock drills for disaster preparedness and all. And every hospital, it is advised to know and self-evaluate that this is our surge capacity. Every hospital should know. Let's say for Asram, for example, we have about 15 to 20 people as a surge capacity. We should limit at that. Otherwise, the care is compromised because you haven't done triaging at the first level. So my advice would be, every hospital, small or medium, should know how to assess this in-house and know what their limitations are. So if there is a surge, let's say if it's like you said, if it's a 2 or 3 bedded emergency room in a small or private hospital, if suddenly 8 people come in, you should have tie-ups with other hospitals. You should have tie-up with ambulance services. You should have checklists and systems and processes in place, so that in case when they come like that, you would have done the best for the patient outcome. So ultimately, that's what matters. So that's what.
So, Dr. Pranay has brought to that two valid points, I would say. One is that, see, there is a disaster management plan in bigger hospital. Okay, so that is one thing, being off. So, second is that if it happens to be a 20-bedded or 30-bedded hospital, it's always better to have referral centers as your friends in order to do the best for the patient. Coming to Dr. Sikandar, we read a lot of, say, evidence-based medicine care pathways. For example, let us say that a patient with the MI comes, then he has to be taken through these kind of measures. If a patient with chest pain comes, then this is the clinical pathway. If a patient with acute severe asthma comes, this is the pathway. However, there is one variable component, because as we say that you will be having 10 identified beds, but you will be having at any given time 20 patients will be coming to the facility. So my question is that in the backdrop of resource limitation, how do you ensure, because practically daily you will be doing it, ensure that we could somehow or the other adhere to the clinical pathways?
Good afternoon to all of you. First of all, I thank you, sir, for having good words regarding our government service and those doctors who are in government service. Though I am in government service, I have in the evenings, because of the lack of government are also giving permission. I do a little physical outside private practice also. So comparing to both this, there is definitely the massive load of patients in government hospital. And regarding, for example, in our medicine OP, for example, yesterday I was in the OP, one associate professor, I am associate professor, and one SR. We saw nearly 230 patients. So it's very humanly impossible actually. So continuously they will be having patients. And in general medicine, variety of symptoms they will be telling you. So we have to immediately think of, and we have to write prescriptions. And meanwhile, in the casualty also we have to handle. Some of the cases they are coming in the emergencies. And in India, what the patient will wait to the last minute, and once he comes into casualty, he wants immediate treatment compared to the Western world. Because then they'll go to the immediately if you have this symptom, because my friends are practicing in US or UK, So all their the system will be protocol, and the system is also first they have to go to primary health center, and there they will see, and then they refer UK, I think. But here directly the patient will come at the last minute, and he wants to miracles there. And the patients are also they don't accept any adverse happening also. So like that we have to so slowly we will get accustomed to that in government service. One fellow will come with fever. Suddenly, 2 or 3 patients will come with snake bite and the dog bite. Some poisons will be there, organophosphorus poisoning or weedicide poisonings, evident, and some COPD. And likewise, you said any MI case also will come. So we slowly we know the art how to triage in that. And if is any MI case comes, so we'll give the tenecteplase, we'll give injections, and then we'll stabilize and we'll refer it where the PTCA will be there like that. So definitely, so over the years, everyone will know the art how to survive in that field. Okay. Whereas in the government private practice, the patient he'll pay and he'll wait. The irony is what I feel. In my clinic, if I go 1 or 2 hours late, also he will not complain. They are seeing TV. But in government, the fellow is a doctor that just he went for coffee or for a break also, he will not wait. So everything will get adjusted and slowly, and those who can survive only they will be there. Some they will resign and go join private practice. That's what I feel.
So Sikandar has brought in 2 important aspects. I mean, like as he had said that most of the government hospitals, due to the enormity of patients, it is a person-driven concept, not a process-driven concept. The process is there, but the person takes the center role because the process will take time. So I believe that, I mean, like in future, we will try to adopt a methodology of process-driven, which is in US or UK. So there I think another important point, if you have noticed or not, in an US or a UK system, they seek a medical service very early, but they will get the treatment very late. Okay. But in Indian system, they seek at the last moment and they get surprisingly immediate treatment. If you travel around the world, if at all you wanted, I mean, if you have minimum means, you need not be very rich also, minimum means for survival, what is the best country to live is India? Please understand. Okay, in US or UK, you have to wait for 3 months or 6 months or maybe 1 year to do a CT scan and MRI. Here you go to the doctor, get it done. Specialist 6 months, here you get it done. So mostly we think that the Indian system is not that efficient. I do not know whether it is efficient or effective, but it is okay, doing very well compared to other things, right? So that is one thing. But however, as he has said is that maybe why didn't he try to triage the patients with his gut feeling and experience by which these kind of evidence-based pathways are put into place, right? Fine. So coming to Dr. Vandana, so OT is a very sensitive field, and it is also one of the, when it comes to medical legal aspect, most of the time you are the stars after anesthetists and surgeons, OG field. During the treatment of a patient, I mean, like there are certain protocols which has to be followed. Let us say concerns. Let us say concerns. So, what are the measures in place? Because most of the time it comes as an emergency labor or comes as an emergency LSCs. So, what are the systems in place to ensure that all these kind of formalities are being made during the attending of a patient?
Thank you, sir. At the outset, a big thank you for the Ashram team for inviting me here. Being an obstetrician, we have faced this again and again about having emergencies at the wrong hour. People just walk in at the worst of times, and just when you have thought you have just drained out, they come out with an absolute emergency you cannot do it. So I think that one of the best things which we can have is having very strong templates for every emergency separately written down, printed on your printed format, which mentions every detail so that in the odd hour also you do not forget certain aspects. Like say you can have column for diagnosis, all the risk factors, make them written down so you put in a tick so that you don't miss out the risk factors. Everything that you would want to explain to the patient, a separate consent for the anesthetics, for the blood transfusion, any eventuality that can occur during, even though an otherwise very safe surgery. I know that a cesarean can be a very routine for most of the times, but you never know. Sometimes it can sometimes go and take a different turn. So we need to keep everything written and always have it in place. You cannot write when the patient comes in. You might forget some aspects, and our patients are very complaining, especially if something goes wrong. They say we were not told of this. So it's very, very important that the consent template is very strong.
So, as Madam told, that consent is very important part of the medical treatment. And if you say that what, as a medical practitioner or as a hospital or as a system, we have to do the one thing to save our skin in this consumer-centric, more of an agnostic kind of world, is that taking a consent. Consent is a very big topic. But one thing which saves us from any kind of litigation is the most important thing is consent. So as Madam has rightly pointed out, that is a very important thing, but of course it is a topic for its discussion. To Dr. Kalyan, I mean, actually this question is a very broad question, but it's a lot of gray areas into it. We cannot say that this is right or wrong because law doesn't say it is right or wrong. The question is that from in a critical care perspective, when you look into, for example, a patient is in ventilator or something like that, when the attender says that withhold the treatment, then what do you practically do? This is actually, there is no right or wrong in this. This is a very complex question for you matter, and even the judges doesn't know what to do. Let us ask Dr. Kalyan.
Thank you for the opportunity. Very clinical dilemma, ethical dilemma. But legally speaking, you cannot, unless until you take an order from the court saying, okay, you can remove for this patient, there is no need of anything. And these people go into court. It's a long process, but it's not practically going to take place. The second thing is the affordability of the patients and patients' emotions. So affordability is very big thing in this area where we are in a town setup. Most of the people don't have the money even to bear 1 or 2 days to prolong the life. Okay, so they request us, please remove the ventilator so that we can take him home. We cannot afford more. In that scenario, you are in a dilemma. You can't, as a doctor, you cannot remove the ventilator and take it home. You cannot do that. The only thing, in some patients we are lucky, like before they will give a DNR consent. When they give a DNR consent even before intubation, that is fine, we can go for that. But without DNR consent or anything, we cannot remove the ventilator. So what we try to do is, we try to explain the patients these conditions. So if it is a brain dead patient, we try for any organ donation. Until now, we are not succeeded with organ donation, only some corneal transplantations has been given from our hospital side. But conclusively, we cannot take it. Only thing is, what they are doing is, it's not what we are doing, it's what patients are doing is, they say, we are taking to another hospital. Okay, we'll please remove it, we'll take to another hospital. In that scenario also, they will go to the ambulance. On the way, they will go take to the house. That's what they are doing, but we are not trying to encourage them. So
It's well said from a very experienced say critical care specialist. It is a very gray area, but you have rightly put it in a very crisp manner that what is happening in a practicality, sir. And I think it is a topic for discussion on it. So for want of time, we will take another 4 minutes, 1 minute to each, asking one question that Dr. Pranay, if one thing you wanted to change, which will help in your clinical governance, what is one minute, one thing?
Advice to small and medium hospitals is what I would recommend to have processes in place because for especially it becomes a challenge for a small and a medium hospital to have round the clock doctors. So it might be an experienced doctor, somebody might get replaced by a physician or somebody. So if we have processes in place, for example, like an MI management or a DK management services. So treatment aspect will you won't be doing wrong or harm for the patient.
Sure.
So in that way, it would protect the hospital is what I would advise.
So there's a very important one process in place so that the doctors may come and go the process in place. To Dr. Sikandar, one thing if you wanted to ask the government, what would you ask for clinical governance?
Actually, most deficiency is human resources.
Okay,
so definitely we will be asking.
Okay, so human resources is the one thing for implementing clinical governance. Dr. Vandana, one thing, if at all you wanted to put in a system that will change your clinical governance, one thing, 1 minute.
Yeah, I would want that all these different high-risk conditions must have protocols. Must be absolutely in place and everybody can adhere to that, even in a small scale hospital. And they should have for early referral, the proper documentation, what they've already given first time, so that the next care person can take care for.
Dr. Sir, you think one thing which should do for improving your clinical governance?
Patient continuous follow-up for the patients.
So some system for continuous follow-up of the patient. So I think two of our panelists say that it is a system or process in place. One from government resources. Resources is the most important, and this is patient follow-up. Thank you very much for this wonderful discussion, and thank you very much for adhering to that time. And we have actually equalized what Babu Bari has eaten away. But anyhow, I think we will get a special prize for our session, madam. I think so. That have a special prize, right? Sure. Thank you. Thank you very much.
Thank you so much, sir. Now I request Dr. Babu sir and Secretary Dr. Sikandar sir. Sir, now I request Dean Kankalakshmi Dean ma'am to felicitate Dr. Kalyan sir. Thank you so much, ma'am. Now I request Dr. Chakravarti sir to please felicitate Dr. Mandana ma'am. Thank you so much, sir. Now I request Dr. Kankalakshmi ma'am to please felicitate Dr. Babu sir and Dr. Chakravarti sir to please felicitate Dr. Babu. Yes. Both. Right. Please carry in time. I request for group photo, please. For this panel. Pose for panel. It's a beautiful panel discussion, sir. Yes. Thank you so much.
Next, we have nursing is the heart of the healthcare. Our next session, nurturing nursing care for superior clinical outcomes. Professor D. Kanakala Mahalakshmi Garu is the Dean of Asram College of Nursing and a senior academic leader with over 30 years of experience in nursing education, research, and healthcare administration. She holds advanced qualification including PhD, BMS, MBA Hospital Administration, and postdoctorate fellowship in nursing.
Invite. No need for introduction, I think. Yeah. He's the principal of College of Nursing with an illustrious 36-year career path by clinical and academic excellence in India and abroad. We welcome you.
Next, we are privileged to have Ms. Sheila, Nursing Superintendent, Nursing member here for 30 years of rich nursing experience.
Because we want to welcome Ms. Superintendent and American Oncology Institute, Vijayawada, as an active panel member. Welcome you, ma'am.
We are proud to introduce Ms. Geeta Reddy, our Chief Nursing Officer, Group Quality Head, and NHS Assessor at Dr. Muthu Hospital, as an esteemed panel member.
We welcome you, ma'am. Now I request, we are delighted to welcome Ms. Narmada Kannapanai, Omega Hospital, Guntur, as an esteemed panel member. We welcome you, ma'am. I request Chair and Co-Chair to start the session. Yes, ma'am.
I think good afternoon and good evening. Yeah, thank you. So welcome you all again for the next session. I think it's the backbone of the any mini hospital or corporate hospital or the nursing fraternity. So it's a very, very important the session. Now we are dealing. So let's welcome. So good afternoon to esteemed invitees, guests, delegates, and panelists, and also the participants. A warm welcome to all of you for this wonderful session for the today conference. So in this Caho Excellence Healthcare Program and one day small conference for medium and small hospitals, the topic given to the nursing fraternity, that is nurturing nursing care for superior clinical outcomes. So this is very enlightening topic and which reflects the focus on transforming healthcare settings by prioritizing the structured leadership, competency development, evidence-based practices, and compassionate engagement. With all this, we can achieve the superior clinical outcomes. With this, we can drive in the satisfactory patient outcome as well as we can increase, that prevention of complications can be increased. So, let me introduce our important panelists here. So, eminent panelist, Madam Geeta Madam here with us, and also Sheila Madam with us, and Matakni Madam with us, and Anada Madam with us. They are the eminent speakers for today's session. They beautifully, they have, they enlightened with us with expected outcomes. I think Geeta Madam will deal with the integrating nursing leadership and quality system for measurable clinical outcomes. And Narmada ma'am deal with the compassionate nursing care in its impact on patient experience and recovery. And Sheila ma'am will deal with the strengthening nursing systems in small and medium hospitals for superior outcomes. And Matakni madam will deal with the specialized oncology nursing practices for improving patient safety and clinical outcomes. Thank you, madam. Thank you for your valuable presence here. Thank you one and all for this opportunity.
Well, anyway, I'll talking about nursing. I think most of the nurses are seated here. You know, what captured my interest is the topic nurturing nursing care. You know, the word nurturing is generally is associated with humans. You know, you nurture a child. It's associated with, you know, saplings or trees. Nurture the sapling or the tree like that, or to, you know, life possessing animals, etc. So this nurturing nursing care, you know, and the, you know, improved outcome, clinical outcomes, you know. So when I thought about this, yeah, it is very, very apt, very appropriate term which is applied to this. I think I'd like to congratulate the organizers choosing an apt title, you know, because nurturing nursing care. Nursing care to whom do we give? Nursing care to whom do we give? The humans. We don't give to the machines or the objects, inanimate or lifeless objects. So when you attend to a person giving, you know, nursing care, you need to keep in mind you're not dealing with a machine or object. So you need to be, you know, we always say provide a tender, loving care, TLC. Provide a compassionate care, because these are irreplaceable. You know, what is grossly missing in the present day nursing is, you know, we treat the fellow humans who are sick, the ill, you know, like machines. That should be the case. All the nurses, budding nurses who are seated here, please take care of this. You need to deal them as if they're like your own. Technology may support healing. Yes, I do agree. We need to welcome technology, but it should be the, you know, overall superior thing when compared with, you know, human touch. Eventually, I'd like to say it is the nurse's compassion or the tender loving care, their presence, and their human connection that truly transforms the outcome. That's why it's aptly said, nurturing nursing care. Let us nurture this nursing care and let us improve the clinical outcome. I know for sure our esteemed panelists, they also will enlighten us, you know, with their wealth of experience in this nursing field so that we all will be benefited. Thank you all.
Geeta ma'am, to please take over the session.
Good evening, all. Good evening. Thank you for this opportunity. I thank Ashram team and Mr. sir for this opportunity here, being here. And I thank Dr. Babu and Dr. Bala sir for giving this opportunity here in the Caho. Integrating nursing leadership, quality system for measurable clinical outcome. First of all, why the nursing leader is important here? For this related to the excellence, clinical excellence in nursing. So in nurses leaders, they influence, they balance, and they support, because the healthcare faces the workforce shortage, economic pressure, and complex patients' needs here. There are studies also proven that here, the unit level improvement comes with a good leader. Is leader alone is enough to bring changes in the organization? I think nursing staffs and students are here. Is nursing leader, good nursing leader, nursing superintendent or chief nursing officer is enough to bring changes? So it's a teamwork. But the change, the good leader only can bring changes among the nurses.
Same, another thing, important thing is transformational leadership. So by which then we can reduce the lot of error and we can improve the system. And truly the true leader can bring changes in the, behavior changes among the nurses and by the empowering individuals. So the good leader should have few attributes. Here there are some attributes, that is top attributes and essential attributes. The good leader should have these are the essential attributes to have it. Then only they can bring changes. Yes or not? Yes or no? So there are, the leader should have effective communication between their subordinate and above their level, management level. So they are the licensed persons to, disseminating the things among the subordinate and escalating the need to their management. So they should have the good effective communication. They should have a good clinical competence. Then only they understand very well about their patient's need and the nurse's need. Then they can give something to them. Then approachability. You just tell me that which leader you like, those who are very strict or diplomatic leader. Approachable. How many of you went to your nursing superintendent office or dean office? How you will feel? Why no answer? Everybody want tea break. Anybody can tell your answer. When you are going to HOD room, how you will feel? You expect that respectfully communicate. You should be able to verbalize your thoughts to them. You want some answer, feedback, closure for that. Correct? So the true leader should have those such quality. Then only really we can bring changes. Then we can, whatever we tell, then they also will follow it. So they have to be a role model to their subordinates. The essential skills, moral character, ethical decision making, and leading change and service improvement. So the true leader should have these core competencies to transform care delivery. The nurses are the largest in the healthcare, correct? In any hospital, who will be the largest number? The nurses. So the organization decided that quality is the goal. The nurse leader is the engine. Without engine, will the motor, anything will function? Yes. So for this, integrating nurse leader truly on infection control prevention practices at the bedside, what it does mean? They don't need to be always at the bedside, but the frequency of rounds and the visibility is more important. So there should be infection control is more important in any healthcare organization. So implementing standardized national, international guidelines, the care bundles, it is more important. Only preparing written policy manual is there. PACA manual is there. Infection control can be prevented. With the manual, can we prevent the infection control in the organization? So we have to practice. For that, the leader should take down these matters, their downlines, and they have to bring the changes. Only the classroom teaching is that enough. So there should be a demo wherever required. The demonstrative skill-based training should be there. One time the skills training is enough. So there should be a multiple time of skill training and reinforcement. And in addition, the bedside training is more important. So daily hurdles on the infection prevention practices. That's all, everything over. Is that enough? We have to do the audit to know the trend, where is the gap, individualized audit analysis, and as a whole unit-wise audit analysis to know the gap and prepare action plan and to bring the changes in the system in related to infection prevention control. There are studies truly proved that 30 to 40% of infections prevention has happened by the nurse-led surveillance. Correct? So infection control improves when nurse manager or leader owns their data. So infection control improves not when policies are written, but when the nurses, leaders are visible at the bedside. Second most important is medication safety. So creating a just culture. Here, every organization, there is a medication auditor like a clinical pharmacist, pharmacologist there. Correct? So I hope the nursing superintendent is not punishing for reporting any error, right, ma'am? Yeah. So you get near misses, more near misses. So here the nurses are the final point of contact before administering medications to the patient. If once we administer the medication wrongly to the patient, can we take it back? That's all. So there will be definitely some ADR or side effect something. So from the prescription, then intenting, dispensing, receiving and administering. So there are steps where every point of time we can prevent an error, but the nurses are the last one who can really prevent it before reaching the patient, right? So there should be a system. That's why there are double check. High risk medications to be verified, double check, double verification. Double verification means what? 1-2% seeing that okay, you can go ahead. Is that right? So the right person, they have to physically first person verify, read out, and before administering again second person, the nurse, they have to see with the check with the drug chart. Then they have to administer. Then in front of the patient, they have to sign it. Can they sign it later? Then if it is not signed to signature, then the second shift, next shift nurse will come and see that there is a gap. So it is not administered. Then again they will administer. There will be double administration. So in order to avoid those things, whatever you are written in the manual, it has to be implemented, practiced truly. Then there is no meaning of good manual in your units. So corporate hospital, there are hospitals proven that improvised technology, integration and barcode system related to medication safety. So when reporting is non-punitive, near miss reporting increases and harm decreases. Correct? So we have to create the just culture. The nursing sensitive indicators are, there are indicators nurses related because every organization in NABH accredited, you have the KPIs. So here the nurses related fall prevention, pressure injuries and infection state and patient satisfaction. There are few KPIs I mentioned here. These are all captured in numbers, correct? So the number can be filled at the desk level. Can we fill these KPIs at the desk level? It has to be captured real time. Data has to be captured and the trend should be monitored. This KPIs, once it's captured by the in charge, it will be submitted to the nursing superintendent or CNO. It will go to the quality department. Only 3 persons will involved in KPI capturing, right? Right? Is that enough? So the every stakeholder at the unit, emergency department, ICU, operation theatre, every nurses or whoever the stakeholder should know that what are the KPIs are monitored in your unit, how it is captured. Because many times when they go for assessment, when they ask initial assessment time, how it is filled, it is mentioned time 1, time 2 like that. So it is not like that just filling it retrospectively. It has to be captured real time. And it has to, every stakeholder, user end should know their KPI level and it is more important. So when what get measured gets improved, what nurses measured gets sustained. And KPI driven linked outcomes. So as like last slide, the KPI truly, if it is monitored, definitely it is reaches the stakeholder, definitely we can see the changes. Building a culture safety, it is truly by the nurse leader, transformational leader, create the psychological safety. Leadership only they can reduce the burnout by giving nurse voices and visibility. There are every organization, they have the challenges listed out here. There are solutions as well. So just look into the integrating of technology and other alternative method to reduce the error and improving the nursing clinical excellence. So empower the nurse manager leader with the data access, invest in leadership training and align nursing KPI with patient care outcomes. So when nurse leader lead with data, compassion and accountability, measurable clinical excellence follows automatically. Thank you. Thank you, ma'am, for your insightful session. Thank you, Geeta, ma'am. Thank you, madam, for your enlightening words, which covers the entire information related to how the leaders can be integrated into infection prevention and medication safety and nursing sensitivity quality indicators
into a unified quality framework. Thank you for the information. So now I would like to invite Sheila ma'am. Sheila madam is nursing superintendent of Asram. She is very dynamic. Ma'am, this is my question to you because you are dealing with the topic on strengthening nursing systems in small and medium hospitals. So, in this context, would you like to enlighten us with what practical and cost-effective strategies can strengthen workforce competency to achieve superior clinical outcomes?
Thank you for the organization. The thing is regarding to our small and medium hospital, how to strengthen the nursing department in the cost and cost effectiveness. We can include our in-house skills training and regular stimulation skills trials we can do. Along with that, we can go for regular bedside audits, clinical checklist, and the standard protocols. We can go with it, reduce the patient care, and we can avoid the variation in the patient. So instead of going with external trainers, we can introduce our mentorship program in the in-house program. So we can cost effectively, we can improve our nursing care in the small and medium. Thank you.
As Dr. Babu had said, instead of going for the decorative things, let's learn to develop what is available in-house. That's very, very important because we all would like to go in for expensive external stuff. Well, once in a while it's fine, but because of the size of the unit, because of the earnings what we get, I think we need to be, extremely cost effective in preparing ourselves. You can have the in-house skills well developed, and then as Madam had suggested, simulation drills, competency checklists. I think well said, Madam. This goes a long way for especially small and medium hospitals to develop.
Madam Matakini. So you are specialized in oncological nursing practices. So currently you are working with the Oncology Institute. So I would like to express my query regarding what key oncology nursing safety practices are essential to ensure safe chemotherapy administration and improved patient outcomes.
Good evening, everyone. Thank you for the opportunity given by the organizing committee. Thank you, ma'am. The questions you are raised towards the chemotherapy patients. So when we think about the cancer patients, everyone know the treatment modality is the chemotherapy. So recently we underwent NABH affiliation process. So our assessor asked one of the nurse, what is harm? She answered beautifully, harm when it is administered wrongly, that will bring harm to the patient, which means higher medications when it is administered wrongly, the patient will end up with a harm. So she was with the answer, she was so happy, and then she picked up the next nurse and she asked the next question, what are the higher medications? So usually when normally they will answer very beautifully, but the assessor asked, this is the examination point, they got little fear and she was put it in. So my nurse educator taken up the assessor and wait and she was doing the action slide. What is that? What is that? Pinch, yeah. So we taught that a pinch stands, it stands for the pinch. The medication comes under the high-grade medications, the anti-security. The pinch potassium insulin narcotic chemotherapy and the heparin. So the chemotherapy is the high-grade medications. So now the any high-grade medication, just ma'am was explaining about the high-grade medications, how it has to be handled. So it is coming to the chemotherapy. So normally when we go to the patients before administering the medications, the vital checking is very important. And during the infusions, we got to monitor for any reactions, and the post monitoring also has to be done. So also once the chemotherapy is completed and we are sending the patients very safely. So do you think that with that the administration part is completed? No. So beyond that, usually the chemotherapy is being given like a weekly, bi-weekly, or in a month's once time. So those are not from the oncology background. There's only the chemotherapy, the medications are which being given. So once the patient is diagnosed to have a cancer, so on the panel of doctors from the radiation oncology, medical oncology, as well as surgical oncology, they will decide what kind of treatment has to be gone first. So if they selected to give a chemotherapy, it's a chemotherapy, it's not just like one time it's given and it's being cured. So it is like a regimen type, either the single medications or the combined medications will be given in a between cycle mode. Like a weekly basis, every weekly the patient has to come, probably for 6 times, 7 times, or 8 times. So every week the patient has to come back again to get the medications. So whenever the patients are receive the first time and going back to the home, and the nurses should wait for to find out the toxicity, because when the medication is administered, there is a toxicity also will follow. It's commonly like nausea, vomiting, and the call will be made to find out how far the patients are feeling. And the same way, the reminder call also will be given just before the day of getting the chemos, in order to not to fall, discontinue the medications. Otherwise, the proper continuity of care supposed to be happen to the patients. So the call will be made to the patients and reminding that you have to come for the chemo medications of the next day. So in such a way, the safety, the chemotherapy safety precautions in the infusions as well as the post-chemotherapy infusions also is taking place for the better outcome of the patient. Thank you.
Thank you for your explanation. As she said, the process should be in place. If the process, when it is in place and when it is displayed, it should be viewed properly, and when adhered to, I think most of the risks which are associated with the administration of whether it is chemotherapeutic drugs, whether it is other drug, anything, process should be in place, it should be displayed, all the SOP should be in place, and when read through, when adhered to, and then when implemented correctly, then automatically most of the risks will be reduced, thus promoting safety. So this will go a long way for all the nurses to learn about this. Thank you, Madam, for your explanation.
Madam Narmada ma'am, you are so passionate about the passion of nursing care. So in this context, I would like to ask you one question, that is, how can compassionate patient-centered communication be embedded into daily nursing practices to enhance recovery outcomes?
Thank you, ma'am, and thank you for the opportunity to be here and a part of this Jeevan Asram. And compassionate and the communication is a key role of nursing. It's a daily practices. It's not an option. Every day we have to deal with the patient and explain them and listen their concerns. Whatever the procedure we do, explain them in and understand their own language, not only them, to their family members also. And whenever they raise the question with we need to answer them in a polite way, in an easy way to understand. In not a few times when we are having more work, sometimes we may raise our voice also. But in such situation, we have to make ourselves move and answer the patient. And one more thing, that to improve daily rounds and inform the patients also as the family members, and we can teach back policy. Like if suppose the patient is discharged, how to take the medication, whatever we explain the 5 points, where the patient repeats the 5 points or not, we can check as a feedback policy. And we should reduce their anxious anxiety levels, and they can we should make them trust on us. And whatever we do, explain them in their own understandable language, and so that they can develop the trust and discharge in a stable condition. The hospital also gain the confidence, and they will trust us. Psychological support as well as recovering faster. Thank you.
Well, madam, thank you. Well, I'd like to just add a word or two on this. When a patient comes to us, if you have little time and explain to the patient about the procedure which is going to undergo. So to a large extent, that will solve majority of the anxiety or apprehension or the negative thoughts which he may be having. Unfortunately, in the present day times, because nobody has this extra time and unable to explain all these things, so the patient goes through a lot of problems. So good communication and then providing, as I've said in my opening remarks, tender loving care, that's very, very essential, absolutely important. If you can mix this up in a balanced manner, I think, the compassionate nursing care will have a greater positive impact in the healing of the whole, be it the body, be it the mind, and be it the soul of the patient. This will go a long way. Thank you.
So before closing the session, so I would like to say that one line: when leadership, compassion, system, safety covering, nursing care becomes transformative, let us continue to nurture nursing practice with commitment, accountability, empathy for better patient outcomes. Thank you one and all. Thank you for the opportunity and thank you all the delegates and participants. Thank you.
Thank you, ma'am. So I invite Nagaraj Bhattu sir to give a memo to Dr. Christopher sir. I invite Manoj sir. I invite Manoj sir to give a memo to Kanakam Lakshmi ma'am. I invite Dr. Christopher sir to give a memo to Dr. Mata Kani ma'am. I invite to give a memo to Dr. Geeta Vedu ma'am. Special gift to Monica ma'am.
Thank you so much for that. Now move to the next session, pharmacy session. For this, to chair this session, we greatly honored to have Professor Nagaraj Bhattu garu, former Dean School of Commerce and Business Management, Acharya Nagarjuna University, and Head of MBA Hospital Administration. As the chair for this session, we welcome you, sir.
Shri Manoj Kumar, we have Shri Manoj Kumar, Managing Director of PTOP Global Services, as a chair for the recent session, and the dynamic leader in the software and this
marketing services.
We welcome you, sir. We are honored to welcome Dr. Priyank, Senior Manager, Clinical Pharmacology, HCG Corporate and Healthcare Global Enterprise Limited, as an distinguished speaker, a seasoned clinical pharmacologist with extensive experience in drug development and clinical research. We welcome you, sir.
Priyank, sir. Dr. Priyank, sir.
To welcome Ms. Muki Anantapatnavan, sir, founder and CEO of Technologies Private Limited, as an distinguished speaker, a visionary leader with over 3 decades of experience in healthcare administration and hospital engineering. He has held key leadership roles in primary institutions, including Apollo and COVID Metro Hospitals. We welcome you, sir. We request Nagaraj sir, please.
Evening to another. Ladies and gentlemen, distinguished guests, esteemed colleagues in healthcare, very good evening. From morning onwards to at present, we are enlightened like anything, but thanks to Asram Chief Operating Officer Rajendra and the team, Caho team. So the day morning session to evening session went on well. We are very happy. Being learning individuals from the University of Acharya Nagarjuna University, along with the students and the faculty, senior faculty, we came here to involve in this program. Yes, the focus is healthcare excellence program for small and medium hospitals. Everybody focus on quality. Yes, quality is never an accident. It is always the result of intelligent effort. As per John Ruskin's. Great things in business are never done by one person. They are done by a team of people. The known Steve Jobs. If you want to go fast, go alone. If you want to go far, go together. And off you can go well. These three are perfect for medium scale business aiming for long term stability rather than short term gains. It is an honor to address you at the Caho Jeevan Conference 2026 hosted at Asram Hospitals in Nelu, a beacon of dedication to quality care in our Godavari region. Today, as we gather on the cusp of transformative change, district level trauma center, NIMHANS 2.0 for mental health and exemptions on 17 cancer drugs plus 7 race diseases, directly easing burdens on small hospitals by improving affordability, supply chains, and skilled manpower. For small and medium hospitals, these translate to opportunities in integrated care models. Digital health via Ayushman Bharat and NABH Allied Excellence that are Caho champions. And enhance, 2.0 new union budget 2027 means on par with our South Indian the Bangalore enhanced model. The same model, the replica in the states of Ranchi and the Tezpur places for the North India. The another important focus point is the strategic strengthening of systems. This is also focused in Union Budget 2026. Push for 50% capacity increase in district hospitals, emergency blocks, Decognizes tertiary care, allowing small hospitals to specialize in preventive diagnostics, daycare, oncology, and rehabilitation. Another important aspect is technology integration. Yes, AI-driven diagnostics, faster CDSCO means Central Drugs Standards Control Organization, approves for 1,000 clinical trial cities and 40,000 crore for electronic manufacturing, will enable small facilities to adopt affordable medtech from telemedicine to precision screening, reducing costs by 20 to 30% and enhancing outcomes. The another point, which is the last point on relating to the governance. Excellence councils is the invisible architecture of trust for small and medium hospitals. It means robust compliance, ethical decision making, and NABH standards that Caho promotes through workshops and convergence events. Especially Budget 2026 strengthens regulatory credibility via CSU enhancements and WHO aligned traditional medicine centers, ensuring predictable pathways for innovation. Key pillars including the data-driven oversight via Ayushman Bharat Digital Mission. In small hospitals, leaders must align vision with execution. Communication boldly, like aligning goals with Vikasit Bharat, lead change through digital transformation and build inclusive cultures. Concluding with these observations, I take this privilege to all a call for a collaborative action. Fellow stakeholders, policymakers, owners, doctors, administrators, let us build, implement budget 2026 at grassroots. Pursue Caho accreditations, invest in leadership skilling and innovative relentless. Small and medium hospitals will lead India healthcare renaissance, delivering accessible, quality care for all. Together we build Jeevan life safeguard. Thank you, JB. Thank you all. With these few observations, I would like to invite co-chairperson and the resource persons to deliver their valuable inputs. First, I invite co-chairperson a few words.
At first, I thank the team Caho and Asram management and the leadership of Asram for giving this opportunity. So since morning, we have various presentations and the panel discussions. Now, it is more about the digitalization of the organization, the various departments into bringing into one line, use of IT and artificial intelligence in healthcare. So we are very much glad to have very much expert here, Anand Padmanabhan sir and Dr. Priyank here. So they will be discussing about the presentation. So in this, in the post lunch session, we heard about the Bahubali, describing various roles of the Bahubali movie and relating them with the organization. But actually, the invisible, the leader in the organization is the IT that is being integrated. So it plays the major role invisibly, connecting various departments and bring better efficiency in the organizations. It saves a lot of money, it cuts the costs, it enhances the efficiency, it saves a lot of time, it brings the better performance by the organization, by the team and the people. Now it's over to Anand Padmanabhan sir. The order. Thank you.
I request Priyank sir to take over the session.
Very good evening, everyone. First of all, thank you so much, the Asram team,
so much, Asram, for inviting me here. It's indeed an honor to stand on this dais with stalwarts of the industry. Thank you, Caho, for bringing this important session, pinning this important session together at the presentation. Right. So while we move forward, while the presentation is put on, first of all, thank you so much for staying around. I think we were scheduled at 4:30, but everyone around being really patient, made your time to stay back. Thank you so much. This means a lot. I'll try to keep it as simple and as short as possible. What essentially I'm talking about is how a pharmacy, a hospital pharmacy. Now we talk about pharmacy, we speak of varied domain of contribution from of the services. We look at the inventory, which is a hospital pharmacy, catering to the inventory as well as catering to the patients in terms of drug dispensing, etc. And we also are looking at some point of time about the clinical aspect, appropriateness of therapies, etc. Where the clinical pharmacy and clinical pharmacology comes. Essentially, what's happening now, Joe, in the next 15 minutes, we are looking at the contribution of pharmacy, especially hospital pharmacy, in strengthening the patient safety in small and medium hospitals. A lot of time, in fact, majority of the times, what we usually hear, pharmacy, is your last impression is your best impression, and is an everlasting impression, is what we say. And usually, what is your last touch point in the hospital? The last touch point in the hospital is your pharmacy, right? If you are an outpatient, but I'm saying you, like myself as well, all of us, at some point of time. Right? So it's not just about our patients, I believe. It's also about us, right? Whatever we do today, whatever systems we put in place, whatever protocols we put in place, whatever SOPs we write for our hospitals, for our healthcare ecosystem, at some point of time, we are also recipient of it. Right? So whatever we do today, we essentially, I strongly feel essentially need to be a little, considerate on our own self, right? Because someday it will be I myself lying on that bed somewhere in some hospital, expecting to be cared, right? To be cared by my physician, to write the right drug for me. I'll be, relying on my laboratory to diagnose my ailment appropriately, or to my radiologist to scan me appropriately. I'll be relying on my nurse to make sure that I'm taken care, my drugs are administered to me appropriately. To every single healthcare professional who is part of the journey, that they contribute or they do their job optimally, right? And being part of the ecosystem, I strongly feel it is important that I build a good ecosystem, right? And it is not for others, as I said, it is for our own self. Whatever I say here represent my views. In no means it represents, my parent institution's views. So when we talk about numbers, since we have a mixed crowd, I tried keeping it as generic as possible, not going into a lot of poor pharmacy or hospital pharmacy inventory aspects of it. Well, when we look at the numbers, I mean, a lot of time, a lot of focus is on numbers, right? Is on revenues. Typically, when being a hospital administrator, a lot of us here are future hospital administrators. A good contribution, about 25 to 40% contribution in your hospital revenue or our hospital revenue comes from your pharmacy services. Right? A very high capital block that happens, right? Rising compliance pressures. When I say rising compliance pressure, as good as employing a good physician, it is equally important to obtain or to have equally competent
pharmacist and premises which is licensed appropriately for the need. And when we talk about licensing process, it varies. It varies from the kind of drugs that are to be used by the respective hospital. If you are a hospital who would be using opioids, you have to obtain a schedule X. You have to gain NOC or licensing from various other statutory bodies. You have to understand the drug rules completely, the reporting is as per drug rules completely, and so on. Right? And this is not just when I say so. There's one thing that we all usually look at. When we say pharmacy, we essentially look at our hospital pharmacies and hospital pharmacy stores, whether it is an outpatient pharmacy or inpatient pharmacy or operation theater pharmacy. There is one part of drug storage that is often less discussed. I'm not saying not discussed, but less discussed. Are the small nuclear pharmacies which are out of the eyes of licensing bodies are on ward stocks. Right? These essentially are small nuclear pharmacies established in every single ward. ICUs is a larger portion of it. Your high risk area, your transplant unit may have a very high portion of it. Right? It's very, very important that whenever we are looking at any aspect, whenever we are looking at any aspect, right? The last point, expiry and your dead stock. Every single location of the hospital takes a consent of it. Right? It's not just your pharmacy store, any of your regulated pharmacy storage locations, but also your unregulated pharmacy storage locations. Where it is equally important that our teams understand it and keep a note of it, ensure that we manage and maintain it. Right. Three primary challenges, I believe, in my understanding, that as an hospital administrator that we come across. Cash flow stress, definitely. If you are operating, say for example, an oncology institute, maybe a smaller medium hospital. In terms of pharmacy cost of drugs now are exponentially high. Right, the kind of treatment modalities those are available and which are breakthrough treatments. Like we're talking about immunotherapies, we're talking of targeted therapies, targeted treatments. And each drug, each vial, at times cost you about 3.5 to 4 lakhs each vial. Right, and this is one drug. This is one single vial of a drug. Right. So these are the kind of costs that you're looking at, and this requires special storage. This requires special handling. This requires, when you're transporting, this requires that specialized transport process. So everything is linked here, right? So it's very, very important that whenever we are planning our pharmacy services or planning our scope of services rather, right? We keep all these aspects into consideration. I'm sure that's something which, as an administrator, do trouble us. In terms of care providers, essentially, in care providers, the first thought was to put physicians out there. But then when you look at today's scenario, right, it's not just a physician who decides the optimal treatment for the patient. It's a team who decides an optimal treatment for the patient. Right? Physician is the one who decides the eventuality of it. But you have a pathologist who is helping you deciding what is the right diagnosis for your patient. You have a radiologist who is helping you deciding what is the right kind of diagnosis for your patient. You have a nurse who is helping you in delivering the treatment the way you want it to be. Right? So it's the team. And of course, the manual tracking. Everything happens, everything goes around, and still a lot of time we are in an era where we are looking at technology. We are looking at digitizing things, we are looking at optimizing our workflows, we are looking at optimizing our ecosystem. So at the end of the day, I mean, what matters? To me, everything else is fine, but what matters the most is the first point. Any stress in the system of any kind affects the patient safety. At some point, right? If I don't have enough funds to, to churn my pharmacy inventory, at some point of time, I may be facing stockouts. If I'm missing stock out of an emergency medicine, my patient safety is at stake, right? Most of us, in fact, all of us are into healthcare. We understand the the essence of time, the importance of time. I'm sure those who are from the cardiac centers, the 60-minute rule, the first 60-minute importance, the first 60 minutes for somebody who is suffering with a stroke, right? We all understand that. Right? So situations like that, which might not be tangible to the situation, but indirectly are responsible for that. Right? Well, why does this matter? With the interest of time, medication errors and any such event happening because of it, we all understand contributes to the largest amount of hospital admission. Those are happening, recorded, unrecorded, both. Mostly unrecorded in this part of the world. What is troubling us? The most troublesome thing are the stockouts of critical drugs or emergency drugs for that sake. Right? The use of near expiry drugs, the problem of the lookalike and sound-alike drug, cold chains, right? And narcotics. I think about the cold chain when we say, I'll just give a small example of the biologics. So what do we do? What do we do? Very basic things. I think even we are the smallest possible hospital, very basic inventory control exercises helps a lot in managing and ensuring that the entire inventory appropriately managed. And we speak and we talk about, we know about the ABC analysis, we know about the vital essential desirable analysis. We all understand that it is important that we, we shell our expiry, the drugs which are nearing expiry, or in a sense, when we call it, say the first expiry going out first, or the first expiry first out, right? Very, very basic things which make big changes. It's all about, paying your utmost attention to it and ensuring that we do a proper mix and match of it. It's not just the ABC analysis alone that helps managing your inventory. It's not your VD analysis alone which helps you manage your inventory. It's not just your FSN analysis alone that helps maintain your inventory. It's important that we understand all three together and implement and practice. That's what helps in managing appropriate inventory at any part of the hospital, not just the pharmacy, right? I'll skip this. Okay, so there were a few examples I thought, in interest of time. So this essentially talks about how the various types of incidents in a hospital can affect patient safety, right from as simple as a stock out to an expiring drug, etc., etc. Okay. So this is something. This is what I was talking a couple of minutes back. It's important that we look at our inventory analysis appropriately, and it's whenever we are in a managed care settings like that of oncology, it's very important that we pay special attention to our special drugs. Right. So day-wise batching, centralized pharmacy operations, protocol-based forecasting. While we are trying to being a small setup, say for example, if I am a daycare oncology setup or a setup of that kind, right? It's important that every member of the care team, right? Whether is a pharmacist, a physician, your nurse specialist, your staff nurse, your attending nurse, physiotherapist, everybody, right? The entire team understand the protocol and forecast operation movement based on the protocol. That will not only help in in ensuring that your patient experience is good, but that will also help you manage your inventory better, manage your funds better. Right? Any which compliances and risks are always part of it. Let's do this. Okay. So we'll just finish with 5 points that I felt are important. For me, in the nutshell, if you have an efficient pharmacy, you have a healthy hospital. Right? What's important is discipline in inventory. What's important is to lower the financial stress, which is directly linked to your inventory. What's important is your data-driven pharmacy. So adoption of technology to ensure that we understand the data better, we generate a good data. It's It's the key, to run a good hospital or a good pharmacy. And of course, strong governance and strong, safety improvements, which with this, thank you so much. Thanks a lot for your attention. Thank you so much.
Thank you, sir. Thank you so much for having me on here. For the next session, the IGA effect. Small investments can create massive impact. The IGA effect, small investment, big impact. For this session, I invite Mr. UK Ananthapadmanabhan sir. Please.
Yeah, good evening. I want to thank Rajarajan really for participating here all the way from Coimbatore. Don't believe I have not also decided. And I've been attending a lot of these meetings, our meetings, NABH meetings and all that. Maybe Rajarajan should give a hearing for what I'm saying now. Okay. So I told you I have come all the way from Bangalore and Balamurugan gave a very nice talk. It was very brief, very nice. Balamurugan is my junior, but did a great job today. Then, but after that he saw me very sad. Balamurugan saw me very sad. But in the afternoon, he saw me very sad and he came and said, "Sir, why are you very sad?" I said, "I'm not sad." No, so you appear to be sad. I told him, finally I had to reveal why I was sad. He said, Balamurugan, my name is Ananthapadmanabhan. My name is Ananthapadmanabhan. And all my schooling, college, profession, every time, the attendance, mine is the first name. In college, in every meeting, it is the first name. But unfortunately, after so many years, Rajarajan, managed to put me as the last speaker. Then, Balamurugan, what he did, he gave me a big hug. That Modi, he won't do like that, sir. He has a Modi jacket. But, why, he's connected to a very, very senior DMK politician and he's a very renowned politician. And, he knows why he has put you in the last. When Karnataka and all come to speak in some of the political meetings, they will allow all the speakers to speak. Finally, only Karnataka will be made to speak. Because, they wanted some crowd to stay back. Otherwise, the crowd will become empty. So maybe, Rajarajan should have thought that, I am the last Karnataka to keep some crowd around that. So he will be at the last. But I will, believe me, it is worth the time. Please understand, I'm going to talk for another 10-15 minutes and you will find it very useful. And what I'm going to talk today is about the frugal engineering technologies that we use in the hospital, digital technologies. All said and done, I have been working in the hospitals for almost 30-35 years as in the operations. And I believe that these technologies, previously they were enablers, then they became drivers, and now they have become weapons. Please understand, technology has been weaponized in most of the countries. Even today, right now, the war has started. Iran-US war has started, bombarding is going on, and it's all through AI and there's a. So I will say that, these are all the technologies. So I believe that technology is a great enabler, great driver, and it is a weapon. If you don't have a weapon, you will lose the war. So, all talking is fine, but on the ground, what are you going to do? And in fact, I keep talking, I'm a faculty in many of the institutes, and I talk to the nurses, I talk to the hospital administrators, I try to teach them technology on the ground. Okay, so what I am going to do is I'm going to leave out HIS, I'm going to leave out EMR, I'm going to leave out medical equipment and all that, but I'm going to go into a very uncharted territory where the nurses should know, where technicians should know, where doctors should know. I'm going to talk about hyper-automation in hospitals. I'm going to talk about technologies like IoT. These are all the technology I'm going to talk about. I'm going to take some time, definitely 10 to 15 minutes time, but it is not spending that time. I'm going to give you case studies. I'm going to show you some pictures which will be of some interest to you. Okay. So these are all the technologies which use in the hospitals: IoT, 3D technology, artificial intelligence, AI agents, drone, genomics, quantum computing, machine learning, Internet of Things, nano technology, cloud computing, computer vision, low code, no code technology. I don't know how many of you use low code, no code technology. This is meant for people like us, process owners. You don't have to be an IT coding engineer. You can do it yourself, and that is the first level of artificial intelligence for coding. So then you have wireless technologies like Bluetooth, low energy, narrowband, IoT, mobile technology, biometrics, robotic process automation, robotics, humanoid robots, real-time location tracking. These are all the various technologies that are used. But I'm not going to talk about all technology. I've just chosen about 5 or 6 technologies, and I'm trying to give you some practical examples of that, what we have implemented, which will be very useful to people like you. So these are all the IT systems that we have in the hospital. We have hospital information system, customer relationship management, finance system, financial management system, human resource management system, supply chain management, quality management system, building management system. But one thing which don't have right now, nobody has, is the operations and maintenance management system. In fact, I have named it as, I brought together many of those IT softwares, and I call it the Digi Yantra. Like your Digi Yatra, I call it as Digi Yantra. Okay, so these are all, I'm not going to talk about all this, but I'm going to talk about operations and maintenance system which we have developed. This operations and maintenance system, which I call Digi Yantra, it uses a set of 15 customized modules. It has got 15 customized modules built on hyper automation platform. When you say hyper automation platform, we are talking about many technologies coming together. And then it's a single sign-on facility. You don't have to go for water management one. You don't have to go to energy management application, water management another application, asset management another application. Everything is one single sign-on. And then enable the organization to work faster, easier, better. And all the 4 are different. They're able to make the organization work faster, easier, better, and cheaper, and do with more with this. These are all the modules. The asset management module, electricity, water, DG, fuel, medical gas, waste management, room and refrigeration equipment, temperature humidity management is used for AMBH. And then ambulance and transport services, medical equipment tracking and charging, fire protection, safety management, passenger management, water management, queue management, park. These are all some of the modules. Another set of modules is that housekeeping and security services, nursing and student hostel management, even student hostel management, restaurant management. Small hospitals require small canteen facilities you can manage digitally. Ticketing system, feedback management system, services cost management system, compliance management. In fact, Balamurgan brought it out very nicely. What are all the compliances? We can install, even maintaining it in the Excel sheet, we should maintain it in the system. Not even in the Excel sheets, okay? So digital documentation library system and asset management system quickly, maybe you can give for asset management, we have preventive maintenance, breakdown maintenance, calibration, contamination, training, and we'll be able to do this kind of an asset management system using low code, no code. And you will see this is the kind of asset register where we put QR codes on each of the equipment. This way, in fact, there is a case study of a hospital in Madurai. And they have got a hospital in Critical, they have got a hospital in Madurai. The beauty of this is tier 2 cities hospitals use this. So all the 750 equipment, biomedical equipments have this QR code. We are able to know where they are working and when they were purchased, how they were purchased, all that. And we are also able to do the preventive maintenance and breakdown maintenance. It's on a mobile. You just have to return the equipment, put the details on the mobile. If you want to upload some equipment, upload some documents, you can upload it. You know what is the status and when it was completed, when it is pending for repair. This is IoT energy management system. And you see here, you have got generators here. You put IoT device on the generator, and then we put IoT devices on the chillers. And we put this kind of a device. This is an IoT device. This can connect to 4 energy meters. And we put this is a Salem hospital. One Salem small hospital is a hospital. We put the IoT device, and this device measures the energy readings like this. We are able to measure how much of units are consumed power, what's the maximum demand, what is the power factor. We are able to do all that here. We are able to, using the software, we are able to know how many units are consumed. If you want a technician, if you want a nurse, you want somebody to go and measure it, it is humanly impossible. So you can get all these analysis here, you get this item in the ST report. This is interesting, in most of the states we have slab charges, peak charges, lead time charges, regular time charges. This IoT device collects all the detail from opening reading, people like you can understand, sir, really. So this opening reading, closing reading, all this comes into this. And so we are able to do load balance. We are able to do critical loads on lead time, non-critical loads on the lead time and reduce the charges. So we are able to reduce maximum demand charges, we are able to reduce power factor penalties and all that we are able to do. And it is a very interesting analysis we are able to do. In a small hospital, in a large hospital, we are able to know what is the nighttime consumption, what is the daytime consumption, what is the holiday consumption, and we are able to fix benchmarks on that and monitor. If it exceeds, we can send a message or something like that. This is the nighttime electricity consumption. So we can fix thresholds and get the details. Then this is a very interesting report which we send to the top management. This is totally energy consumption, DG energy consumption, total energy consumption, maximum demand, minimum demand, power factor. Minimum power factor, DG sector, run hours. All this goes at 8 o'clock. It goes to the CEO or maybe even the maintenance manager and all that. This is a report that goes at 8 o'clock. Every day it goes, but for 1 week. So the first day it comes back again by rotation. This again very interesting. I am very particular that nurses should not do non-nursing work. So what I have done is I have identified a lot of these non-nursing work like managing ward boys, ward girls, doing water management, or transporting samples, all that phone calls, and maybe even taking temperature readings and all that. I have identified about 10 or 15 non-nursing jobs and tried what I can do. This is a very classical case like this. Here you find that on nurse, there are about 20 or 30 refrigerators in the hospital, or even operation theaters, they have to maintain all this. Your nursing supervisor has to come and see this, then you will use it to the NAP. I have removed all that. So what I have done is I have put IoT devices like this. This IoT device is put in the refrigerator, it is put in the operation theater and all that. It goes. Every 1 hour the reading is taken. So nurses don't have to do that. We have done it about 10 or 15 small hospitals. So this is a plan. You will see all the readings come like this. You are able to know what is the right temperature, humidity, all that we are able to see. This is the kind of you are able to see this temperature maximum in the industry. How much hospital in Madurai and Tanjavur, both hospitals we are able to do. So we are able to blood storage area, laboratory, dialysis, all that we are able to do. And we are also able to send threshold alerts. Suppose if the temperature goes below 22 or goes beyond 24, we are able to send alerts to the nursing director or maintenance manager or something like that. Nurses don't have developments, say that. And this water management, this is again very important, especially in cancer hospital and all, we have tanks. We have got delayed tanks where radioactive water goes into the sun and we have to keep it for 30 days to cool off and then only dispose. So we don't want to open the tank. So we want to know if drinking water is there or not. We have put this kind of IoT device and we get this kind of a display near the tank and once the level goes below 40%, there is a sound. So the plumber or anybody will know that it has become less. And if it is overflowing also, we'll be able to sell that. And we'll get in our dashboard, we get this kind of a report saying that this is the syntax tank is this level, cement tank is this level, sample is this level, all this is available in the real-time live remote. Real-time live remote, you are able to get that. And this is a portal management. Again, what we have done is we have put QR codes for all the porters that we transport using this. No more phone calls, and nothing happens like this. So we are able to know which porter was moved from one port, which place, at what time. We are able to optimize the use of the porters. And ticketing system, again, we have put QR codes for nurses, especially nurses should not call up anybody. So their QR codes are placed in the wards. They just scan, and then once they scan, your form opens and they can say whether water is not coming or food has not come, anything they can do this. And you will be able to get this kind of a report like. So you can even upload. You can even upload a picture of that. And so what happens is you don't have to phone up. Nobody says when you didn't call at 5 o'clock. They say no, you called only at 7 o'clock. All that this week. So we are able to manage all this, and we are able to get a report saying that how many biological equipment, how many maintenance, all that. Some other This ambulance is again very interesting. You know, you have 5 or 6 ambulance. You want it to retire. When did they go? When did they go? When did they come back? How much of fuel that was there used? How many trips they made? All that they are able to know. This you are able to know this month, last month, what have they achieved? How many trips they made? What are the fuel expenditure? Everything there is. And this is the dashboard also you get this kind of a dashboard. How many trips? How many liters were spent? Then what was the fuel expenditure? What was the repairs and maintenance? What expense? All that there. And we are also able to upload the invoices and all that and monitor the repair and expenditure of that. Last is we have the fire safety. It's again very interesting. We have put QR codes of 150 fire extinguishers and about 80 fire hydrants. You don't have to take a sheet and write down and an Excel sheet from all that. Once they do a QR code, is done in couple of hospitals. So they just get a report like this. And this is the kind of dashboard also we get. You get a dashboard. Suppose you have 4 ground centers, fast and bus, and then you know that. So this is a very interesting for plans or tax or and this is called the patient tax. If you have got ventilators, you want monitors, you want infusion pumps, syringe pump, put all this, and then you put it all this and they move from operation theater to ICU, and track where they are. You can charge the patient, not lose the same. And you can see in time, out time, and real time. You can see it anywhere from there. One good thing is all applications are in one sign on. One sign on. Nursing director will be able to see everything in one sign. So this is again interesting. Even if you have a small canteen, you can manage this canteen. Once the after that also you get this kind of a report saying that how many sales were made, how many purchases were made, all that. And finally, we get the entire dashboard, how much electricity, month wise, what was water, medical oxygen, diesel, petrol, LPG, cylinder gas, telephone, broadband, biomedical investment, all that we'll be able to see. And this is the final slide. How do you like this slide? How do you like this slide? Tell me where Arthapatra. That is the last slide. No, tell me what is the Arthapatra is 69. Tell me Arthapatra when he was 7. That is my Mary teacher. Mary teacher, if I am talking English, it is because of her. That is Mary teacher, and these are all my Raja, Gauri, all my friends are here. Still, I am in touch with some of them. So tell me where is Arthapatra? Can you tell me where is Arthapatra? Yeah, no. So tell me where is Arthapatra? Okay. I asked Peter. Then of course, thank you. I'm going to show you one more slide. That's a very interesting slide. I go to Chirkara University every year. I take classes for all the nurses and hospital administrators. It's only on digital and applications like this. I teach the low code, no code, and all that. And yeah, this is what I like this. This is a class which I am taking. 1 week. You know, today because I said you can't the boat. So I practice. So, but there they said you can do it. It's a mention. And more you can manage why you cannot manage. So in fact, this is the class I take last month, last 1 week. Just to tell you that you know, not 15 minutes. Why this is a fairly fun until 5 years ago. No, okay, Ramaraj Carton and other shirt. But that's my, you know, so many boys and girls to photograph selfie. Thank you very much.
Thank you so much, sir. So wonderful session. Now it's a felicitation time. I request all the Ashram family members to come onto the dais for felicitate the Mr. UK Ananda Padmanabhan sir. I request all for everybody. And I request all the chair and co-chair and Priyank sir also please join. Dr. Harish Gautam sir, please. Sheila madam, and all speakers also. Please. I think this to give the momentum to Dr. Priyanka. I request all to give a momentum to Nagaraj sir. Now I request give momentum to Sri Manoj Kumar Garu. Thank you so much. As we come to the close of this entrance stage, knowledge was shared, ideas were exchanged, commitments were renewed. Let us move to the valedictory session.
Yeah. Thank you all. And before closing the event, we have lucky draw. Who's going to do the order? Game sessions can be made. Yes, sir. Yes, sir. Please take order.
Let's see who's the lucky winner. And the winner is Aniket Kumar. The winner, lucky winner, Aniket Kumar. And the lucky person here. The winner is Asram Hospital. From District Department. And please come on stage. We have Nick here.
Continue का बोल रहा हूँ.
Lucky Nick winner. Nursing Department, Asram Hospitals. Second winner. We have the winner. Next, the luckiest person. Navyasri Ashram College. Navyasri.
Representative from Congress.
Next, we have another winner. Usha Ashram Hospital. Nursing Department. Right?
Yes. Before closing that, it's on behalf of Caho and Asram Hospital, particularly from Caho, we like to thank the Asram family and hospital and the event members for the wonderful hospitality and arrangements. There are a lot of people are behind the scene, and it's our privilege and it's our duty to thank the key members from Asram Hospital, starting with Mr. Prashant Garu from marketing. Thank you, sir, for your hospitality and arrangements. Ms. Sumanta from marketing, and Mr. Lakshmi Garu from marketing team, Mr. Hemant from quality. Here, where is he? Thank you, Hemant. Mr. Madhu Sudra Rao Garu, because he is the one who did all the flyers and all the background work. Thank you, sir, for your wonderful working behind the scenes. The Srinivas, Group CEO office, and this Alu Monica, she is the one. In the morning, she is doing the wonderful job. Please give a big hand to her. So, thank you for your support. And Mr. Kiran, come here, Kiran. So, give a big hand to Kiran also. Thank you for it. And Nayak, so we missed Nayak from HR. Thank you, Nayak. From yesterday, you are being with us, and thank you for the good darshan in the Chiri Tirupati. So, thank you all. And not least, is Balraj Shekhar, also part of the team. And thank you, everyone. And Hemant is I told it. Thanks to all the FNB, IT team, facility, so all the team members. So, madam, thank you for last meeting over here. And thank you, everyone. We'll meet next year, even maybe after 3-4 months. Thank you, everyone. Please give feedback about the event in the group or your team members. Thank you once again. Thank you.
For Acharya Nagar students, there is a bus in A and B module, in middle of A and B module. At 5:30, there is bus to Acharya Nagar. Vijay.